यूट्यूब ऑन है ना?
यूट्यूब लगा दिए।
लाइव करे है ना? तब का देखा था?
अरे तो यूट्यूब अब जा रहे हैं, चलो।
यूट्यूब पे जा तो बोलबा तब ना, हेलो 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 हेलो
हेलो हेलो
हेलो
हेलो।
हेलो हेलो।
हाँ ठीक है। हेलो हेलो हेलो। हाँ ठीक है।
ठीक। हेलो 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 हेलो।
रुकिए, हम माइक से बोले हैं। माइक माइक किया था भैया।
हेलो, हम
बोल रहे हैं।
हेलो चेक चेक, हेलो हेलो, माइक टेस्टिंग, चेक चेक, हेलो चेक, हेलो हेलो। यहीं देख लो।
भाई जाने तो बाहर देख लो।
हेलो चेक चेक, माइक टेस्टिंग, हेलो
सर आइए।
हेलो हेलो, चेक चेक। आवाज आ रही है? गुड मॉर्निंग, गुड मॉर्निंग, गुड मॉर्निंग।
हेलो 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 हेलो। ठीक।
बस कर दो, जब स्टार्ट होगा।
माइक दे माइक तो दो।
एक माइक है वहां पर, दो हैं।
अच्छा ठीक ठीक।
चलो, वो बच्चे तो लाए नहीं कर देते। नहीं सारी बात है, सेशन देने का। हाँ
Depleted audience, yeah. More the merrier. Please join in. So, we start today's program with a fun quiz. And it's not a very formal quiz. So, be prepared to answer. It's basically a medical quiz. It's related to medicine, tangentially related to medicine. So, just keep your thought processes awake and we'll do it. And at the end of every question, please raise your hand or shout out the answer. Whoever answers first, could I have a handheld mic? I think I'll prefer that. Whoever answers first gets the prize. And you can come up here. ठीक है, हाँ. Then you can switch this off. Yeah, I'll be better off. Yeah. So the whole rule behind it is shout, scream, raise your hand. Whoever answers first correct can come up here and pick up a prize. Certain gifts from Pondicherry, certain chocolates, whatever. It's you. Okay, shall we start? Okay. Best wishes. Let's start. Question number 1. Dhanvantari, the Hindu god of healing, has is also in the Puranas as the god of Ayurveda. He has both things in his hand. Trunk, chakra, trunk, chakra, amrit. What is there in this hand? What is there in this hand? Medically linked. Loud, loud, loud. Not a pen? Thermometer, no. Bone marrow aspiration needle. It's a living being. Anyone? Leech. It's a leech. Okay, Avinash. That's match fixing, but whatever, doesn't matter. Leech. That's the whole concept of hirudo or leech therapy. The leech was there in the hand of Dhanvantari. Okay. Next question. What's this? Microtome, no. The first ever something. Okay, fine. I think I don't. Oh, the answer came for me. Target light cell gate. ठीक है, एक चॉकलेट ले लीजिए आप. आ जाइए. आ जाइए. Okay. ठीक है. So that's the first microscope. Anton von Leeuwenhoek's. There are about 7 or 8 available still in the museum in Austria. And this is what it is. Okay. The next question. वो नहीं मुझे पता. Yeah. And then apparently यहाँ पे कहीं रखते थे. And he discovered, he identified so many things based on this, including RBCs. Including RBCs and all he described, plants, animals and all that. Connect the two pictures to get something that adds color to our lives. Perfect. That's hematoxylin and eosin. This is the bark of the tree from which hematoxylin is obtained. And that's the Greek goddess of dawn, Eos. So the concept, Eos, hematoxylin and eosin, that's the connect. Right. Sometimes it's good to have 0 on your answer sheet. It's a historical logo. What became zero on that day? Eminently. Look at the year. Smallpox. Smallpox became zero on that day. Great. Okay. एक डॉक्टर की मौत. Award-winning movie by Tapan Sinha. Story of ostracism, bureaucratic negligence, reprimand and insult of a doctor instead of recognition and award. The movie, Pankaj Kapoor and Shabana Azmi, movie is based on whose life and what work? Okay, I'll grant that to you. I'll grant that to you. It's basically the life of Subhash Mukhopadhyay. The first test tube baby, Durga, was his. The entire IVF process in India was his, but he was ostracized, landed up committing suicide. Yeah, that's Subhash Mukhopadhyay. In fact, it was just very few, a month or two later than Louise Brown, who was the first IVF girl and the test tube baby in the world. It was there, but this is what it is. Subhash Mukhopadhyay and IVF. All right. Naveen, sir. Patent of an Iranian physician. Name the person or the instrument. Again, eminently guessing. Right, Jamshidi. That's Iranian. Iranian. Come, Dr. Jasmine. There are some things from Pondicherry, some of our ashram products you can make. Okay. Where are the PGs are not here anyway. Yeah, definitely. This is in 1981, St. Petersburg. Someone observed that it was possible to differentially stain nuclei and cytoplasm of Plasmodium in malaria. Just fill in the blank. Petersburg, St. Petersburg. Yeah, obviously. Right, Romanov. That's Romanovsky. Romanovsky stain, the concept of. Okay. This color is called tawny. Okay, there are lots of animals, it's tawny. How is it related to a disease? No. No, simple. एक्सप्लेन करना पड़ेगा नहीं है कोई आंसर नहीं है चलो सिरोसिस अच्छा फिक्स है ठीक है एक चॉकलेट ले लो यार okay cirrhosis why because the Greek word for that color tawny is kiros and this was the color of the liver. So you can imagine alcoholism, ancient disease, even the Greeks identified it. This was the color of alcoholic liver, tawny, and that's how it is. Okay. You series bataiye kaun hai? Netflix. अगर नहीं देखा है तो आज का होमवर्क है ये सब जाके ये देखो प्लीज सीरियसली Anupam Kher is also there. It's a series about any idea? No one. New Amsterdam. Please, देखो इसको. That be your next binge. Okay. Yeah. आसान है. अविनाश नहीं बताएगा. The medical connection. Warfarin. Brilliant. Warfarin, of course, you know the sweet clover and the cows that died eating the sweet clover out of bleeding. And what the name has come from Wisconsin Alumni Research Fund. WARF. So that's the connect. Right. First come first served. That's PNH, the urine of PNH. It's also called the. Any idea what this disease is also called? Okay, but black mornings and yellow sunsets. That's the urine description of urine flow of the day. Right. Double fortification with. Okay, iron and iodine. Who answered first can come and grab a prize. नहीं वर्मा का गलत हो गया. It's iron and iodine. Iodine तो था ही पहले अब because of the anemia मुक्त भारत This is Dilip Mahalanobis, Indian scientist that saved the world. There was an article on him. Indian scientists that they saved the world. Out of a devastating war came the solution that revolutionized the therapy of a global disease. Again, brainchild of a relatively unknown Indian medical man. What was the brainchild of this Dilip Mahalanobis? He lived in Calcutta, Salt Lake. He was known as the Dr. Babu, but his work was never recognized. Something related to that, sir? ORS. The ORS solution was his creating, the constituent of ORS. It happened during the Bangladesh War. In the Bangladesh War 71, he was right. ये simple है. Rarely there are some discoveries which shape the future of mankind. This paper talks of one such discovery. Sir ने बोल दिया Philadelphia chromosome. Novel and Hungerford. Sir, yeah. ये बताइए. You all know about the drink? Okay, granted. Gin and tonic. The tonic part of it is because quinine was very bitter, so they mixed it with gin to serve the soldiers in the World War I Afghanistan war. It was a daily recipe for all of them. That's how the gin and tonic part of it has come. Stephen was a 5-year-old boy when he became the first patient described to have this disease in 1952. He was dependent on blood and plasma transfusion, was infected with HIV in a period when blood was not routinely screened. He died of AIDS. What is his surname? Stephen's surname? Christmas, right. Chapter 11, Stephen Christmas. आ जाओ यार ये खत्म कर ले लो ना ये मुझे वापस ले जाना पड़े ये बताइए. The lady on the left is Padma Shri awardee, professor of microbiology, Madras Medical College. The lady on her right was her MD student. In the year 1985, for her thesis work, she collected blood samples. What did it lead to? (1985) MD microbiology thesis के लिए blood collection was done. What did this lead to? Chennai, 1985. HIV. HIV. The first cases of HIV were discovered through this thesis amongst the commercial sex workers in Chennai. So this was the project. And Suniti Solomon, a remarkable lady in the field of microbiology. And this lady, her student is still alive. She lives in Tanjore, practicing microbiologist. Okay. This is the holy water sprinkler. This one. Some genus of organism is named after this because it resembles the shape. पुराना है कोरोना वरोना नहीं. Shape, this is the sprinkler का shape, ये वाला. Microbiology या किसी. Aspergillus. Aspergillus. What disease? इसका मैप है 2021 का एक नहीं नहीं वो देखो ना इंडिया में इतना ज्यादा ऑल ओवर द वर्ल्ड. किसने बोला एनीमिया? हाँ रश्मि देखिए कितना 30 ईयर का है लेकिन 204 countries and it's still 21 का डेटा है. एनीमिया डॉक्टर रश्मि आ जाइए. Okay, it has 5 major varieties. It has 5 major varieties. The 5th one has been added relatively recently. The first one translates to sickle bearer. Discuss. What are the 5 varieties? Okay, पहला वाला falciparum, दूसरा वाला vivax, तीसरा वाला oval, fourth is malariae and knowledge. अरे उनको दे दूं या आप कर लो ठीक है सिंपल बहुत पहले से पूछते थे सब कुछ नहीं गलत है वो बिटाई पॉस्ट्रम लैटरम होता है लैटरम नहीं होता नहीं एंचोवी सॉस पहले तो पता ही नहीं होता था कि एंचोवी होता क्या है सो दैट्स अ फिश एंड आई स्टिल डोंट नो वेदर इट इज द पस और द सॉस फोटोग्राफ anchovy sauce pus of liver amoebic liver abscess who answered he's stealing all the gifts चलो ये तो सिंपल है हाँ बात चलो आप विजय तिलक सर आप आ जाओ पहली बात आपने आंसर किया चलो वी आर ऑलमोस्ट फिनिशिंग ये क्या है चलो amylite simple I had kept some for PGs there I mean that's why you might find these very simple connect the two pictures में मुझे explain भाई वो ऊपर वाला मैप Struma ovine is the correct answer. Struma is the river, Struma in Bulgaria, on the banks of which iodine deficiency occurs. So that's how the name Struma. You know, Struma is at times goiter is called. We used to be thought. That's Struma ovine. Okay, you know that FDA says that a medical device is something that is used to either cure, treat, prevent a disease. There are 2 living beings that are considered as medical devices. Living beings. Leech is one. Other? Maggot. Leech and maggot. Other one pen each. Pen lena aur kuch nahi lena. Maggots and leech are 2 living beings that are considered as part of medical device. Simple. कौन है ये? पापा निकोलो. लिखा भी हुआ है अगर ठीक पढ़ सकते हो तो लिखा है पापा निकोलो. ठीक है that's Paniculus. ये बताएं. This was basically a Polish physician Edmund Barniaki. He defined the clinical use of this particular test. He detailed his finding in 2 articles, and these findings were initially not very popular, but this is something we know as something, which is the answer. It's called as Barniaki reaction in that Poland and East European countries. Some test that we know as something, dash, 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 is called as Barniaki reaction. Its values देखो पता चल जाएगा नहीं ESR erythrocyte sedimentation rate and this was the instrument that he had got it. French dermatologist Ernest Besnier possibly introduced the word to the medical community in 1879. The word is of Greek origin coming from 2 words, life and sight. It's the lifeline of all pathologists, all of us, most of us. Life and sight. Micro to chota ho gaya. Something. Greek for life and Greek for sight. Bios. Okay, bios is life. Sight is opsis. Okay. This is identify the IHC stains. This is normal lymph node, that's a lymphoma. PCL2 normally नहीं होता है ना ऐसा Ki67 proliferation. This shows the polarization of the reactive follicle centroblast and centrocyte, and that's what you see in a lymphoma where it's scattered. That's clear 67 of the proliferation index. Okay, I think this is the last. Yeah. Stanley was born in 1915 and often at a young age. He was raised by his grandmother. He later completed his schooling from Tufts University. His work in the field of medicine is highly revered. An excerpt from one of his work is, tattooing may cause dermal pigmentation of an innocuous but sometimes embarrassing nature. The tattoo pigment has the distressing property of persisting in situ throughout life in dermal macrophages, creating difficulties if one wishes to marry Alice when the adornment is tattooed Mary. Just, what's his surname? How do we know him? How do we know Stanley? Anyone? Yeah, simple hai. Something that all of us have read by and swear by. That's Robbins. Stanley Robbins. If you have read the earlier, these were all there in Robbins. All this was part of Robbins. You know, now it has got commercialized and terrible. All these little stories were there in the original Robbins. Okay, I think that's all. Thank you very much. I finished on time. Time is. इसको कुछ नहीं ये बहुत कॉम्प्लेक्स है ये आपको
स्लाइडें कहाँ है? आप देखो क्या क्या मैं पहले आराम रहोगा हमारे बस में यूरा पे भी है तो 9-15 के 35 है कितना हुआ Probably, you know, we have small with baby and junior and right, so please go ahead. Okay, the video
मॉर्निंग एवरीवन। काशी नगरी में आप सबका स्वागत है और काशी नगरी में शिव की चर्चा किए बिना यहाँ आना अधूरा है। तो मैं चाहती हूँ कि आज बहुत अच्छा मौसम है, आज सेकेंड डे है कॉन्फ्रेंस का, आप सभी रिलैक्स्ड भी हैं, बहुत सारे लोगों ने काफी घूमा भी होगा काशी को, तो अब आप काशी को फील करिए विद दिस शिव स्तुति। नमामि शमीशान निर्वाण रूपम विभुं व्यापकं ब्रह्मवेद स्वरूपम् निजं निर्गुणं निर्विकल्पं निरीहम् चिदाकाशमाकाशवासं भजेऽहम् निरङ्कार ओङ्कार मूलं तुरीयम् गिराज्ञानगोतीतं गिरीशम् करालं महाकालकालं कृपालम् गुणागार संसार पारं नतोऽहम् तुषाराद्रिशङ्काशगौरं गभीरम् मनोभूतकोटि प्रभाश्री शरीरम् स्फुरन्मौलिकल्लोलिनी चारुगङ्गा लसद्दालबालेन्दुकण्ठे भुजङ्गा चलत्कुण्डलं भ्रूस्फुटं विशालम् प्रसन्नाननं नीलकण्ठं दयालम् मेघाधीश चर्माम्बरं पुण्यमालम् प्रियं शङ्करं सर्वनाथं भजामि प्रचण्डं प्रकृष्टं प्रगल्भं परेशम् अखण्डम् अजं भानुकोटिप्रकाशम् त्रयः शूलनिर्मूलनं शूलपाणि भजेऽहं भवानी पतिं भावगम्यम् बलातीत कल्याण कल्पान्तकारी सदा सज्जनानन्ददाता पुरारी चिदानन्द सन्दोह मोह पहारी प्रसीद प्रसीद प्रभु मन्मथारी न यावदुमानाथ पादारविन्दम् भजन्ति हलोके परिवानराणाम् न तावत् सुखं शान्ति सन्तापनाशम् प्रसीद प्रभु सर्वभूता निवासम् न जानामि योगं जपं नैव पूजा न तोऽहं सदा सर्वदा सम्भुतुभ्यम् जरा जन्म दुःखोदतातप्यमाणम् प्रभु पाहि यापन् नमामीश शम्भु। हर हर महादेव।
हाँ सर क्या नाम है हाँ सर ऐसा है Hello, John. I'm doing this call. You're right. Yes. What's more fun than the usually Yes, hold on a minute. Yeah, it's not actually. This is why I issue. Yeah.
वो भी है
अच्छा अच्छा कौन सी जगह पर
आ रही है मैडम आ रही है हम आ
कौन सी
ठीक और ओरिजिन है आशुतोष सर का जो ओरिजिन
जी जी जी
ये है ना ऑलरेडी ठीक है
चला के देखिए।
और वहाँ क्या वो रखा है क्या?
हाँ जी मैम, सिलेक्ट
Good morning and welcome back to UPGHCon 2026. We trust that you have thoroughly enjoyed our first day of scientific feast as well as our extraordinary quiz by our quiz master extraordinary Dr. Devdatta Basu. For the first session of this second day of scientific study, we have navigating population changes in pregnancy, where understanding physiological hypercoagulability is essential to preventing complications. May I invite the chairpersons for this session, Dr. Jasmeena Alwalia, Professor of Hematology, PGI Chandigarh, Dr. Sikha Sachan, Professor and Department of Gynecology and Obstetrics, IMS BHU, and Dr. Shomasri, Assistant Professor, Department of Gynecology and Obstetrics, IMS BHU. Kindly introduce the speaker and stars.
I follow. I told
My can't bring
I can't control.
So,
Why by two?
it's a duty to take it.
Why by two? Why by two?
Speaker of our session, Dr. Rashmi Kushwaha, will be speaking on navigating coagulation changes in pregnancy. Dr. Rashmi is well known to the hematology circles as well as to our national circles. She's a professor at Dr.
Right.
Department of Pathology, I think, Northern American University. And she has her special areas of interest are coagulation disorders, multiparametric flow cytometry, and hemoglobinopathies. She has a large number of publications and she's held some very important posts like the treasurer of this society, has delivered so many national talks. We had the pleasure of hearing her on more than one forum. So without waiting any further, Rashmi, the floor is yours.
Thank you so much, ma'am, for the kind introduction. Very good morning to all the faculty members, delegates, and students. The outset, I would like to thank Dr. Vijay Tilak and my dear friend Dr. Dikpa Rani for giving me a chance to visit Shivki Nagri. And yesterday I got an opportunity to attend the Aarti at the temple, which is here itself in the campus.
Right, yeah.
And that Aarti was really mesmerizing with all large damrus playing together. And it was really beautiful. So when the scientific program was being finalized, Deepa asked me, Madam, what would you like to present? And since coagulation is very close to my heart, so I thought, let's present something related to the coagulation. And then I decided to present the coagulation changes in pregnancy because this is a topic which is hardly discussed and almost every female goes through this process of pregnancy at least once in their lifetime. So why not to discuss this topic, which should be addressed timely. So let's start with the case. A 26-year-old primary gravida at 32 weeks of gestation with no medical illness. Her routine laboratory investigations revealed 11 grams per deciliter, platelet of 1 lakh per cubic millimeter, PGIR normal, APGT normal, fibrinogen elevated to 520 milligram per deciliter, and D dimer elevated. So are these parameters normal or abnormal? So what happens in pregnancy? There are certain changes that a woman undergoes throughout all the trimesters in the coagulation parameters to prepare the body to prevent against the blood loss which can occur during the parturition. So talking about the hemoglobin of 11 gram per deciliter, during pregnancy, there is increase in the plasma volume by 40 to 50% at the term gestation. This leads to dilutional anemia. Although the RBC mass also increases, but the dilutional effect is more than the increase in the RBC mass, leading to the dilutional anemia. So in pregnant women, hemoglobin of less than 11 gram per deciliter is defined as anemia. So this woman has hemoglobin of 11. So this is perfectly in the normal range. Coming to the platelet count of 1 lakh per cubic millimeter, there is something called as the gestational thrombocytopenia. So approximately 75% of the pregnant women have this gestational thrombocytopenia, wherein the platelet count is between 75,000 to 1 lakh. So nothing needs to be done if the platelet count falls between 75,000 to 1 lakh because it is quite physiological. However, if the platelet count falls below 75,000, then it needs to be evaluated. So this patient, the platelet count is 1 lakh, which is absolutely normal. And all the parameters return to the baseline 6 to 8 weeks after the delivery. So there is increased plasma volume leading to the dilutional anemia and reduced platelet count because of gestational thrombocytopenia. Now, let's see what happens to the coagulation parameter. Pregnancy is a transient hypercoagulable state. All the factors are increased in quantity except for the factor 11 and 13. This increase happens because of the estrogen, which causes the increased protein synthesis. There is increase in fibrinogen, D-dimer, von Willebrand factor, and all the fibrinolytic factors undergo a decrease. Protein C and antithrombin remain normal till delivery, and they are slightly reduced during delivery, and further they come back to normal, whereas protein as factor 11 and factor 13 are reduced. So pregnancy is a transient hypercoagulable state. Now, what does that mean? When we are doing PT and APTT, because of this hypercoagulable state, there is slight 5% reduction in the PT and APTT value in pregnant women. So this we have to keep in our mind. Now, this patient has fibrinogen of 520 milligram per deciliter. A normal non-pregnant woman, the fibrinogen is between 200 to 400 milligram per deciliter. So this is definitely slightly higher than the normal range. And throughout the pregnancy, there is increase in the fibrinogen level. Like in the second trimester, it is around twofold increase. Towards the third trimester, it is 2.5 to threefold increase in the fibrinogen level. So the fibrinogen of 520 milligram per deciliter in this woman is normal. Pregnancy is a hyperfibrinogenic state, which is perfectly normal in this case. The increased fibrinogen is not pathognomic. However, if the fibrinogen is falling low, that is below 200 milligram per deciliter, then we have to be alert, because this is a very good marker for a impending postpartum hemorrhage. As for the fibrinogen, even the D-dimer undergoes a constant increase throughout the pregnancy. Towards the final trimester, the D-dimer value is around 2000 nanogram per ml. So increased D-dimer is also normal in this case. So this patient has mild thrombocytopenia, which is a gestational thrombocytopenia. PT and APTT are in normal range. High fibrinogen and elevated D-dimer is physiological and expected in this term in the pregnant female. So learning point from this case are that whenever we are evaluating a pregnant woman, always use the pregnancy specific ranges for those cases. Elevated D-dimer is not pathological and high fibrinogen is protective. Now coming to the case 2, a 30-year-old multipara with vaginal delivery. She has a blood loss of 1.2 liter. Her hemoglobin has fallen to 7.8 gram per deciliter, platelet to 1.1 lakh. PT-INR is normal, APTT is normal, fibrinogen is reduced to 180 milligram per deciliter, and D-dimer is elevated. So clearly this case is fitting into the postpartum hemorrhage with a blood loss of 1.2 liter. And most of the cases of postpartum hemorrhage are because of the uterine atony and the local trauma rather than the coagulation disorders. So in this case, fibrinogen is 180 milligram per deciliter, which is definitely low. So there are studies which suggest that we should try to maintain the fibrinogen about 200 milligram per deciliter, because when fibrinogen falls below 200 milligram per deciliter, it will lead to postpartum hemorrhage. Another thing is that in a pregnant woman, at term, the fibrinogen is quite high, around 600 to 700 milligram per deciliter. So at the time of delivery, if the fibrinogen falls to 400 milligram per deciliter, then that 400 value is still in the normal range of the non-pregnant women. So if you consider the range or the reference range of the non-pregnant woman, then one might feel that this is falling in the normal range. However, if you see how drastically the fibrinogen has fallen in a pregnant woman during delivery from 600 to 400, then it's quite significant. So always do a serial measurement of fibrinogen rather than doing a single point measurement. So this is again something to be remembered. Now, in this case, PT and APTT were normal. So here I would like to comment that PT and APTT remain normal initially till there is a blood loss of around 3 liter. So never depend on PT and APTT alone. Always do fibrinogen as a first marker to predict the postpartum hemorrhage, and it is clearly the most accurate and early marker of risk of progression to severe PPH. So there were studies, like in this study, you can make out when the fibrinogen quantity is more than 200 milligram per deciliter, there are very less chances. And if the fibrinogen is more than 400 milligram per deciliter, then absolutely no chances of postpartum hemorrhage due to coagulation abnormalities. However, if the fibrinogen starts falling, then there are increased chances of severe postpartum hemorrhage. For every 100 milligram per deciliter decrease in the fibrinogen concentration, there is 2.63 fold increase of the postpartum hemorrhage, increased risk of the PPH. Another thing we have to remember when we talk about maintaining the fibrinogen level, then we give the transfusion. So these transfusions should be given very judiciously. Otherwise, it can further lead to dilutional hypofibrinogenemia. So the transfusion, while giving the transfusion, always monitor the fibrinogen level to prevent the dilutional hypofibrinogenemia. So the learning point from this case are fibrinogen falls before PT and APTT. Target the fibrinogen level of more than 200 milligram per deciliter and do not wait for the INR to rise, because by the time the INR has risen, it will be too late. And fibrinogen is one of the early markers of the life-threatening hemorrhage. Management is as per the standard protocol by giving the cryoprecipitates and the fibrinogen concentrates. Now here is a third case, a 34-year-old woman with abruptio placenta, intrauterine fetal death and severe postpartum hemorrhage. Platelet 60,000 per microliter, PT-INR elevated, APTT elevated, fibrinogen is markedly reduced and D-dimer is markedly elevated. So clearly this patient is going into disseminated intravascular coagulation. So there are many causes of DIC in the pregnant woman, starting from the amniotic fluid embolism, intrauterine death, HELP syndrome, eclampsia syndromes, placental abruption, septic abortion, postpartum hemorrhage, and acute fatty liver of pregnancy. So here I would like to mention the role of thrombin, what happens in the body. So this thrombin is a key marker. It regulates the procoagulant state, anticoagulant state, as well as the antifibrinolytic and the profibrinolytic state. So let me explain that. Whenever there is a release of tissue factor with activation of the extrinsic pathway, it activates factor 10 and causes the release of thrombin. Simultaneously, the intrinsic pathway also gets activated, so there is a thrombin burst. Now, what does this thrombin do? It converts fibrinogen to fibrin, which takes part in the formation of the blood clot. So this is how it is a procoagulant. On the other hand, it activates the protein C, which along with protein S has an inhibitory effect on the factor 8 and factor 5. So that will further inhibit the thrombin formation. So it is kind of anticoagulant also. Now this fibrin, along with the fibrin monomers and fibrin dimers, will undergo degradation with tissue plasminogen activator, leading to the FDP formation. So this is profibrinolytic pathway, and this factor 2 will activate the thrombin activable fibrinolysis inhibitor, which will inhibit this process. So this is antifibrinolytic pathway. So thrombin is a key element regulating all these pathways. Let's see what happens in DIC. Like in this case, this patient had abruptio placentae with intrauterine fetal death. Now this caused the release of large amount of thromboplastin and tissue factor. So there is increased tissue factor, which caused the formation of increased amount of thrombin, which in turn led to the formation of increased fibrin. Fibrin monomer, fibrin dimers and multimers, and finally the formation of the blood clots. And on the other hand side, it activated the thrombin activable fibrinolysis inhibitor. This had an inhibitory effect on the fibrinolysis. There is formation of 4 and more of the blood clots and inhibition of the fibrinolysis. Plasminogen activator inhibitor 1 and 2 are also inhibited, leading to the reduced fibrinolysis. So here there is increase in the coagulation and reduction in the fibrinolysis, leading to the disseminated intravascular coagulation. So in this case, PT is increased, APTT is increased, platelet is reduced, fibrinogen is reduced, and D-dimer is increased. Now all these tests have certain limitations in pregnancy, because as I told in the initial case, that concentration of almost all the coagulation factors rise significantly during pregnancy, causing either a reduction of 5% or PT-APTT in the normal range. So when all these coagulation factors start reducing due to consumption in DIC, initially the PT-APTT might still remain in the normal range. So we might ignore that, okay, PT and APTT is the normal range. However, it would have been increased as compared to the baseline values. So again, the same thing I would like to repeat, that always do the serial measurement of PT, APTT, fibrinogen, D-dimer, all the parameters of the coagulation. Similarly, for the platelet, a serial drop in the platelet count is more significant than a single measurement. And low fibrinogen is not very sensitive to predict DIC. It is more sensitive for the impending postpartum hemorrhage. A single high D-dimer value is not meaningful, but a continued increase may help in clinical situation where DIC can be a complication. So always do a serial measurement of all the parameters. Okay, this is the ISTS diagnostic scoring for the overt DIC. So as we can see, all the global coagulation tests like PT, platelet count, fibrinogen, and fibrin-related markers are taken into account for deciding the total score. And more than or equal to 5 is compatible with overt DIC. However, it needs to be repeated once daily, and less than 5 is suggestive of non-overt DIC and should be repeated in next 1 to 2 days. So in this case, the interpretation is severe hypofibrinogenemia, high D-dimer because of the excessive fibrinolysis, prolonged PT-APDT, thrombocytopenia, all pointing towards DIC and should be managed as per the standard protocol. Coming to the next case, 28-year female at 36 weeks of gestation, she has mild leg swelling with leg pain and the D-dimer is elevated. No chest pain, no dyspnea. Just the D-dimer elevated, mild leg swelling and the pain. So does elevated D-dimer confirm venous thromboembolism in this case, or should we need to do something else also? So in this study by IIIrd, they studied 250 cases of singleton pregnancy. Among them, 5 cases had DVT and 28 twin pregnancy. Among them, 2 patients had DVT. And they studied the D-dimer value. There was no upper cutoff of D-dimer which can suggest that this patient can have deep vein thrombosis. The only finding was that a patient with twin pregnancy are at higher risk of developing the DVT. There was no upper cutoff determined. However, the lower cutoff, that is less than 2.6 microgram per ml at the term pregnancy, almost excludes the deep vein thrombosis. So definitely there is a role of the lower cutoff of the D-dimer level. But since we know that in pregnancy, the D-dimer is anyways very high. So to determine the D-dimer of a less than 2.6 microgram per ml is like little difficult. So the learning point from this case is that D-dimer level physiologically increases with advancing gestational age and the increase is more evident in the twin pregnancies. D-dimer alone cannot be used to diagnose venous thromboembolism. It requires the clinical assessment as well as the correlation with the radiological findings. D-dimer has a low specificity in pregnancy and low D-dimer of less than 2.6 microgram per ml can exclude DVT. So this was about D-dimer. Okay. Another case, a 29-year-old graduate to para 1 at 34 weeks of presentation with severe right upper quadrant pain, persistent headache, increased BP oozing from the IV sites, and the lab parameter shows platelet 48,000, elevated liver enzyme, LDH elevated, PT increased, fibrinogen markedly reduced. This is a peripheral smear which is showing the beautiful cystocytes or the fragmented RBC. The whole idea of keeping this case was to prime our students to how to recognize the cystocytes and how important it is to recognize the cystocytes in the peripheral smear. So this is clearly the case of health syndrome, that is hemolysis, elevated liver enzyme and low platelet. But as we can make out, the PT is increasing with the reduced fibrinogen. So this patient is further going into the disseminated intravascular coagulation. Another similar case, a 26-year-old female at 28 weeks of gestation presents with fever, confusion, reduced platelet, elevated LDH. Elevated LDH suggests there is hemolysis. However, the lesion enzyme, PT and APGT are in the normal range. And again, as we can see in the peripheral smear, there are presence of good amount of cystocytes. So this case fits into the microangiopathic hemolytic anemia, that is thrombotic thrombocytopenic purpura. Now a word about the point of care coagulation testing. So at this point, I would like to convey that fibrinogen assessment by the Claus technique is still considered to be the best technique which can be available in the lab. However, whenever we are sending to the sample to the lab for fibrinogen assessment, there is certain amount of turnaround time which is involved. And even if you are doing the fibrinogen very fast, it will take 1 hour to 1.5 hours. That is the minimum time required to convey the report to the patient or to the ward. So this point of care testing like ROTEM or TEC, although they give a faster result, but the drawback is that these facilities are available at very few centers in India. However, if your center has the ROTEM or TEC facility, then definitely you can use this and you can get the result within 10 minutes. And with viscoelastic testing, you can definitely monitor the therapy which is being given to the patient. So definitely it has an upper edge of giving the early results. If ROTAM and TAC traces are normal, clinicians should investigate for other causes of bleeding, and the hemostatic support is not required in such patients. And fibrinogen replacement is needed if the FibTam A5 is less than 12 millimeter and if there is ongoing bleeding. So learning points are that ROTAM identifies problem faster than the traditional coagulation test and prevents the unnecessary plasma overload. Now the entire presentation, there are certain take-home messages like fibrinogen of less than 200 milligram per deciliter predicts severe PPH. Always think early fibrinogen replacement, but at the same time, take care that there is not the development of the dilutional hypofibrinogenemia. PT and APTT are late markers. D-dimer is useful for DIC, not for routine PPH and thromboembolism. Always have a good look at the peripheral blood smear. It will give you a lot of information. And don't forget to do the serial monitoring of the coagulation parameter, which is very much required. We need to have a look at the trend these parameters are following rather than the single point measurement. So with this, my presentation ends. And since the STAGO is a partner in this conference, so I will do a small presentation on this kit SGL-IR test, fibrin monomer detection during the pregnancy and the role of fibrin monomer detection. This kit is available with STAGO and only with STAGO. No other company is providing this kit, and this is quite helpful. So there was a study done by Onishi et al. Regarding the fibrin monomer complex in normal pregnant women and how it can predict the thrombosis. So it was taken up with the aim for measurement of fibrin monomer concentration with other fibrinolysis markers during the normal course of pregnancy, and to evaluate if fibrin monomer is suitable for evaluating the thrombotic status in the pregnancy. So there were 87 normal pregnant women recruited in the early pregnancy, mid-pregnancy, and late pregnancy, some cases belonging to each of the category. And 127 randomly selected non-pregnant women were also included as a control. And one pregnant woman with venous thrombosis has been included. The parameters like fibrin monomer, thrombin antithrombin complex, just 4 more minutes. Thrombin antithrombin complex, D-dimer, FDP, and plasmin alpha-2 plasmin inhibitor complex were measured in all the cases. So as we can make out, the first table is showing the patient characteristics, the age, and the gestational week they were falling into, and fibrin monomer complex, D-dimer, thrombin antithrombin complex, and all the parameters that were measured. And fibrin monomer complex was measured by various techniques like latex immunoassay as well as the enzyme immunoassay. And it was found that this latex immunoassay technology is definitely more better than as compared to the other technologies. And this latex immunoassay technology is what STAGO has provided in their kit. So coming to the findings, in this graph shows the finding of fibrin monomer in a non-pregnant woman. So most of the maximum, this side, the y-axis is showing the number of patients or the number of women, and this x-axis is showing the fibrin monomer complex concentration in milligram per liter. So as you can make out, the maximum number of women had the fibrin monomer of around 4, that is 4.18 milligram per liter, with a complete range of 2.69 to 7.09 milligram per liter. However, one point to note here is that none of them had a fibrin monomer concentration of more than 10 milligram per liter. So 10 milligram per liter was the upper cutoff for fibrin monomer concentration in the normal non-pregnant woman. So what happened in the pregnancy? Again, whether in the early pregnancy, mid-pregnancy, or the late pregnancy, the fibrin monomer concentration remained same, that is 3.35, 3.95. That means there was no difference between the pregnant and the non-pregnant woman when you talk about the fibrin monomer complex. Now let's see what happened in deep vein thrombosis. There was one patient who had DVT during pregnancy, and the fibrin monomer concentration in that patient was very high, 32.4 milligram per liter. And there were other studies also, the data available from the other studies shows that most of the patients with DVT have a fibrin monomer concentration of more than 24.4 milligram per liter. So clearly, fibrin monomer concentration is very much higher in patients who have DVT in pregnancy. So it can be used to assess the deep vein thrombosis in pregnancy. Whereas if you talk about the D-dimer in normal pregnancy, it is not very helpful to predict the deep vein thrombosis, as I already mentioned in one of the cases that I presented that anyways it is going to increase throughout the pregnancy with maximum level being in the final trimester. So conclusion, fibrin monomer concentration was not markedly changed during the course of pregnancy. It is a promising marker with high specificity for thrombosis during pregnancy, and this could help avoid the unnecessary administration of prophylactic anticoagulants to the pregnant woman. And further studies with larger populations are required to confirm this finding, and it could be a potential marker for thrombotic status in pregnancy rather than D-dimer. So definitely we can use this kit in the labs for diagnosis of deep vein thrombosis in the pregnant woman. And with this, I would like to end my presentation. This is the this time you can see this is the beautiful Sardar Patel Hostel of King George's Medical University, and you can see ये जो गुंबद नजर आ रहे हैं ये administrative block के हैं. There is physiology department behind, and football match is going on in the playground. Thank you so much.
Thank you, Dr. Rashmi, for a very nice presentation. I don't think it can be made any easier than this. There is a case, there is an explanation, and you can see that the 5-6 tests that we are so used to in coagulation are also wonderfully brought out by the cases on what we have to rely on and what we don't. So with this, I open this presentation to questions from the House.
Very good presentation.
Thank you so much.
Apart from doing D-dimer and fibrinogen, is there additional relevance or use of doing FDP?
So definitely, I think we can do FDP, but I don't know how reliable results we'll get because there is reduction in fibrinolysis and increased coagulation in DIC.
Suppose we don't do FDP.
So, did I get the question right? You said that other than D-dimer and other than fibrinogen? Yes. So I'm not very sure that I can answer this very well because we don't use the FTP kit at all. So I don't have real life experience on this. Some of the tests that literature that we see does mention that it is there, that it can be used, but I don't think it is so well used otherwise. The thing is that we will all be using kits which are easily available to us on either on our analyzers or as point of care tests, small kits. And those ones will be the ones which have been tested most and have been found to be very useful. And these two parameters, fibrinogen, there's no denying that is one of the most important triggers for your replacement. So I don't know, maybe Rashmi knows more about that, but I don't have a clear answer.
Once we have not been using the FDP measurement in the
maybe it's true DDT for FM, but other than that, in a bleeding setting, I don't know. Any other question?
Yeah, as Dr. Rashmi gave her in her talk that ROTEM and FIPTEM advanced testing, but it's a far-fetched idea for our Government Institute to get such high-end tests. So I would recommend all the girls to make friends with your gynae colleague. Their staff can tell in advance that we are sending one fibrinogen. So we can make our machine on, keep the things ready, and by the time we receive sample, it takes only 15 minutes for centrifugation and 10-15 minutes to do tests. So within 1 hour, telephonically we can kind of tell results to our colleague, and then we can serve the purpose and see the molecule as definitely resized. So that's what we do. And any critical patient, we always tell, आपको सिर्फ phone कर दो, हमारा staff आपके receive करेगा फटाफट. We will make sure that you will get the result in within an hour. Fibrinogen for sure.
Yes. The clause technique is still the gold standard in
CMC people say like one cross method, what we test is the best. Even if fibrogenemia has been reported based on that, no genotype and all, because we will get many months or years to do so many things. By the time patient will collapse and I mean, a bad situation for it.
Thank you for highlighting such an important point. It's absolutely true, as we are always constantly looking for newer and newer equipments to help us out in solving our emergencies and our diagnostic problems in coagulation. This test still stands the test of time. Ross method is the preferred test and will be, will stay there for a long time. The Rotem and all do have a place, probably those who are used to it and have the machine on and everything is ready, because even there the tracing takes very long to complete. We keep hearing at A5, if the curve reads this, then we can trigger for fibrinogen. Yes, we can, but to get a complete picture in a situation like DIC or bleeding in pregnancy, maybe you need to look a little bit further and see the whole curve. So all techniques, as in everything else in medicine, plus and minus, but a good way. Any other question? If not, I'd like. Oh, this is making a lot of interest.
It's not a question, and I'm diversifying from the main topic. आपने एक बात कही serial measurement.
Yes, sir.
मैं सिर्फ population के लिए नहीं कह रहा, मैं कह रहा हूँ तमाम situation में serial measurement really helps. और मैं आपको अपना live example बताता हूँ कि I was a lecturer at IIIrd, जवाहरलाल नेहरू मेडिकल IIIrd, और समर वेकेशन में और विंटर वेकेशन में काम पूरा तो मेरी मदर को डायबिटीज थी और मैं टेबलेटेड फॉर्म में उनके सारे पैरामीटर्स सारा फोकस डायबिटीज पे था लेकिन व्हाट आई वाज फाइंडिंग वाज उनका हीमोग्लोबिन बहुत ग्रेजुअली बढ़ रहा था 12 था समर में आया 12.5 फिर विंटर में कराया तो 30 फिर समर में कराया 13.5 so everything was within the normal range, but it was showing a rising trend. And I told it to my brother, who is a clinician and a colleague of Tripathi sir, कि भैया मुझे ऐसा लग रहा है कि कुछ गड़बड़ हो रहा है. तो उन्होंने कहा गड़बड़ इस रिपोर्ट में नहीं है, तुम्हारे दिमाग में है, बहुत शक्की मिजाज के हो गए जब से तुमने पैथोलॉजी कर रही है. And then finally it turned out वो 14, 15, 16, 17, 18 तो मेरा ये कहना है कि आप जैसे कह रहे हैं एक मेजरमेंट अगर हम लेते हैं आई वुड हैव दिस नाउ लेकिन राइजिंग ट्रेंड है विद इन द नॉर्मल रेंज है दैट इट बिकम्स एबनॉर्मल एंड वी नीड टू इन्वेस्टिगेट
For example, the greatest count. If we do not know what is the so-called latest count in a particular patient, suppose count is 2 lakhs. Maybe it is decreased because its count was 4 lakhs. But 4 lakhs, it has decreased by 2 lakhs. Or if it is 2 lakhs, maybe it has increased. It count was 1 lakh. So one count may not tell whether it is normal, decrease or increase. Right?
I think that these are all very valid points. Rashmi, you want any concluding remarks?
Thank you, ma'am.
Thank you very much for participating.
Thank you, ma'am, for the amazing discussion, and thank you, chairpersons, for chairing the session. From microscopic slides to molecular platforms, hematopathology continues to evolve. For the second session of the day, we have slides to sequencing, molecular diagnostics in hematopathology. I invite the chairpersons, Dr. Nidhi Johri, Professor, Department of Pathology, SRMS Bareilly, Dr. Mohammad Faiz, Associate Professor, Autonomous State Medical College, Shahjahanpur, and Dr. Ashutosh Singh, Assistant Professor, Department of Pathology, Autonomous State Medical College, Jaunpur. I introduce the speaker and start listening.
So the speaker for this talk is Dr. Prakhar Gupta. He's Senior Consultant in Molecular Genetics in the Department of Molecular Oncogenomics, NRL Delhi, Dr. Lal Path, New Delhi. His area of expertise is hematopathology and molecular pathology. He has established high throughput molecular diagnostic and NGS services and extensive publications in molecular hematopathology. Over to you, Dr. Prakhar.
So good morning to everyone present here. Thank you for the kind introduction. I'm Dr. Prakhar. I'm senior consultant in NRL New Delhi. So the topic for my presentation is slides to sequencing, how molecular diagnostic reframe hematopathology. Reporting basically. So myeloid malignancies are clonal disorders that are characterized by acquired somatic mutations in hematopoietic progenitor cells. And with the with the evolution of laboratory-based ancillary techniques, there has been a continual enhancement and improvement in understanding of the disease biology, treatment, and disease behavior. So various attempts at risk stratification using different techniques have been performed to date. For example, in 1976, this was the morphological classification. Then came the era of cytogenetics, where AML were risk stratified into favorable, intermediate, and poor risk factors. Where the normal karyotypic AML actually came into the intermediate and had a very heterogeneous outcome. Then came the microarray era, which identified many key genes like NRAS, JAK2, NPM1, and FLT3, which alter the diagnostic profile of a patient and have a diverse outcome. To the current NGS era, where genomic profiling of AML allowed the understanding of key biological differences and proposed newer risk stratification models. So this paper from 2016 by Dr. Ellie is the landmark paper for AML that identified more than 15 different genetic subtypes of AML by performing a targeted 112 gene NGS-based sequencing panel in a cohort of 1,500 patients, and it identified AMLs which have genetic fusions, which have no genetic fusion, had DNA mutation, and which did not fit into any genetic classification. And eventually they came with a genomic classification based on the genomic subgroups of, like example, NPM1, TP53 mutated, core binding factor AML. And based on this, a distinct genomic subgroups were proposed, which led to the foundation of revised EAL in 2017. So coming on to the AML classification, which has itself gone evolution over the years based on the newer diagnostic techniques. In 1976, it was heavily reliant on the morphology. It required 30% blasts and cytochemical techniques like MPO for classification. Then came the WHO 2001, in which the blast criteria was reduced to 20%. It incorporated some newer disease entities which are identified by genomics. Example, recurrent translocation 1517, 821 in version 16. This was expanded in 2008, including the data which came from microarray and early data from the NGS, and KMP2A rearranged translocation 69 AML entities were established. To 2017, where the classifications were expanded and major genomic subclassifications were established into specific disease entities like AML with NPM1, biallelic FPI AML, among the others. So coming on to the WHO 2022, it follows the theme of fifth edition of WHO Blue Books and retains the lineage-specific hierarchy-based classification, and it incorporates genetic-based subclassification of the disease. For example, this myeloid entity over here has been classified into precursor and mature. Similarly, lymphoid, stroma-derived, and histiocytic dendritic. Another important aspect is to see that genetic tumor syndromes have been exclusively included in the fifth edition of WHO books. So with the release of the WHO 2020-22, in parallel, ICC classification was also proposed, with both heavily relying on genetic classification, allowing for a more accurate stratification. There are certain differences in the conceptual divergence, like the blast percentage cutoff. ICC follows a blast percentage cutoff of 10% for the recurrent genetic abnormalities, whereas WHO only follows the presence or the recurrent genetic abnormality, except for BCR-ABL1 and BZIP, where 20% cutoff is still required. The category of MDS AML, which is proposed by ICC, which includes all the cases of AML which do not meet a blast threshold, but a 10 to 19% blast threshold has been established by them. This entity is contained inside the WHO MDS EB2 group. Then ICC has a genetic emphasis on certain groups like TP53 mutated and SEPA mutated, giving them their own subgroups. So what is the impact of this classification? So this reclassification of WHO into WHO 2022 and ICC 2022 has allowed 23% of the cases to be re-stratified into the respective subgroups. And when we compare head-to-head WHO 2022 to ICC 2022, there is a 13% of observer variability depending on the specific subgroups which is proposed in the individual classifications. What is interesting to note is that in 2016, this NOS group has actually shrunk it into those defined by differentiation in WHO and the ICC NOS group by around 25%. So similarly, in the ELN 2022, major changes have been done where NPM1 mutated AML with FLT3 ITD is now an intermediate risk irrespective of the allelic ratio. So this group was previously classified into favorable and intermediate depending on the AR. Furthermore, NPM1 with adverse cytogenetic risk is now placed in the adverse risk group. Only inframe BZIP SEPA mutations are classified as favorable, and any secondary AML or AML with MR mutations de novo is classified into the adverse risk category. Genes like ASXL1, BCOR, EZX2, ZRSR2, and U2AF1 are actually inside the adverse risk group. So what is the real world applicability of this ELN 2022 classification? When you re-stratify the patients based on the ELN 2022, around 13% of the patients have been re-stratified. Predominantly, these patients arise from the intermediate group where patients having MR mutations are actually classified into the adverse risk groups, and those NPM1 FLT3 ITD low AR patients who were into the favorable risk group are classified into the intermediate. So similar validation and refinement of ELN has been recently published from TMH Mumbai. In this, 16% of the patients were reclassified, of which 11 patients are actually BZIP SEPA classified into the favorable risk group. 38 cases were restratified into the intermediate. These were cases of NPM1 having FLT3 ITD at low AR, and 17 cases were actually classified from intermediate to adverse because they had presence of MRP. So NCCN has actually adopted the recommendations of both WHO and ICC, giving equal weightage to both of them. For example, SEPA, WHO, and inframe BZIP SEPA mutations are included in the AML recurrent genetic abnormalities. Similarly, for MDS also, common cytogenetic abnormalities have also been included, which have been recommended by WHO and ICC. So over here we can see similar approach has been applied for MDS as well, where the WHO 2022, which actually stratifies MDS into those which have which are genetically defined, for example, 5q, SF3B1, and biallelic TP53, and MDS by morphologically defined, which requires some percentage of blast with other findings like fibrosis and hypoplasia. So the entity MDS IV2 and MDS AML actually have 10 to 19% are the same entities, but with a different nomenclature. So coming on to the newer category of myeloid precursor lesions, which include the clonal hematopoiesis, have been included in WHO and NCCN. The clonal hematopoiesis have a VAF of more than 2% and are observed in older age population owing to somatic mutation as a result of aging, smoking, and other genotoxic stress. CHIP or clonal hematopoiesis of indeterminate potential are precursor lesions which have clonality, but there is no cytopenias or dysplasia, and they have low risk of transformation to aggressive disease or even low risk MDS. Coming to ICUS is idiopathic clonal cytopenias of idiopathic cytopenias of uncertain significance, in which there is cytopenias but there is no clonality, and they have a very moderate risk of progression to any myeloid malignancy. Then comes clonal cytopenias of undetermined significance. So these can be low risk and high risk. The low risk CCUS have a lesser rate of progression compared to the high risk, and they progress into cases of MDS. These clonal mutations are associated with faster transformation to hematological neoplasm, increased cardiovascular risk, and overall increased mortality. So discussing about the lower and higher CCUS. So CCUS mutations generally, so CCUS entity actually shows mutations in the DTA genes, which are most common. So this red curve over here is CCUS with other mutations apart from the DTA gene. When CCUS actually acquire mutations in spliceosome gene complex like SF3B1, SRSF2, U2AF1, and ZRSR, these actually form the higher risk seekers group. So the higher risk seekers group have cumulative probability of evolution, a higher cumulative probability of evolution. And on the follow-up analysis, we can see that these patients actually have similar survival of low-grade MDS cases. So there are some cases which I would like to discuss, which highlight the importance of molecular testing. So this is case one is a 42-year-old male, acute onset fever, gum bleeding and fatigue, had a hemoglobin of 8.6 and pancytopenia, 45% blast, and these blasts specific morphology of cup shape. So in flow and morphology also AML had a bone marrow had AML with 70% blast. The flow cytometry was negative for 34,117, positive for 1333, and a morphological diagnosis of AML was established, possibly NPM1C. So NGS was performed and exon 11 frame shift mutation in NPM1 gene type B was identified at a VAF of 60%. Apart from that, a 64 base pair insertion in FLT3 was also identified at a VAF of 29.13% and AR of 0.6. So the overall diagnosis was AML NPM1C with FLT3 ITD, intermediate risk stratification. So the question is morphology enough? So despite a convincing morphology, mutations of FLT3 and NPM1 are detected in 84% of cases with this particular morphology. And still, there is 60% of the cases which do not have this morphology actually come out to be positive for NPM1 and FLT3 mutations. Another important consideration is targeted therapy. So midostaurin and second generation FLT3 inhibitors are also available, which actually improve the survival of the patient. So there are other genes which are like IDH1, IDH2, KMT2A, and recently incorporated NPM1 ziftomenib, which have targeted outcomes and will require diagnostic establishment of the variants. So coming to case 2, 28-year-old female had severe bleeding, menorrhagia, pancytopenia in peripheral blood. Bone marrow showed hypergranulopromyelocytes. A FISH PML RARA was performed, which was negative. And on immunophenotype, it was 34 HLA-DR negative, 1333 positive, and MPO strong positive. An imperial diagnosis of APL was established. ATRA was started, but the patient did not respond. On further workup, this is the RARA break apart probe, and we can see the RARA is actually broken up. And on NGS by RNA sequencing, the ZBTV16 RARA fusion was established. So the diagnosis was APML with variant RARA translocation. So why establishment of the variant transcript is important? Because though 99% of PML RARA cases do show classical APML, 1% will show ZBTV RARA. The important thing is in this algorithm is to see that variant APML which are resistant to ATRA will only respond to chemotherapy, and this needs to be kept in mind. Coming on to the last case, this is a 68-year-old male having progressive fatigue for 6 months, pancytopenia in peripheral blood, occasional hypolobated neutrophils, bone marrow was hypercellular with dyserythropoiesis and dysgranulopoiesis, 4% blast and 5% ring sideroblast on Pulstin. So a positive pathogenic SF3B1 mutation, which is K700E at 46% VAP was found, and it was classified into the MDS SF3B1 entity despite a 5% ring sideroblast, because SF3B1 in itself can establish the diagnosis. So why is risk stratification in MDS currently and NGS data important? Because of this newer entity of IPSSM, which is a 6-tiered classification system which incorporates alteration in 31 key genes, which 16 are major effect genes and 15 are residual genes. So these genes are implicated into the overall prognostication of MDS. So this is how the IPSSM scoring actually comes. This is a 6-tiered classification, and it gives a personalized survival curve analysis. On right, we can see that the survival curve shows MDS cases with isolated SF3B1 mutation, and those MDS cases with have 1 to 2, 3, 4, and more than 6 driver mutations. And we can see isolated SF3B1 has actually better prognosis compared to those which are having more number of mutations. So coming on to the process of somatic variant classification and interpretation, this is the job of a molecular pathologist. The process of variant classification and interpretation is often referred to as clinical bioinformatics. After the NGS data is performed, the data is available to us after the variant calling. The pathologist performs the annotation following HGVS nomenclature and functional evidence findings. This is followed by oncogenicity classification of the variant, and it is classified into one of 5 tier groups. Then a tier-based classification as proposed by ASCO-AM guideline is followed, but based on the FDA-approved therapy to give the clinical significance and level of evidence of the variant. So the job of the molecular pathologist is not just limited to generating a report. He can also participate in molecular tumor boards, where he can be a part of the MDT team and deciding rare variants and how they will impact the treatment of the patient. So there are certain things to look forward into a report, molecular report, and certain things to avoid. First, it should have tiered, action-oriented interpretation of the reports. Like it should have a tier-based classification, tier 1 level A, level B, which is depending on the FDA therapy, which has been either utilized into the professional guidelines or not. It can be tier 2, the variant of potential clinical significance, level C and D. Variant of uncertain clinical significance is tier 3, and variant of benign or likely benign is tier 4. Raw tables should be completely avoided as it is overwhelming for the clinicians and it obscures the clinically relevant findings. All panels should not be reported, only clinical relevant genes to the particular disease phenotype should be reported. Coming on to a practical algorithm for leukemia cases. So first, the morphology should be established. And the morphology should be established by making the bone marrow aspirate smears and biopsies. Second, samples should be collected in apparent tube for flow cytometry and cytogenetics analysis. And third, should be the molecular sample collection. So the question arises, what size of panel, whether single gene testing is required, and what should be the turnaround time which the clinician should actually look forward to. So this is the Goal Consortium of Hematopathology Association, where 18 academic laboratories were sent questionnaires to identify differences and similarities in molecular testing approaches. It was found that most laboratories have a conservative panel size of 50 to 100 genes, and they have a LOD reporting of up to 5%. The turnaround time is from 1 to 2 weeks, and they follow ancillary testing, which are the basically to cover the caveats of the NGS. For example, capillary electrophoresis for finding out FLT3 ITD variants and using Sanger sequencing to identify the SEPA gene mutations. So another thing which we should follow is the integrated molecular reporting, where the final report should have the morphological findings, the IHC findings, and the cytogenetics and molecular finding as well. So this takes around 1 week to 8 days time at an average to give a complete integrated report. So finally, regardless of the classification system used, the ultimate goal is to support patient care through actual diagnosis, meaningful treatment guidance, and contribution to ongoing research. To conclude, molecular diagnostics redefine disease and are not decorated reports. Contextual interpretation is key, and integrated reporting aids in better understanding of the disease and aids in clinical decision. Thank you.
So Dr. Prakhar, it was a wonderful presentation. You covered all the latest updates, and I think this was very essential for all the junior residents, because whenever you present a seminar or a poster or an oral paper presentation, we tend to ask the latest updates about these classifications. And I think all the junior residents must have benefited from this talk. And now next generation sequencing is also available in IMS VHU. So I hope in future, Dr. Tilak sir and all the other faculty members, they will incorporate the morphology report as well as the next generation sequencing report, because it's going to benefit the patient ultimately. This was a very good talk, Dr. Prakhar.
Any questions from the audience?
आपने कहा था फर्स्ट पुल के can you go to that slide? हाँ नहीं वो है morphology. हाँ filtered particle, what is that? हाँ यहाँ पे make filtered particle section, what exactly is this? Any idea?
So filtered particle is when the aspirates are not there, you can actually, take imprints and whatever particles you find out, you can make blocks of it.
Okay. Plot section.
Plot section, exactly.
Plot section.
And from the plot section, which we have after making the smear, whatever extra material we have.
Yes.
It's thought section that we are doing routinely and it's sometimes जो हमने देखा ऑब्जर्व किया पहले हम लोग क्रॉस सेक्शन नहीं करते थे उसके बाद जब ये क्लॉट वाला ले रहे हैं जो यूजुअली हम लोग फेंक देते हैं कि बेकार है it provided sometimes a diagnosis which we missed on aspiration on biopsy and on an imprint. एक मैं आपको शेयर करना चाहता हूँ एक क्लॉट सेक्शन के अंदर हिस्टोप्लाज्मा मैंने देखा I was not ready to believe क्योंकि ना तो वो एस्पिरेशन में था ना इम्प्रिंट में था ना बायोप्सी में था I called my spouse who is a microbiologist and asked her कि भाई ये मुझे लग रहा है कि मैंने तो हिस्टोप्लाज्मा इतना दिखता नहीं she said नहीं हिस्टोप्लाज्मा but still I was not ready to believe तो फिर मैंने कहा कि अब हम लोग करते हैं इसको बायोप्सी करते हैं और इसका कल्चर करते हैं बायोप्सी से and it turned out to be culture positive histoplasma so clot section is very important.
Sir, actually, this was presented as a poster, and I was the judge of that poster. It was a very good poster, and I think the case and the histoplasma came in bone marrow wash.
Yeah. Divya is there, right? Yeah.
Is there any possibility like in NGS, we are not getting the mutation and through some other technique like Senger's or something like the chirally SEPA or so is there any possibility like we have done NGS and we still can miss the mutation which is present because of the limitations of NGS?
So, it all depends on the panel size basically. If you have a very small panel size like 20 to 30 genes which are only essentially targeting the important genes, even rare variants and rare, for example, ZBTB16 which we found, our panel is of 120 genes and it looks after around maybe 150 different sort of fusion and fusion partners. So that can be missed maybe on a smaller platform, but and probably the important thing is to highlight the representative sample should be actually available. So if there is a bone marrow involvement and peripheral blood is not showing just 1 or 2, it is only 1 to 2% blast, then maybe NGS will be falsely negative.
Any more questions? Or comment है I saw you drinking water from the glass bottle and I was so happy कि हम लोगों ने जितना प्लास्टिक वेस्ट है वो सब्सटेंशियली रिड्यूस कर दिया है और मेरी रिक्वेस्ट रहेगी त्रिपाठी सर से और डॉक्टर वर्मा से कि जो हम लोग यूपीएचजी के आगे करें तो कोशिश करें कि हम लोग we move on to these biodegradable material so as to reduce environmental जो हम लोग वेस्ट जनरेट कर रहे हैं थैंक यू वेरी मच क्योंकि सर एक सेइंग है we have not inherited this earth from our forefather we have borrowed it from our children और जो कुछ चीज आप अपने बच्चे से बोरो करते हैं वो आपकी जिम्मेदारी है कि या तो उतनी अच्छी हो या उससे अच्छी उसके लिए छोड़े हम सबको अगर हम थोड़ा सा डिटरमिन्ड हो जाए तो वी कैन डू दैट इट इज पॉसिबल थैंक यू
Thank you, sir, for this amazing presentation. Thank you, Chairperson, for chairing this session. For our next session, when does undetermined significance require closer attention? Monoclonal gammopathy of undetermined significance remains clinically relevant and carefully watched condition. For this session, I would like to invite the chairpersons on stage, Dr. Abhishek Abhinav, Professor, Department of Pediatrics, IMS BHU, Dr. Varun Kumar Singh, Associate Professor, Department of Neurology, IMS BHU, and Dr. Abdullah, Assistant Professor, Department of Nephrology, IMS BHU. Chairpersons, please introduce the speaker and start.
ये वाला
नहीं पता very good morning to all of you.
इससे सेव करोगे कैसे चलाओ
Safe रहेगा सर. We like that Dr. Tripathi sir. His area of interest in clinical hematology and transfusion medicine. His achievement is visiting scientist in hematology, National Institute of Health.
सर नाम क्या है
He is recipient of National Award, Department of Science and Technology, Government of India. He is fellow National Academy of Medical Sciences from India
and then a FRCP from the London, FRCP from the Glasgow, and a FRCP from Ireland. He has owned more than 150 publications and written 6 books and 2 scientific films. Very impressive series, sir. Over to you, sir. He will talking on the monoclonal gammopathy of underlying significance and is everything significant. Over to you, sir.
Yeah, is that it? Hong Kong.
The topic of today's presentation is monoclonal gammopathy of clinical significance. A very hot topic these days. The two great legends, Dr. John Wallenstrom, Dr. Robert Price. In 1944, Dr. Jan Wallenstrom and colleagues referred the presence of abnormal protein, that is paraprotein, also known as gamma globulins, in patients presenting with refractory anemia. In 1978, Dr. Robert Kyle coined the term MGUS, monoclonal gammopathy of undetermined significance, for those patients who had monoclonal protein and where it was not possible with available methods to determine which patient will develop glioma. So this is the definition of monoclonal gammopathy. Monoclonal gammopathy is defined by the presence of monoclonal immunoglobulin in plasma, urine, or both. That is produced most often by clonal plasma cells or less often by B lymphocytes. One should also include B lymphocytes, as we have seen. We have heard the presentation yesterday. And by Dr. Tathagat, the patient was supposed to be having plasma cell clone treated accordingly. Later on, autopsy found out to be B cell. So this is a very important point. These are criteria for diagnosing MGUS. Amount of protein is less than 3 gram%. Clonal population of bone marrow plasma cell less than 10%. Absence of myeloma defining events. But mind it that in even general population, so-called healthy persons, the prevalence of having MGUS is around 0.7%. It increases with age as much as that at age of 70, it can go up to 5 to 7%. There are important 3 types of MGUS. Non-IgM MGUS, that includes IgG, IgA, and very rarely D. IgM MGUS and light chain MGUS. You don't get M protein band, only you get raised light chains. And this is something more about light chain. The first 2 is original description based on data from 282 patients. The normal range was supposed to be 3.3 to 19.4 and lambda 5.7 to 26.3. The ratio, generally in clinical practice, we follow this. The normal kappa lambda ratio is 0.26 to 1.64. But another study, which was done on more than 41,000 samples, they recommended that normal ratio would be 0.4 to 2.59. But patient with renal dysfunction, this could be high even without disease. And you can see that then you can consider the ratio as 0.46 to 3.3. So the message is that light chains are raised from normal in patients with renal dysfunction. So what is MGCS? This is the difference between monoclonal gammopathy of undetermined significance and clinical significance. In MGUS, this monoclonal protein is essentially inert. It's not doing any bad thing in the body. It's just silent. While MGCS, clinical significance, means monoclonal protein is toxic and doing something bad in the body. So how does it do? This monoclonal protein deposited in tissues, this can act as autoantibody in the tissues. This can also damage tissues through cytokine activation and also complement activation. So these are mechanisms by which monoclonal deposition in the tissues are toxic. And this is the criteria. This is the presence of MGUS and not meeting the criteria of myeloma or Waldenstrom. And there is a presence of myeloma-related organ toxicity. That means No therapy is needed for MGUS, while MGCS requires specific treatment. This is a summary of these terms. The first two is myeloma. M protein positive, more than 10% plasma cell positive, TRAB also positive. This is myeloma. Second row, monoclonal gammopathy is there. Plasma cell more than 10%, no damage, no symptoms, small raise. Third row, there is a presence of monoclonal gammopathy. Plasma cell less than 10%, no TRAB. This is MGUS. And along with MGUS, if there is a specific organ damage, then it is MGCS. This could be of various kinds, renal, neuro, skin, that I will detail subsequently. So MGCS, in MGCS, there may be single organ involvement or multiple organ involvement. This is the picture, very dense picture showing the spectrum of MGCS. And these are important types of MGCS reported till date. It's the renal MGCS, that is called MGRS, neurological MGCS, MGNS, cutaneous MGCS, hematological. Now, many more entities are being added. There are three more important types: MGTS, monoclonal gammopathy of thrombotic significance, or it can also lead to acquired valvular disease, or cryoglobulinemia, and ocular MGCS. So let's see a case. 70 years male, hypertensive for 10 years, mild anemia, 9 gram%, clinical examination unremarkable. So in this scenario, generally, the anemia could be deficiency anemia, iron or B12. Patient is hypertensive for 10 years, so it could be CKD, or we can think of other causes as well. So here are the reports. 9 hemoglobin, 4,500, 1.6 platelets, MCV 78, microcytic, reticulocyte 1%. And patient has iron deficiency, creatinine is 20, B12 normal, creatinine is raised 2.1, urine is normal, ultrasonography normal. So the patient is diagnosed as having CKD with iron deficiency anemia, and subsequently he responded to intravenous iron therapy. But what is the cause of CKD? Generally, we don't follow these patients. Patients are happy with the improvement with anemia, but we should go deeper to find out the cause for CKD. Serum protein was done, was done. There was no M band, but here light chain was high. This is the patient where the last row, red color. You can see the kappa lambda ratio is 11.3, which is raised. Even if you consider the presence of renal dysfunction, it is raised. So if light chain is raised in this patient, there are three possibilities: light chain MGUS with hypertensive nephropathy, light chain myeloma, or MGRS, that is M protein with light chain deposition. There are three possibilities in this case. So in order to decide which one is correct, for myeloma, we need these two tests: bone marrow examination to see the number of plasma cells, and PET CT to see the bone lesions. And here bone marrow examination showed 6% plasma cells, that is less than 10%, and PET CT did not show any bony lesion. So the light chain myeloma is out. So now there are two possibilities: light chain MGUS with hypertensive nephropathy, and MGRS, MGCS now, light chain deposition. So here renal biopsy is needed, and it showed light chain deposition disease. So the diagnosis in this case is monoclonal gammopathy of renal significance, and the pathology is light chain deposition. So that's how we diagnose MGRS in this case. Something more about MGRS. This term was described in 2012 by International Kidney and Monoclonal Gammopathy Research Group, a term that describes any B cell or plasma cell clonal disorder that does not fulfill the criteria of cancer, yet produces a nephrotoxic monoclonal immunoglobulin that leads to kidney injury or disease. Patients who meet criteria of MGUS, who demonstrates renal injury attributable to underlying protein, and renal damage in the setting of symptomatic myeloma is not considered MGRS. And it can present in various types. It can present as acute kidney injury, chronic. It can present with proteinuria, hematuria, or even electrolytic. So any kind of renal presentation will be present in these patients. When to suspect MGRS? If the patient of MGUS or patient of smoldering myeloma, patient with smoldering WM, and this term this MBL, monoclonal B-cell lymphocytosis, if they present with renal involvement, you must suspect MGRS, or patients with unexplained renal impairment, proteinuria, and found to have monoclonal protein should be evaluated for MGRS. And for diagnosis, kidney biopsies must to demonstrate monoclonal hemoglobin deposition and presence of light chain or M protein in plasma and bone marrow examination to characterize clone. To characterize clone is very important. You must decide whether it is plasma cell or B cell, so that accordingly we can treat patients. And there are different types of ultra-structural changes in kidneys. This could be organized deposits, fibrillar, microtubular crystals, non-organized, MIDD, PGNC3, or even thrombotic micropathic abnormalities. Treatment of MGRS depends upon pathologic type of kidney injury and nature of clones, whether it is plasma cells, B cells, or lymphoplasma cells. So you have to characterize what types of clones are culprit. Another type of MGRS is monopathy of neurological significance. Patients who meet criteria of MGUS, not meeting the criteria of myeloma and Waldenstrom, and patient has peripheral neuropathy mediated by M protein and serum M protein. But it's difficult because you see, in MGUS, the studies are presence of peripheral neuropathy in patients of MGUS, people with MGUS. And it was 6.5%. And in mass control, who did not have MGUS, it was 2.8%. So certainly, the prevalence of peripheral neuropathy in patient of MGUS was much more than those who did not have MGUS. So there is some relationship between presence of M protein and peripheral neuropathy. But it's difficult to decide whether it is association or it's a cause. MGNS could present as only neurological phenomena, or it could be neurological plus system. Neurological is like IgM related or non-IgM related. IgM related is called DATS-M, non-IgM, I will detail it. And there are two important syndromes which are characterized by presence of both neurological and systemic, amyloidosis and Poem syndrome. So these are examples of MGNS. Most well-described clinical association of neuropathy with IgM type of M protein is DATS. The full form of DATS-M is chronic distal acquired demyelinating sensory neuropathy. And here IgM protein binds with myelin-associated glycoprotein. Another example is non-IgM protein associated neuropathy, that is IgG type. It presents like chronic inflammatory distal peripheral neuropathy. So two very important clinical types of MGNS. And accordingly, we treat the patient because it is IgM related, so they may not respond to steroid alone. So here the treatment is IVIG, rituximab and combination, while non-IgM, again, you can give IgG, but steroid is, these patients are steroid responsive. And now there are two important examples, amyloid and Poem syndrome. I will not touch about amyloidosis. A few lines about Poem syndrome. We should not restrict ourselves just to 5 words, poems. There are much more in Poem syndrome. Important 5 things are polyneuropathy, organomegaly, endocrinopathy, monoclonal gammopathy, and skin changes. But PEST is papilledema, extravascular volume expansion, sclerotic bone lesion, thrombocytosis, erythrocytosis. They are PEST. And still others, elevated BGF, pulmonary hypertension, thromboembolism. So Poem syndrome is not limited only to 5 words, poems, PEST, and others. And this is NCCN guideline and classification of poems. And this is sclerotic bone lesion. So coming to cutaneous, skin involvement. Patient presents with skin involvement goes to dermatology clinic. But patient may be suffering from monoclonal gammopathy. And these are different types of syndrome. Schnitzler syndrome, scleroderma, necrobiotic, xanthogranuloma, Kempe syndrome, cryoglobulinemia, systemic capillary leak syndrome, and Crohn's syndrome. Just have a look up some of the pictures. If patient presents with chronic urticaria, he may not be just a simple case of allergy. You must also think of this possibility. It is chronic urticaria, and this is IgM kappa type of gammopathy. Patient may have leukocytosis, raised CRP, and treatment and IL-1 mediated disease. Patient may present with some papular lesion like this, scleromyxedema. And this is IgG related disease associated with TGF beta, and treatment is IVIG and chloride-specific therapy. Patient may present with necrobiotic lesion, yellow papule clots like this around eyes, and here it is IgG monoclonal gammopathy. So now hematological, it's a very important, recently discovered. There's a paper in New England Journal, VITT like monoclonal gammopathy of thrombotic significance. It is recently described highly prothrombotic condition. It shares features of HITT. It is exactly like heparin-induced thrombotic thrombocytopenia, but without history of exposure to heparin. There is a presence of monoclonal protein, and this protein has anti-platelet factor 4 antibody property, just like heparin. What happens here? Patients present with recurrent thrombotic episodes, and response to anticoagulant and antiplatelet therapy may be inadequate. There are reports when patients did not respond to heparin and antiplatelet agents. And despite having heparin doses, patient continues to have recurrent thrombotic episodes. So here you must suspect presence of monoclonal protein. And because these patients when treated with bortezomib, they respond. And now there is a drug, imlifidase. This is IgG degrading enzyme. This is a new product. It's not available yet, but this is used in MGTS. Cryoglobulinemia. It presents with skin problem. It is vasculitis, and type 1 is related to malignancy. Type 1, and here again, it should be associated with M protein. Acquired valvular disease. It can be associated with M proteins, generally lymphoproliferative disorders, and treatment is same as valvular disease like IVIG, rituximab, but plasmapheresis. And it is ocular also. It also doesn't spare the eyes as well. Patient may present with different ocular presentations. So now finally, is the term MGUS relevant? Should we preserve this term or it is now irrelevant? Because monoclonal gammopathy is always significant. It is doing something in the body, whether it is obvious or not. And also, those who have MGUS have shorter survival than the mice control. So it is not benign. It is always significant. So there was a study, there's a paper, abstract, there's an oral paper, last ASH meeting, no more MGUS. The title was No More MGUS, Spanish study, and they studied 5,000 MGUS patients and followed for 5 years. And they created a model based on 3 things: circulating tumor cells, M protein levels, and abnormal FLC ratio, 3 things. And they proved that CTC can redefine MGUS into benign or malignant. So now there is another term that is called MGMS, gammopathy of malignant significance. You can see this, the red line is the low CTS and the blue is high CTS. So blue CTS, there is more chance of developing into malignancy. So those blue are known as MGMS and the red is MGUS. But again, whether significant or not, they say MGUS, don't write anything, just say monoclonal gammopathy, don't write anything. Because everything is significant. So this is the whole list of monoclonal gammopathy. It's could be benign or don't say anything about that, or it is clinical significant, it is renal significant, neurological significance, cutaneous significance, thrombotic significance, ocular significance, malignant significance, and last, infection significance. If person has monoclonal protein and has recurrent infections, that means it is doing something bad in the body. So it is also same. So there are different kinds and many more yet to come in near future. So I think that's all. The take-home message is monoclonal gammopathy should not be left as undetermined. Its clinical significance should be sought for. Always look for systemic involvement, particularly renal, neuro, and dermo. Patients primarily presenting with renal involvement, neuropathy, hematological features or recurrent thrombosis should be assessed for presence of M protein. Thank you very much.
Thank you, sir. Thank you, sir, for this very insightful talks.
I was looking at the watch.
Sir, what a timing, sir, for that.
And discussing the various spectrum of this monoclonal gammopathy of clinical significance. Sir, I have 2 to 3 questions, sir. I am from neurology department, and those questions may appear ordinary to you, sir, but I just want to ask those questions. Sir, as you told, sir, in IgM, MGUS and non-IgM, in IgM there is prevalence of demyelinating neuropathies more than the non-IgM. Sir, any particular reason for that, sir?
I don't know the details about that. I think neurologists should be more of that. Because I know this IgM related does not respond to steroid. Non-IgM related will respond to steroid. And they present differently clinically. So nerve involvement. But there is donor or something that I don't know the details.
So one more thing that
Can you highlight like in CIDP?
yes, sir.
It is mostly
Demyelinating, sir.
and in that's
That is also demyelinating.
it's a donor.
Distal quad demyelinating sensory and
It's a donor.
no demyelinating.
Both.
Both. And you in one slide, sir, you told that non-IgM related that inflammation that was axonal. That's why you were.
That is right. Okay.
Sir, one more thing is, sir, most of the time in our outpatient department, we tend to get such cases who presented to us with symptoms of peripheral neuropathy. And on initial evaluation, we do not get any cause. Then we plan for this evaluation for this MLS and other myeloma also. Sir, when should we proceed for bone marrow examination, sir? That is invasive. That's
So suppose you do serum electrophoresis and you find M1, or if you go total myeloma profile, you get high light chain. Then the problem is whether it is MGNS or something else. Then you go bone marrow examination and also skeletal survey in order to find out whether patient has element of CRAB or not. Right? Serum calcium level, renal involvement, anemia and bone. That's why we get bone marrow and skeletal survey. If it is positive, then it is myeloma. If it is not positive, then patient is suffering from MGNS. Again, you cannot say whether it is MGNS or it is association. The patient is 80 years of age. Protein may not be depositing in nerves. They are together, but they are not related. Or they are related also. So in that you can write MGNS.
So ultimately, sir, we have to do 3 things. One is the bone marrow assessment. Second is blood parameters assessment. And third is the deposition. We have to demonstrate the deposition also. So ideally, even nerve biopsy should be done. So like in kidney, we do kidney biopsy to confirm that there is a deposition. So production, circulation and deposition. Then it will be.
Thank you so much.
इसमें मैं एक चीज contribute करना चाहता हूँ. I'm talking about MGUS. Sir, all the patients are asymptomatic. And if you tell them that they need to do a bone marrow examination, they are reluctant to undertake a bone marrow examination. In that circumstance, these detection of circulating tumor cells in the blood, plasma, and even in urine by droplet digital PCR is now coming up in a very big way. It's a non-invasive way, and that helps because compliance to patient is wonderful. If you can do it from urine, you can do that without all the pain associated with the.
There is a limitation. By doing CTC, you can tell the patient that here you have a more chance of developing into malignancy. Every patient of MGS has a chance of developing into malignancy. So if patient has high CTC, more chance of developing. That you can say only. But there is another thing. if you want to exclude presence of a disease, then you have to do other, like you said, bone marrow and Susan.
Will be very good screening test, sir.
Skill.
Thank you, sir, for excellent talk.
So, Dr. Verma?
Yes, sir. Because mostly we start evaluation when patients present with those symptoms. So usually asymptomatic, because these are the studies where they have seen at the general population and they have screened the whole population, they found that disease. But for our clinical practice, mostly patients will be coming with some clinical manifestation, whether renal involvement, maybe nephrologist will be referring for workup of monoclonal gammopathy, or sometimes the neurological peripheral neuropathy. Also, we keep on getting patients who are not responding, so just for workup.
Sir, being a nephrologist, I would like to ask a question. The case you described today is very frequent these days. And sometimes what we find is a kappa or lambda restriction on biopsies. But despite extensive workup, we go for a bone marrow biopsy, we go for SFLC, we go for SPEP, even flow. We don't detect a proven. So how do you manage such cases?
If you don't detect a clone, then it is not NGRS. Even if patient has light chain, even if patient has light chain in the blood, if it is not demonstrated in kidney tissue, that means kidneys are not involved because of empathy.
What I'm saying is we find a light chain restriction on kidney biopsy.
So you have
Yeah.
biopsy.
We have several patients. We have light chain restriction on kidney biopsy, but we won't detect a clone on extensive workup like SPEP or anything. We won't detect anything on workup, but we have restriction on kidney biopsies.
There must be clone, that is light chain restriction must be there, but it is predominantly coupled, and only then it will say that it is a malignancy rather than benign. So clone finding restriction is must, so that you can embark the treatment.
This question. We saw one case, a 60-year female, she presented with acute renal failure. And she was evaluated, and kidney biopsy was done. Kidney biopsy showed deposition of this IgG, and it was light chain restriction. We did bone marrow, there was no plasma cell, only it was 5 or 6%. But light chain ratio was altered. So in these cases, we thought could be MGRS, and then patient was given clone, because in multiple myeloma, there are two diseases happening. In all these diseases, one is clone burden and the other is a product of the clone. In multiple myeloma, we have clone burden, which is causing the disruptive lesions actually. Whereas in myeloma and this amyloidosis and other things, we have clone-related product, which is being deposited and causing the damage. So in these cases, what we gave DCD therapy, and patient had a very good response. Later on, patient was also this followed up, and because of this VCD, patient was responded to therapy. So in MGRS and other these conditions, it is recommended that clone-directed therapy should be given.
That's right.
But that is fine, but his question is like he's not getting evidence of monoclonality in blood and not getting marrow plasma cells in the head. So in this, one thing is that, like sir mentioned, the plasma cells may be only 4 or 5%, which may be reported as normal. So the other thing is, because it is a dangerous plasma cell clone, so probably if you are really want to establish the association, probably you can go for flow cytometry to detect the plasma cell clone.
Also did flow. I have seen 2-3 cases, such cases in my lab. And it was very difficult to convince the hematologist to treat that case. And eventually we went with the chemotherapy and that patient improved.
Okay. So still maybe we need more sensitive tests to detect.
I've seen that.
Actually, myeloma infiltrates kidney in a patchy manner. So you can, I'm just saying, sir, that myeloma can involve bone marrow in a patchy manner. So it is not always there that you get a biopsy and see everything positive. But serum free light chain iron is a very, very sensitive test. It does pick up light chain. So please go back and check it in the laboratory. I was not trying to say this, but it is not possible that you have a light chain in kidney. Light chain in
It's the same thing that I was saying. You have to treat it as a monoclonal gammopathy of renal significance. If you found clonal restriction in the kidney biopsy, so it has to be treated as a case of clonality, right? Whether you are picking it up or not, that's also I said. SFLC is usually a very good marker. So you would like to, but if you don't even have evidence of plurality elsewhere, take it as a case of renal significance in GRS.
LCD, that's for stress. And in the NGRS, see like the serum tree light chain will be reduced. The ratio will be reduced. It will not come up to the myeloma defining event weight. But they will be a different and the slope only be marrow would be even less than 10% plasma or less than 5%. So it is something.
Yeah, what's it?
Organs related.
Is it more than 10%, then there's myeloma? No.
Yeah, so
Organs
that's
related.
only dealer will then it will be labeled as LCD. Thank you, sir. Thank you, Chairman. We now will take a break for breakfast. Kindly take your seats at 11 a.m. for the mid-morning scientific session. Thanks.
हाँ
Welcome back, delegates. Now, from plasma cell monitoring, we will now shift towards the analyzer-assisted interpretation. Modern hematology analyzers often provide the first diagnostic clue. So now for the next session, I would like to invite our respected chairpersons, Dr. Arvind Kumar Singh, Assistant Professor, Department of Transfusion Medicine, Dr. RMN Institute of Medical Sciences, Lucknow, Dr. Shobit Agarwal, Associate Professor, Department of General Medicine, HIMS, Varanasi. I would like to request the Honorable Chairperson to kindly introduce the speaker and commence the session.
Good morning, everyone. The next session is the plot thickness, the role of WBC scatter plot in leukemia. And our speaker is Dr. Naveen Katkar. Sir is a professor and head in the Medical College, Solan, Himachal Pradesh, and interest of area automated analysis, correlation testing, hemoglobin test disorder, and hemolytic anemia and leukemia. And sir has more than 90 publications in different areas. Sir.
Thank you. First, thank Dr. Vijay Tilak, Dr. Deepa, and the entire organizing team for this kind invitation. Quick quiz before I start my talk. What is MGES? You heard of MGRS, MG this, there. What is MGES? This is monoclonal downpairing of exam significance. Questions आएंगे. Okay, so my topic is the scatter plots in leukemia. Quickly, a show of hands. How many of us are PGs here? Postgraduate students. How many of you, show of hands again, look at your scattergram graphs carefully? No show of hands. So this is what should change. Please look at these curves and graphs and histogram. Very, very important.
Please come in the front. आप आगे आ जाइए. आगे आ. All the PGs may please come in the front so that you can listen to the talk.
Unlike the morning session, we will not have any involvement of the faculty. In the time that I have, I will only give you a flavor of what is possible with leukemias, much like this Baskin-Robbins streets. That's my outline. I'm going to focus mainly on case studies. But this background is important to understand what instruments can do for us and how. I will not talk about complexities of flags, raw data, or newer parameters. That's another session altogether. Why did we choose this topic? We have lots of newer parameters, but remember the graphical output, like we just saw, is almost always ignored by most people, even lab hematologists, even pathologists. We need to change that. You can actually rapidly flag a leukemia or abnormal population. We can give you subsets. You can even diagnose some leukemias. You can actually suspect them to a 95% accuracy. That important. And like I said, most importantly, life as a pathologist or hematologist is more exciting. You must have passion about this. What is coming, the output that coming at you is important, very, very important. So the WBC enumeration, the journey started with Wallace Stolper, 1953. He started in 1949, took him 4 years to get a patent for somebody to believe that cell counts are possible. He was passionate, kept passionate. We know the tap definition. I'm still very fond of it. I still have a personal counter. Do not get away with that. A lot of people I see now, you have differential counters on your mobiles. Exams में नहीं allowed a mobile. You will struggle. So keep your manual keys very well going. Then you got your typical 3-part histograms, more complex 5 parts with the WBC to get separate populations. VCS plots with Beckman Coulter, different way of presenting the cells. Digitize information. You put in a slide scanner, gives you all the differential, even a smear report. Revolutionary, yes. Which flowers are these? Ladies should tell. Remember your anniversary is that time. Forget me not. So these are forget me not flowers, and you should never forget the peripheral smear. That is always your fallback whenever you struggle, even with automation. See what your cells are saying. Lots of confusions. The students might be confused with these graphs are weird, this, that. Fine, I agree. But it's all about pattern analysis. Now, in this picture, there are muffin heads and a dog that I still can't pronounce, Chihuahua or something, whatever. So all you need to learn is after some time, which is a dog, which is a mouse. So even in these plots, with seeing more and more of these, you have to learn to see which is this and which is what is the difference between you. And you will learn. You don't need fancy books, fancy speakers at all. Our time when we were growing up, 2 models. This was expensive, this was less expensive. That was the choice. Now, and more. It won't even fit into a big screen. So this is the choice of analyzers now that you have. Lots of makes, lots of new components. The 5-part analyzer and the 3-part analyzer. Labs with 3 parts seems हमारे पास 5 part है. 5-part वाला उनके पास तो 3-part. This needs to balance out, and you will see some examples. So a 5-part is very merciless, expensive, lot of work. It will take you very far, very comfortably. Lot of features. Manually still take you from point A to point B, but more bumps. AC इतना काम नहीं कर रहा होगा, speed उतनी नहीं है. But they will take you from point A to point B. That's the only thing to understand. So the old impedance principle, not repeating that at all. The principle of 5-part analyzers, no detail, just a flavor. We have Beckman Coulter saying volume, conductivity, scatter. So they examine a cell by 3 different methods. And then say this is this, the white cells. Fluorescence flow cytometry by Sysmex separates the cell population very well. Believe the 5-part differential, they are very good. The Mindray, DHHS technology, and Horriba with the double flow and the hydrodynamic focusing. I'm going to talk focusing mainly on my work on ADV. We had this for 5 years. I had suspects let's work this. So this is based on myeloperoxidase. So imagine your slide still. So this does a staining for you inside for all cells. So some are obviously MPO positive, some are negative. Then the laser hits there and the suppressed. Very important to know the principle of the machine that you are working in. A lot of people ask this question, where are the different way? Does not matter. They will be similar in some ways. So they have a different personality in terms of they will categorize cells in a different way, maybe at a different place, but they get it. We need to understand how do they do this. So if this is the analyzer, the lab hematologist or pathologist has to be very close connected. Don't leave it to it initially, run the print out data. Work with the analyzer. When problems happen, troubleshoot, go there, go to the analyzer room and see. You learn the maximum way, not from a book, not from a speech. A lot of people think now, I believe in my knowledge very strong. Somebody says no technology is space. So I'm afraid of both these statements. The first one is I don't need to see the sphere even in a leukemia. The height of technology. Somebody says machine 5-part X, 7-part X, could measure the sphere technology. Both have limitations. So this has to work together. Understand where your morphology is limitation, use technology. Understand where your technology can make mistakes, use morphology. So let's look at what is common. So scatter plots, as the name suggests, your dots are scattered based on what they are. What are the kinds of cells? Why are the scattering your technology to do that? So on the IIIrd 120 where I worked with, this was the basic principle of the analyzer. So in terms of if you did a myeloperoxidase staining, what WBC is? Not talking about the cell lines. That's not the topic of today. So like your regular NPO, it will give you an NPO of cells within. But does it tell you this is NPO positive, negative? No. What's it for? So you have to learn to interpret that plot. That's it. So this is a cartoon actually from the screen of the machine. So all white cells dip into a pool where they are stained, and then some come out NPO negative, some come out NPO positive. And then when the laser hits them, more complex the granular the cells goes to the side, more simple it is forward scan. So lymphocytes, granulocyte basically are treated. So the flow cell actually asks the question, who are you when the cells pass through the. So that's a WBC scattergram on the ADV. You got granulocytes here, lymphocytes here, monocytes here, eosinophils here, basophils close to the lymphocyte zone place have very less cells, so hardly matter that way. And these are other populations. So that's why your cells are placed. So your blast would come somewhere here, reticular cells here, lymphocytes, granulocyte, left shape there. That is how the system was programmed to. So we talked about one population here, beyond the lymphocyte, this population. This is called in that instrument large unscattered cells. So what can come here potentially? You can get class, you can get atypical lymphocytes, and you can get something plasma cells. So these areas we expect this population to be. That was the printout of the ADV 120, very complex. But I'm going to focus on that part. So everything seems complex till you start understanding. I'm focusing on the WBC scatter plots here onwards. That's the granulocytes, the lymphocytes, some monocytes here, some LUC. Now this does not mean that are all blasts. It might be some large lymphocytes that are just going up because of their catastrophe. So this is one thing. So I feel separate population that way. So the link of a histogram with a 5-part scatter plot. If you look carefully, this is a granulocyte zone there, corresponds to that. The lymphocytes correspond to the lymphocytes. So it's actually seeing like a complex way of interpreting the same cells. So when you get a leukemia are bad cells, they are rowdy cells. They don't follow boundaries. They do not know that my place is this because they are not programmed into this. So imagine this train somewhere in Germany. You can imagine maybe 20 people sitting in it, many vacant seats like the audience here. Very organized versus the train in Bangladesh. Now, I haven't shown you the engine which has 120 people on the engine also. So leukemic cells are like this. They will be all over the place. They will not follow your zones. And that is where the diagnosis is. So that's the normal plot for a normal WBC count. So you will get a differential like this, pretty accurate. Pretty accurate to scatter plot ratio. acute leukemia. So where do you expect your blasts? In this zone. Where do you expect lymphocytes? In the CLL zone, in the lymphocyte zone. Where do you expect your CML cases? You would expect them this one. And actually wider. This is neutrophils. The left side cell will go up till there. A lot of patterns that you will see will be very familiar. So what are the prerequisites for leukemia identification? On a scatter plot, on a histogram, on my machine, or your machine does not. Okay, be aware of the technology. This was an MPO based, so I know what is happening inside these cells. Sufficient number of blasts. If your cutoff is 7%, 3%, don't expect the machine to tell you a flagging. Understand the eye instrument connection. What am I seeing on the scatter plot versus what does my smear show? Very important. If you think there is a disconnect, there will be a reason. Usually we think there is a mistake, either by the mind or the machine. Obviously, it is not, because both will work together. If normals are working, abnormal will also work, same thing. Expect heterogeneity in instruments also, and their diagnostic implication for you. Let more important. You know that no two acute leukemia are right. Same way, no two scatter plots of the same leukemias. Same condition. Correlate with flagging. The machine will tell you this, look for blasts here, this could be a typical cells, correlate. Analyzer of this path. We need to be smarter just to make sense of this path. That is all. Let's start with case study on basic device. Quick diagnosis from the residents from the CBC. This should give you some hint. We're dealing with leukemia, acute leukemia probably. I got an answer of COPD, which is because the lymphocytes are very. But remember your TLC can go with both. But 3-year-old, suppose I make this 30-year-old. Your diagnosis is starting. So remember, do not forget the history. So let's look at this scatter plot now. Now the granulocytes are much less. You are getting everything in the lymphoid zone and going up into the plastic zone. I want you to only remember this. This is a continuum. There is no break case. It seems like it. So why are so many lymphocytes? The machine is flagging only 11% blast because these are problems with small lymphoid blasts. Yeah. Because their size.
इसके बाद ना सावित्री मैम का जो कल कैंसिल हुआ वो होगा वो उसका जो सीबी स्पीकर का वो भी मैडम का
79% plus. So versus 12% of the machine. So is the machine wrong? No. It's actually telling you probably a lymphoid blast. That's normal versus the next case. Focus on this only, and you again get your answer of acute leukemia. Platelets are down, PLC is up. And you see if they have gone up compared to the last case, based on the lymphoid cells. Very similar, except the granulocytes are a bit more, but that's normal. But your brain population is still there. However, the LUC is now significantly higher, telling you probably larger plus. This could be. Remember AML, M2 and A2 and M1 blasts are similar morphologies. So this can be a lymphoid blast or a matter, but still an acute leukemia machine. The pellicle shows 76% blast, typical AML, no? So our ALL and AML were not very different. Did you get to know there are blasts? That is already. Somewhere in a medical college in the Department of Pathology, Sumit, the third-year resident, is frantically calling the consultant. He has seen a problem. The problem is, trust me, if you're gold standard, you're seeing 75% blast, but in neutrophils are 70% on the machine. That's actually 77%. LUC is hardly so. Machine is telling you no blast. In that sense. However, when you look at this, and it's large unstained cells. They're not empty or negative, but large. They're lymphocytes. So you see a pattern like this. This is your monocyte zone, with some lymphoid cells, and spread all over. There is a disconnect, no doubt. This picture tells you most likely an acute leukemia. Peripheral showing 55% blast. This is the time where morphology and technology clash. No blast versus so many. And the common thing you will hear is the machine color report you. This is where the machine tells you don't understand. What was our technology? Our technology was myeloperoxidase. So imagine glass which are more myeloperoxidase, which have a maturation going on, have been thrown into the granulocytic bodies. So the MLM2. So MPO positive glass and these immature precursors, because it's M2, are thrown into the stream-wise granulocytes. So you have a, that is why you have a different picture than the other leukemias, which are MPO negative or very weak leukemias. So this is an M2, and this was proven by 821 classification. Case 4. Any comments? MPO positivity is more this side. So this is actually gone and hit the body. Strongly MPO positive. Think again. Platelets are low, CML is unlikely. Look at the history, altered cystoria, maybe an intracranial bleed, APML. So this is a classical picture of APML where the high peroxidase activated grows the scatter just to the right. And this is a typical parabola shaped curve that you can see on a plot. And if you look at other technologies or other instruments for APML, almost everywhere you will have a particular peculiar morphology. So normal promyelocytes for 82, classical APML. And this plot is so correct. I'm showing you 4 other cases for APMS. Very similar. Very similar. So this pattern comes up and you think this is very, that's why I said some of the plots can be diagnostic. That is compared to the normal. Case 5, fever and gum bleeds for 4 days. Again, an acute leukemia like CBC, you got some monocytes, LUC not that much, mostly granulocytes. On peripheral, you saw a lot of monocytoid cells, which are probably placed here and gone there as well. So this is an M4, blast and monocytic cells. I'll take you to the picture. So the first picture we looked at versus the second picture. Look very similar. So why not an M2? Right? So do you think there is a difference or is there a similarity? There is a very subtle difference, or this seems like a continuum, this seems to have a break. This is that pattern analysis. You must learn to look at patterns. So this break tells you this population versus this are a bit dissimilar. And I'm going to just draw an outline to show you. That's it. And this has a incision on there. So this one. So you know there are 2 separate populations looking the same. So that is why M2 versus M4. That was a separate myeloblast and a monocytic population. On the other side, a single granulocytic profile going east. Case 6, very typical in the monocyte zone. So you're sure this is monocytoid. You got 75% very few blasts, so this is M5. Maybe or B or written, it's your large cells. So sometimes they're very defined in their population and you can pick them very clearly. Remember granulocytes? Almost anything, nothing there. Case 7, visa requirement. Look at your differential now, absolute lymphocytosis, platelets are normal. What's the diagnosis? CLL, most likely. Where do you expect your cells? Now remember our continuum. The blackness is not going there. So it is restricted to these small looking lymphocytes. So even though this looks like, okay, increased there, but it is sticking here. LUC is very less, 3.8 is very less. So this is typical CLL. I'm just going to compare CLL versus ALL. You look at that, restricted black zone here, black zone extending as a continuum. So those are blasts, these are not. You see, fatigue for 2 months. You have a predominant, your granulocytic differential, platelets are high, TLC is 2 point. TLC in lakhs, think of CML. There. Your neutrophil zone was here, but that shifted to a lot of left shift cells. Blast count is very less, which means chronic phase. You can even make that out. That's a typical manual differential. Typical CML in chronic phase. That's the difference for now. So look at your neutrophil cloud. Should have been here, shifted differently because of the nature of the cell. A lot of left shift cells are cropped. Okay, the patient was lost to follow-up, presented 5 months later with more acute symptoms. Predominantly one type of population instead of the mixture. What has happened? Yeah, everybody pointing this has come up. Can I take 3-4 minutes? So this has come up now, which means blasts have come up. So you can actually pick up a CML in blast crisis, just looking at your old case, old printouts versus the team. So 77% blast cell, so that's a CML chronic phase. The rest of the cell population left shift is there. So blast population is problem. Okay, that's I think 4 cases there. This is so what I want to tell you in LUC, other than blast, you can get plasma cells coming up there. You can get lymphoma cells coming up there. You can also get pro-lymphocytic population going up because there is all MQ negative. So they'll go in that zone. Okay, one case where the Mercedes scores over the nano. We said both will take you from point A to point B, but some advantages. Let's look at that. Generalized weakness, 2 months, no organomegaly, pancytopenia, old age. Sumit is stuck again. He is now saying you have neutrophil discrepancy. So I'm getting 77%, automated is 43. 30 difference versus a manual count and automated, too much. Again, the whole point is understanding the machine. Our machine ka principle kya tha? Myelocorrection. So that's so differential. Peripheral is actually showing 77%. Look at a smear, you got pseudobar bodies, nuclear abnormalities, hypogranularity. This is MDS, myelodysplasia syndrome. These are hypogranular cells. If you're deficient, so your machine is not picking them. So machine is not wrong. It has actually gave you a diagnosis of probable MDS disease. Please slide more. So a lot of PGs and sometimes faculty will look at मेरे ये तो 5 part का बता रहा fancy मेरे पास तो 3 part है. So let's look at it. What is the answer? हाँ. तो यहाँ पर if it's a 5 part and 3 part के पास फिर भी बाकी सब नहीं है. फिर भी एक चीज है impedance. Impedance will still give you a lot of answers. Let's look at that quickly. 2 peaks, predominant peaks. Imagine them on a 3-part histogram like lymphocytes and granulocytes. And that's a mixed population. जो नीचे trail करता है. Imagine acute leukemia as the Everest. That's it. No 2 peaks, 1 peak. If you do this, you'll pick up most of the acute leukemias even on a 3-part very well. So let's look at this normal. So your granulocytic peak, everything corresponds there. This is normal again. What happens now? Single peak. It has broken the boundaries of 2 population, 3 population. Another one, single peak. Maybe across zone for single peak. So left versus right, right one appears larger cells, volume wise. So just to summarize, that's normal. This is an ALL. That's an ALL. Smallest blast to the left side, almost like a 5-part scatter low down. Larger blast to the right side, almost like a 5-part scatter up. Hardly any granulocytes, predominant in the lymphocyte peak. Look, Everest, but in its own zone, very important. The Everest of acute leukemia will break the zone, it will go like this. It is still in the lymphocyte zone, which means normal like lymphocytes to the high is CML. So in CML, what do we expect? Granulocyte, but why now? Left shift cells. Is this a single peak? No. Very important. So look at this. Lymphocyte peak rises and falls a bit, then joins the granulocyte peak. This is very important. Single peaks will break boundary, break these zones, and then form a single peak. So chronic leukemia will not give you a single peak, although it may look like. Acute leukemia definitely will cross the monocytic and show you. That's a CML CT. And what is this one now? Still CML, but something has joined now. CML in blast crisis. Imagine what we picked up with a 5-part, 3-part species. The same information. Now is it a single peak? Yes. But there is an important ones. So jackpot. If you have a 3-part, how to convert it to a 5-part? If you have a 5-part, how to make it to a 7-part? All I want is join this 2-part analyzer. This. Analyze your data well, so you will get most answers. I asked before coming, I asked ChatGPT, can WBC scatter plots replace the pen from here? Very intelligent answer. It says no. These are screening and flagging tools, not a definite idea. So anyone thinking, yeah, answer it, please see this video. Very, very important. So I'll conclude with pattern recognition. Most leukemia you can suspect, some you can diagnose. Chronic leukemia is easily suspected. APM has signature pattern, very correctly stated. we need to be aware. Pathologists need to be aware, but I'm very disheartened to see pathologists need to be aware. Very, very important information lies there. And be the friend of your family. Thank you so much. Sorry for exceeding time.
Thank you, sir, for such a wonderful talk. Sir, I have one question.
Yes.
It was GPML with the TLC or not?
Yes.
Usually in GPML, we get TLC growth.
Yes.
What will be the scatter drop in that case? Will it be similar?
See, when you get a TLC low, sometimes, so for the PG resident, very valid questions. I picked up this case because the number of dots would be more. The high TLC. We do get it in India compared to the West. We do have a significant population of high TLC areas. Right? So important to realize that. Sometimes your faggots are least in these. They're just hypergranular, looking weird and all that. So if your TLC is low, quite often there is a possibility your abnormal promyelocytes may not be that high. If you're dealing with a 1200, you may have 3 promyelocytes. Your marrow will actually fit in. So if you run a marrow on the analyzer, you'll get these values. But so it depends on the number of abnormal promyelocytes you see on your smear. If they are 20, 30 plus, you get these kind of patterns, even with the low TLC. Your density of dots will be less, but the pattern will be.
Sir, fabulous talk. In fact, all your talks are so wonderful and so mesmerizing and so basic. Sir, I had developed that interest in 3-part analyzer, and Dr. Deepa would remember she was doing her post-graduation and I was her guide. So I started reading these 3-part instruments, sir, and I found a wealth of information है. और एक पॉइंट ऐसा आया सर कि मैं देखता था वो हिस्टोग्राम जो था, एंड आई वुड आस्क माय रेजिडेंट स्क्रीन है या नहीं है. उसने कहा नहीं है, तो मैंने कहा डॉक्यूमेंट्री क्वेश्चन है, और अगर है तो CML है. इन फैक्ट आई ट्राई टू डिफरेंशिएट इवन एक्यूट ल्यूकीमिया कि अगर आप देखिए ALL है सर, तो मोनोमॉर्फिक, यूजुअली अगर L1 है तो मोनोमॉर्फिक पॉपुलेशन हो, और अगर AML है तो थोड़ी सी शिफ्टेड और ब्रॉड होगी. Those very fine points. So as you told that a 3-part analyzer can also give you a wealth of information, and we should not be suffering from inferiority complex. कि नहीं हमारे पास 5 part नहीं है. In fact, what I found out, 3-part is very robust. और जहां 5 part हाथ खड़े कर देता था, वहां पे भी 3-part बना रहा था हिस्टोग्राम. So wonderful presentation, and Kevin, whose message is very loud and clear. You can derive a wealth of information looking at the numeric data and the histogram.
Excellent presentation, sir, as always. So I just have a question and a comment. One of my residents presented an old paper yesterday, and what we had done is that we had compared 2 analyzers, A and B, for blast flagging, the sense and spec for the blast flagging. So we had collected about 90 to 100 samples, and one analyzer gave a sensitivity of 90% and specificity of nearly 90%, while the other had a sensitivity of 100% and specificity of only 10%. So in a lab where we have to decide the slidable criteria, we're using a 100% sensitivity or making a lot of sites which are not required, whereas for the other one, there is a balance. So what are your thoughts on that? How do we work around that? The other thing is that when this was being discussed in our department, then one of our faculty said that this should not be presented and this should not be published because there could be no legal issue with it. How close is that? We are all scientists and we have to work around it.
I don't see any legal issue with science.
Yeah, that's what my take for that.
Absolutely no problem with that, because you propose something, works, may not work, but if you're signing out a report based on something like this, it can matter. But a legal issue is too fast-paced, which is probably somebody trying to stop you from it. Happens. So we don't deal with analyzers and cells, we deal with egos also. Yeah. So your first point, to me, your blast flags or any flag, blast flag is really vital, you know that. Other flags can availability. To set it up, we can't rely on the instrument fed data. So you have to work on your population, seeing smears, lots of blasts, and then decide on your blast. So you may get usually a LUC cutoff of this was 68%. Beyond that, you will get a flag. So if you work out in your population, your kind of cells, your kind of staining, what are we getting? You will have to work with the application engineer to derive the ranges for a cutoff for your blast, so that only at this point are they flagged. That is a lot of work for validation.
Yeah.
So what we do is usually work on samples. So even when we say इसमें blast नहीं है, but even that is a patient sample, right? So that patient would have some triggering of something, some infection that even makes the granulocyte or the lymphocyte a bit reactive. We can't see that much on morphology, but the instrument will pick that up, and probably that cutoff will go higher. So sometimes they will include things which are not to be included. Sometimes they exclude what is vital. So this, to me, the answer is lot of thousands of samples validation in your lab. Then to set, okay, our cutoff of this is this. They usually have a 0 to 300 that range or whatever the machine you're using. And you can tell the application now set this block flag threshold to this. Then you will actually start getting what you want.
Oh, thank you.
Thank you, sir.
Thank you, sir, for that enlightening talk. Now we turn to pediatric marrow, where interpretation demands both expertise and sensitivity. So for this session, I would like to invite our respected chairpersons, Dr. Rashmi Kushwaha ma'am, Professor, Department of Pathology, KGMU, Lucknow, Dr. Surabhi, Additional Professor, Department of Pathology, AIIMS, Patna, and Dr. Parichay Singh, Assistant Professor, Department of Pediatric Oncology, MPMMCC, and HPCH, Varanasi. I'd like to kindly request the Honorable Chairpersons to introduce the speaker.
Thank you. So the next speaker for the talk is Dr. Savitri Singh, and Madam is Professor at the Institute of Postgraduate Institute of Child Health at Noida. And her areas of interest are hematopathology with special interest in coagulation disorders, cytopathology, and flow cytometry. So she has a good number of achievements in achieving the Best Oral Presentation Award, International Conference on Hematology and Blood Disorders at Dubai. Former specialist at Ministry of Health, Muscat, Oman. She was former HOD and at the Department of Pathology, PGICH, and in Andaman. And she established hematology and specialized coagulation laboratory at PGICH. She's an integral member of the BMT team, instrumental in initiating UK NICOAS as in Noida. And her total publications are more than 50. So over to you, madam, for this interesting pediatric bone marrow cases.
सबसे पहले मैं अपने आयोजकों का धन्यवाद करना चाहूँगी, स्पेशली डॉक्टर विजय तिलक और डॉक्टर दीपा रानी, मेरे सीनियर्स का डॉक्टर सर, मैडम जस्मीना और बाकी सारे मेरे स्टूडेंट, आप सभी को मेरा आज का अभिनंदन। मैं समय की सीमा का ध्यान रखते हुए अपनी प्रेजेंटेशन को सीमित करूंगी। I have prepared this presentation keeping in view our clinical fellows, our teachers, and few cases for faculty and very few for senior resident and junior residents. So I come from a pediatric institute. So it's sorry for interruption. Our institute is standalone institute in Uttar Pradesh. It has got a well-established pediatric hemato-oncology department, pathology department with 24/7 hematopath services. We are doing routine hematology, special hematology, flow cytometry, histopath with ISC, cytopath with ICC, and coagulation lab with extended workup for hemophilia. So this is our little bit data for past few years, and we have little bit rising trend for our bone marrow aspirates. Marrow biopsy as well, almost less than 5% cases, all the cases we get bone marrow aspirate as well as biopsy. Then annual, we get quite a lot patients for leukemia workup, and this is last our 188 new annual registration of childhood cancer at our center. Now coming to marrow, we all know that pediatric marrow and adult marrow is certainly common and pediatric marrow almost 100% cellularity. But on the age of 15 years towards 18, and by the age of 25 years, it attains age-related changes and becomes more or less adult marrow. That's trabecular bone loss and increased fat. And reticulin collagen increases with age and decrease in cellularity and synthetic function starts at around 5th to 6th decade of age. So all these things should be kept in mind when we are interpreting marrow of adult or pediatric patient. So indications at our centers are mostly anemias. Other than that so-called common aplastic and megaloblastic, there are other forms of anemia also which can be diagnosed. Then mostly IBMFs, storage disorder. Leukemia is the major chunk at our center, and staging for lymphoma, solid tumors, miscellaneous cases can be picked up like HLH and follow-up marrow after chemo and post-BMT. Then there are a few points which I would like to highlight at this forum, that is pediatric marrow. Who should be doing marrow? Our aim is to give the correct diagnosis and adequate sampling has to be done. And for that also we have to have marrow. Maybe you need molecular workup and flow. So marrow has to be appropriate. Then of course bone marrow aspirate to look for more. And then biopsy. Biopsy for not necessarily we might get 1.5 to 2 centimeters in all the cases. But even if we get less than 0.5 and we can still make diagnosis. So if at our center clinicians are doing marrow, so then we no longer can say कि marrow अच्छा नहीं है and we can't give report. So it is coming perfect. So mostly we are able to do our reporting. Then setup for emergency medication has to be there because while doing marrow also problem can arise. So if hemoglobin is 3 or something like that, prior BT has to be done and monitoring while doing procedure is on. Then requisition form is to be filled by the resident, what we get in BMA, BMB, and imprint smear are always prepared because they are several at times. We are getting something inappropriate or like it's not proper in marrow and bone marrow biopsy, yet we can make diagnosis by imprint. And processing in lab has to be done perfect without any lacunae. And there are certain changes like cellularity of marrow is much more higher in pediatric marrow, and we get more of a lymphocyte as a normal constituents of marrow. And of course, hematogones also can be seen. So prior knowledge, these things are important for reporting pathologist. So now we come to our case. Case number 1, 6-month-old female born out of non-consanguineous marriage. Second baby, sibling healthy. First infection occurred 5 months. And that culture was positive for Pseudomonas and Enterobacter TB. Then there was platelet perforation and Candida albicans. Then this is CBC. Hope we can appreciate in CBC. Previous talk was elaborate about our this thing, scatter plot and all. So now we can see in CBC, we only see hemoglobin, TLC and platelet. I would emphasize here that we have to have the habit of seeing absolute count for almost all. So here we see ANC is very, very low. It's 29. So for an infant, ANC cutoff is less than 1000, and for childhood, it is more than 1500. So ANC is very low here. Platelets is okay, and hemoglobin is also low. So looking at the very low absolute neutrophil count, other causes for neutropenia were ruled out, and then further it was decided to go ahead with marrow. Marrow, this is the marrow showing the normal maturation, and this is the marrow from the patient where we don't see any stem cell, no neutrophil, even only occasional myelocytes. And there are no neutrophilic series. So it was thought that this is maturation arrest in bone marrow. Later on, keeping in view clinical presentation of the patient, palatal perforation and infection, and marrow having more myeloid maturation arrest, molecular was sent and it turned out to be alien gene mutation and severe congenital neutropenia was the main diagnosis. So a little bit about neutrophils. We can see the neutrophil in our left picture and we can see the maturation from blast to promyelocyte to myelocyte, metamyelocyte band and neutrophil. In certain infections also we can get maturation arrest, but that usually happens at the level of metamyelocyte or band cell. And of course, if because of infection, we might also see cytoplasmic reticules, toxic granules and other features so that we can corroborate the finding and we not go for molecular in all the cases. So now this is a simple algorithm for classification and isolated neutropenia. In that they have given it could be syndromic and it could be non-syndromic. If it is syndromic, then we have to have features of some syndrome like SDS. We can get some pancreatic insufficiency and others. And here in our case, no, they're finding only the neutrophils were where ANC was very low. And other than that, non-syndromic, we can have severe congenital neutropenia. Prior to going for all this thing, we have to rule out other secondary causes like drugs, exposure of drug as well. Then age, neutrophils, age depend upper limit of normal is newborn period 7,000 to 13,000 per micrometer. Then children 8,000, this is normal, adults 7,500. Neutropenia we call less than 1,500 in a child and less than 1,000 in infant. So for workup, we would be doing defects in marrow. So we'll be doing bone marrow. There can be bone marrow failure syndrome. Neutropenia can be part and parcel of that. Or it could be syndromic like SDS. Then there are cyclic neutropenia, myelocatechosis, Will syndrome, and reticular dysgenesis. Then for evaluation, as I said, we have to think in terms of infection, drug exposure, significant family history, physical abnormality, LAP and all we have to see. And then based on that, we will decide what next we have to ask. We can't ask a high-end test in each and every case. So this is again showing that neutropenia. If it is neutropenia syndromic, then we will be working for something different. If it is non-syndromic, then we may go ahead with marrow and try to do further work. So in this, we can show that the granulopoiesis is defective here in neutropenia, and the most common is alien-associated congenital neutropenia, which was our case. Then we go to our next case, 2.5-month boy. Fourth child born to non-consanguineous marriage, 3 elder sisters, no significant family history, fever since 5 days, cough and fast breathing. So cough and fast breathing, like there are chances of URI that we'll think first. So, and other important finding was hair blonde, brown color and hepatosplenomegaly. And provisional diagnosis was thought of some viral infection because of the cough and other things. Chest X-ray showed perihilar infiltration present bilaterally. Dengue and blood culture, all other tests were negative. So possibility considered at this stage was malignancy first, storage disorder second, infection, EBV and other things, and HLH. In view of fever with HSL, further patient was evaluated, hemoglobin was low, ANC 567, which was low, and platelet count 75,000, allowing extra case of encyclopedia. Peripheral smear showed only increase in monocytes and atypical lymphocytes. Platelets were low, no evidence of any hematological malignancy. So when bone marrow was sent to us, bone marrow showed hemophagocytosis. In the macrophages, we can see neutrophil, and in upper left picture, sorry for the quality, but this is original. And the down one, I prefer to do this thing, hematoxylin is staying in all marrow. So that gives very good picture, and content also can be seen very well. So this was hemophagocytosis, having lymphocyte, neutrophils, and other cells within the macrophage. So considering the presence of hemophagocytosis with fever in splenomegaly, further workup for HLH was done, and these are the findings. Ferritin, TG, fibrinogen, these findings are there, and based on that, we had thought we have to see clinical presentation also into account on do fertility. So till now it's HLH. Diagnostic criteria is entered all to 004 and not take time for them. And further workup for familial HLH was done. Suspected familial HLH in view of early age hypopigmented hair, initially mildly hypopigmented hair, which gradually increased to almost all the hair color became blonde. Hair mount examination was also done, and irregular distribution of melanin clumps were noted. Here showed no granules in neutrophil, and clinical impression with all these findings caught up. Now it looks we are heading towards pre-series syndrome with HLH. Then further workup was done, and RAB27A gene was found missing. This is the picture of the child when he was small. This is almost all the color of the hair became like that. Hair mount examination. First one is normal, and the last one is the patient. And this one from Kashi syndrome, which comes in close differential. So Grisely syndrome, rare autosomal recessive disorder, pigment dilution of skin and hair, cellular immunodeficiency, uncontrolled T cell activation, accelerated phase, and neurological abnormality. The child was managed with steroid, and there were exacerbation of fever, and condition was deteriorating. And in the last, he was pursued for BMT because that's the only treatment which can cure it. But the child could not have been saved, and he developed in CSF also this thing, hemophagocytosis. Child did not survive. So final diagnosis of the case was pre-series syndrome. Then come to third case. 5-year-old male presented with a 3 months history of pallor. Clinical examination revealed clubbing, pectus scavatum, genuvarum, with no HSM or lymphadenopathy. Here I would like to tell you, when we got marrow, these findings were not given to us. So I request my clinical friends that when you are sending marrow, please be helpful to pathologists. Send what all you have if you feel that you will get the correct diagnosis. Because we were worried, where are we doing? We are not able to fix the diagnosis. CBC was done, hemoglobin was 5. And this hemoglobin was always low in spite of all kind of hematinics therapy, and the workup for anemia was done. Did not get any significant finding. Leukoerythroblastic picture with a few hypochromic cells along with normal cells also. BT was also done, so that would be. So leukoerythroblastic picture with HB low. We thought we are dealing with some myelophysic anemia. Then this is the serial CBC follow-up. And somebody in morning talk emphasized the value of serial monitoring of the cases. So at times we get insight into our diagnosis when we see serial this thing. So these are the bone marrow findings. It is hypocellular stromal edema. Marrow was hemodiluted only here and there. Few NRBCs were there. These are again bone marrow biopsy findings, stromal edema, and some fibrosis and patchy in this hematopoietic cells. Then molecular was done. We had consulted our genetics department. We are dealing with the case and we are not able to make the diagnosis. And this all X-ray and all was given later on. So while seeing X-ray and the kind of serial monitoring count in bone marrow, he said we will order for one test, and he had asked for this NGS panel for some particular disease. And then we got this. PBX-A1 and sorry. This is Ghoshal diaphyseal dysplasia, first described by Ghoshal et al. In 1988 in 5 Indian patients with refractory anemia with skeletal dysplasia. So I'll not read much because we are running short of time. It may mimic myelopathic anemia and should be considered in differential diagnosis when evaluating refractory anemia with skeletal changes. So learning point from the case highlights the critical role of bone marrow aspiration and biopsy in diagnostic workup of Ghoshal hematodiaphyseal dysplasia in patients presented with refractory anemia with skeletal abnormality. We should keep this in mind when we are dealing with a child having refractory anemia and bone marrow having hypocellularity and fibrosis, and we have ruled out other usual causes what we come across. These are a few references. Then we come to third case, 3-year-old child initially presented at the age of 1 year with the consanguineous marriage history and the history of elder female siblings' death due to intracranial hemorrhage at an age of 3 years. So there is some history of bleeding in the family. So we have to keep in mind when we go further. This is the CBC graph having ANC low. I think it's 493. ANC is low, hemoglobin also low, and platelets. So it's again pancytopenia. In PS, we could see only few scattered platelets. In marrow, we could see patchy foci of erythropoiesis, and neutrophils were there. And megakaryocytes here and there, they were seen. And these are on high power view of the megakaryocyte, which were there, but they were not developed and they were poorly formed megakaryocytes. So then I tried to read what is the cause of this, why we are getting this ill-formed and very few meg. Even in biopsy, we saw cellularity was patchy, but the meg, what we saw prior was catching something fishy, which I have not seen earlier. So then we went further and we wrote in our bone marrow biopsy report in view of occasional meg with poorly formed morphology. And in view of history of the patient, we should think of congenital constitutional thrombocytopenia. So further workup was done and it was found that it turned out to be congenital amegakaryocytic thrombocytopenia. Now we go to next case. My time is running short. 4-month-old child and another 13-year-old female with this CBC. Bone marrow was done. And we saw in aspirates was diluted, but then still we can see these cells arranged in rosette-like structure, and centrally some pale pink eosinophilic structure is there, and that gives reminiscence of some rosette formation. Then this was the biopsy. Biopsy is hardly anything is normal in this bone marrow biopsy. And on high power, we can see all the cells appearing, small round cell and some molding. And from this also we can make our mind that we have to further do ISC for neuroblastoma, and it turned out to be neuroblastoma. Another case, 8-year-old male, the child came from Allahabad for some 5 months. He was on ATT, had cervical lymphadenopathy and HSME. And when came to us, we saw bone marrow biopsy was sent to us and aspirate. PS did not reveal much other than anemia. And bone marrow aspirate showed these cells, hemodiluted again, but these cells having some resemblance to what we call Reed-Sternberg cells. Then another cell which appeared monstrous like, very big in size and having prominent nucleoli. And when biopsy was done, we can see single Hodgkin cell with prominent eosinophilic nucleoli there. So diagnosis, further ISC done and confirm HD, Hodgkin lymphoma. This is a case came with cytopenia, and marrow was sent. CBC was not sent to us, said it's pancytopenia. Clinically, they thought would be leukemia or maybe aplastic evolving. When I saw marrow, again, we could see this hemophagocytose cell having clearly in a cell, we can see some platelets, some lymphocyte and other cell within the macrophage, and so the pancytopenia could have been explained. Then I asked, I want to see PS because I can see some brown pigment within the neutrophils and other cells. Why there is dysplasia in marrow? So we saw PS and we saw that there was MP. So this was malarial parasite associated with HLH. This is another case. I will take only 2 minutes, sir. I'll just rush through. 5-year-old male with consanguinity in parents. Previous sibling death presented with massive splenomegaly and neurological normal. So this is a low part view of our bone marrow biopsy. I hope my PGs can make out the diagnosis. Almost all the cells appear histiocytic with foamy cytoplasm centrally or little bit centrally placed nucleus. Yes, anyone now? It's so clear. Foamy cells, foamy is something to form something lipid or like that, fatty. And then PAS was done and they were positive for PAS. And now this was further analysis done and confirmed it was Niemann-Pick disease. This is a very interesting case. 1-year-old female with fever and pancytopenia with bleeding manifestation. Possibilities again with that we think of only Luke only. This is high-power view of the same. I hope we can make out almost all the malignant cells have centrally placed nucleus. That is one catch for diagnosis. Then cytoplasm is ample amount, bluish, some peripheral and perinuclear distinction is there, and vacuoles in variable size and collapsing with each other is there. And that's what how we catch about think of that rare is erythroleukemia, that is M6. But the PAS was done, which will give you log-like or maybe diffuse positivity, unlike like ALL blast where we see small dots. It is different from that. So it turned out to be M6 on flow also. So the flow was not done at our center, it was done outside. Then another important case, this case will highlight the importance of seeing peripheral smear carefully. Even one cell in PS can give us what is the clue. So in this PS, we can see that arrow, some erythroid cell with subtle indentation or what you call erythroid cell appears dyspoetic in first thing. Then second smear, I could see some cell which was appearing tri or four load. I thought this is something, even if it is one, it is giving me some clue where I am heading for. Then another dirty smear, but then red cell, and it was, and even now, then this for imprint, I actually like to emphasize that imprint are the most important treasure in our bone marrow aspirate examination. If we stain all our imprint, we can get diagnosis. Even cytochemistry also we do on imprints only. For clinicians, like shaky come na pade, all the jaldi diagnosis de de. So what we do, we try to utilize that. Same for further if we have to do further. So here in imprint also, I hope we can make out on top some YBO or double shaded cells. Then this is biopsy and reticule was high in this. Molecular confirmation was done that it was CBA type 2. And when we get fibrosis, there is one variant CBA type 2, SEC23B, where we can get even fibrosis. Need to differentiate from IIIrd. Then this is another case I just written fast. This case I could not solve, so I have put it here. You can see what necrosis in the marrow. And these all fibroblast like cells in between hardly any hematopoietic cells. So then we see the area we can make out this necrosis. And these hypocellular areas like you see in CNS lesion, and then some cellular area, all of the marrow was like that. and patient had bilateral backache and bilateral leg weakness for 15-20 days. And unfortunately, we could not, by the time we could think of doing what next, patient could not survive. And later on, when they came to collect their certificates and all, they said, बच्चे को कुछ CNS में tumor था, हमने पकड़ नहीं पाया और बच्चा का death हो गया. So it's better if we have any leg pain or back pain or something persisting, we should ask for MRI or CT scans so that we can further put ISE and fix it. So this diagnosis we could not make. I regret not having done justice with the patient. This is, I think we can make out. This patient has some granuloma in the left. This thing we can see in bone marrow biopsy, epithelial cell granuloma. After seeing granuloma, CBC, monocytosis, we told our clinician, please get typhoid test done, and it turned out to be typhoid. To begin with, only bone marrow aspirate and biopsy could have been avoided. But when somebody said sending, we don't say what happened there. Last time, I think this is one case, 1 year female with pancytopenia, and there is this one PS not very good, but PS has only one class in this PS, and that's dog, and they are bluish in color. Nothing else, and one NRBC that's also not very good. It's almost all the cells are having bluish surface blast, which are too blue not to be missed, right? So by seeing this, we can think of some particular entity, and it was actually M7 on pro-saturated. Honestly, I did not pay attention that time, so I thought what all I have not. I should just see. This is one imprint, just like that. It's followed case of NHL. So it's not necessary that when there is infiltration, we will not have any other normal cells. Here we can make out beautifully stained legs. And in between, there is a lot of lymphoid cell infiltration that was actually NHL. This is again an imprint display. And this is my last slide. Anyone? PGs? It is showing everything neutrophils, band, and the other cells of hematopoietic. And one in the center is megakaryocyte. But then what is that megakaryocyte? Something serpentine. They are proplatelets. Sometimes some snake-like structure may traverse and they will come in circulation, and then we can see them. So that's all. This is actually one child having all the cells in a marrow. They should be there, but disease is taking out. And special thanks to my pediatric hemato-oncology team and Dr. Neeta Krishnan, my department colleague, my staff, Monica, Mayank, and Prashant, who helped me making.
Thank you, Dr. Savitri, for the wonderful cases and the wonderful presentation. And it's very important to evaluate the peripheral smear, because peripheral smear is the marrow mirror of whatever is happening in the marrow, and it will give you a lot of clues. So we can quickly take up 1 or 2 questions.
Question, but comment to follow up what Dr. Ashmi said. Peripheral smear, very, very important. Never to forget. And it is, when you have marrow, do not rely on a CBC done 5 days back. The same day, the marrow day, the CBC should be part of the report. Second, picking up on your first case, the neutropenia, although this is a child, but it is now relevant in India. We were stuck, so I'm sharing this so that somebody else is not. We got a referral from engineering university for screening the medical students, 38 students. This was in 2014. And university outside we didn't know, but when I saw the reports running through, PLCs of 3,200, 3,900, 2,800, 80%. Then I saw the names, Bangwa something, it was African. So remember, we have a lot of African population in India now studying in universities. One day, some of their samples might come to you. So there is a condition called benign ethnic neutropenia. So for their population, this neutropenia was normal. They were tested for SBS, HIV, everything. HIV was normal, all of them. So we were stuck wondering, kya ho gaya, machine ko kya ho gaya, ye ho. Once we read up, we found this out. Important to look at the context since we are having a population of African students in many universities. Thank you. Excellent presentation. Cyclical is cyclical, as the name suggests. That was a common. Yeah, so this is ethnic. So in their community, this was all 38 department students, except for 7, all of them had hysterectomy. Asymptomatic, no fever, nothing. No evidence of all.
No, thank you. Thank you. A good series of presentations. 2 points. One was on the case that you showed as necrosis.
Yeah.
It was a child with bone pain and severe thing. Yeah, so keep always ALL in your thought. We have seen cases of acute lymphoblastic leukemia which undergoes spontaneous necrosis. And IHC is helping. We published also, in fact, just last week, Dr. Tejinder Singh showed me one of his cases. Total necrosis, somewhere in the focus, we found a focus of blasts, applied TTT, applied CD10, flow was negative because most of the cells were necrotic. So IHC helped, and we have published it also. ALL is one which mimics like a juvenile arthritis. Children are there with severe bone pain. They roam around and they go pressure. This is one thought. And secondly, like you talked of the cyclic, the benign neutropenia. We also have something like benign thrombocytopenia, the Harris syndrome. The entire Bengali Assamese population, it's normal to have a platelet count of about 1 lakh, 1.5, 95, and they are functional platelets. So these ethnicity and the regional background, we must always keep in mind when we are. Thank you.
Case, bone marrow escape was having only neutrophil. Eosinophilia, TLC showed neutropenia, and there was no blast in PS.
Okay.
And
generally with necrosis, you get severe pancytopenia. Severe pancytopenia. That's what peripheral smear doesn't show. Bone marrow aspirates fail because it's necrotic. Somewhere in the focus of the biopsy, we have been able to pick up. Yeah. Okay, maybe then it may not have been metastasis. It would be a case business. Yes, thank you.
Yeah.
So your case of AML and 7, that 1-year child was in the case of Down syndrome.
No, it was not. It turned out to cancering. It was not. I missed it because that research that thought we just wrote acute leukemia and the possibility of this. It was not straightforward, but now if I had even M7, it could be fast then and there.
Was there any vacuole or vacuolization anywhere on the film?
In some case.
Yeah. Now, in this case, the child who died, hypocellular areas, hypocellular were hypocellular.
लास्ट में हमको किसी को मतलब
CBC biopsy
Yes, ma'am. Thank you.
Thank you, ma'am, for this wonderful talk. I have one question. Ma'am, from here, many times we get cases of anemia, they get transfusion outside, then they get to the hospital. So in those cases, how many days should we wait for changing a peripheral smear? Because you said that blood transfusion will affect smear, still even working for anemia.
We have to have each CDT scan. That's it. Ideally, we should, in health case, we see prior transplant can do. But in this, we can't, then we have to make a mistake on bone marrow training.
So thank you. We'll end the session now. Thank you, Dr. Savitri.
Chairpersons, thank you, ma'am, for that convention. So now we come to one of the most distinguished moments of this session. To comment this prestigious Professor Ashutosh Kumar audition, I would like to invite on stage Dr. Rashmi Pushpahar, take the dais and invite the auditor and dignitaries.
Very good afternoon to all the faculty members and delegates present over here. It is truly an honor for me to stand here today and introduce a person who actually does not need any introduction in the field of hematopathology. So we have gathered here today for the oration lecture in the name of late Dr. Ashutosh Kumar, a stalwart in the field of hematopathology. He was a visionary who played a fundamental role in establishing and advancing the field of hematopathology and in setting up the hematopathology unit, a department of pathology, KGMU. So the lymphoma leukemia registrar, the population lab, and the general hematology lab at KGMU was established by Professor Ashutosh Kumar. He was my mentor, my teacher when I joined KGMU in 2009, and he guided me till 2019. He was a guide, a teacher for many of the students who have passed out from the KGMU Department of Pathology. Through his tireless dedication, pioneering work, and deep commitment to patient, he laid the groundwork for what we now recognize as a thriving and evolving discipline. He was not just a brilliant hematopathologist, but a mentor, a guide to many students, and a compassionate human being. Dr. Kumar's dedication to building and nurturing the field of hematopathology is unmatched. He poured his energy into creating systems, mentoring young doctors, and ensuring that patients receive the best care possible. So I'll just take you through this journey. He graduated from King George's Medical University in 1977 and completed the MD in pathology from KGMU in 1979. So this is a very old picture which we could get, and you can see this is Ashutosh Kumar here, this is Dr. P.K. Agarwal madam, this is Madhumati Goyal ma'am, U.S. Singh sir, and the thin and the lean girl is Dr. Nusrat Hussain. Next mirror. This is a very old photograph.
60 minutes. Okay.
Sir was appointed as lecturer at MLN Medical College, Allahabad in 1982. And then he rejoined KGMU in 1983 as assistant professor. That is the time when he established the hematopathology unit. And eventually he served as a professor and head of the Department of Pathology until his retirement in 2019. He was interested with the key leadership role. He was Dean Faculty of Paramedical Sciences from 2014 till 16 and Dean Faculty of Medicine from 2016 till 18. He was a renowned expert in hematology with focus on anemia, leukemia, lymphoma, coagulation disorder, and the stem cell research. He was instrumental in establishing the coagulation laboratory at KGMU. During his initial days, he used to prepare the PT reagent using the extracts of the brain obtained from the mortuary. And he was really involved in development of the coagulation lab. He was actively involved with the Hemophilia Society in Uttar Pradesh and in Lucknow, and he used to actively participate and help the hemophilia patient by going through various camps and getting the samples, doing the inhibitor analysis, the factor assays, as well as counseling on the patient. And I still remember that one of the patient who was a regular visitor to the hemophilia camp, he qualified the NEET and took up MBBS at KGMU. And sir sponsored his studies for throughout the 5 years. He led and contributed to numerous outreach programs for the hemophilia community. He visited Sheffield, UK as a fellow of the Hemophilia Society for the coagulation training. He organized various conferences and CME during his tenure at Pathology Department KGMU, and he had many numerous publications to his credit, numerous book chapters which were published. So other than the academic career, he was talented in painting, cartooning, music and crafting work, and he loved picturing the flowers and taking the photographs of the birds. And very often during the routine reporting time, he used to show us that, okay, this is a bird that I saw today morning. And he used to click the photographs. So he was deeply passionate about history, archaeology, anthropology, and general knowledge. He embodied humility, compassion, and empathy in all the interactions, revered not only as a brilliant academician, but also a deeply caring mentor. And yesterday only we were discussing with Dr. Tripathi sir and Dr. Tilak sir that how he guided so many students, even those students who were not directly his candidates and they were candidate of some other faculty members, and he guided them for the thesis. These are some of the photographs where we are celebrating his birthday at our department. And when sir was diagnosed to have CA, we used to visit his house, and not only that, he very often used to ask, "Are you getting any interesting cases in the laboratory? If yes, please tell me." And he used to come to the lab that time also, whenever he got time to see those slides, to discuss the cases with the students. And these are some of the photographs from the department. And sir lives in our memories and hearts. So with this, I would like to invite Dr. A.K. Tripathi sir to CV of Basu sir.
It's honor for me to introduce Professor Devatta Vasu, who is Professor of Pathology, MGM, CRI, Puducherry. He's former Professor and Head, Department of Pathology and Department of Transfusion Medicine, Chipman, Pondicherry. He did MBBS from Maulana Azad Medical College, New Delhi in 1985. MD in Pathology from the same institute in 1990. He's Fellow of Indian College of Hematology and Fellow of Indian College of Pathology. His area of interest in medical pathology and medical education. He has several awards and honors. Some of them are Tamil Nadu and Pondicherry Position of Annual Conference of IIPM. Position in the Karnataka chapter, Northeast chapter of IIPM Chhattisgarh. Member of National Medical Council. And he was involved in the revision of MD Pathology curriculum 2023. He's president of Puducherry chapter of Indian Society of Hematology and Blood Transfusion. And he has 241 publications. With this, we request to proceed.
I would like to invite the other chairpersons for this session. Sorry, I missed out initially. Dr. Jasmina Aluwalia, madam, and Dr. Naveen Bharat on the stage. Handing over the mic to the
Thank you very much, and it's an honor, absolute honor to be here, deliver the oration. Could I have the first slide?
वही चला जाएगा
Same that on the screen. Should I do this? Yeah. All right. Statement bring around our innovation. This poem by Robert Frost has been a part of my journey throughout. The road not taken. Two roads diverged in a yellow wood, and sorry, I could not travel both. I think that's a part of all of us. And be one traveler, long I stood and looked down one as far as I could to where it went in the undergrowth. Then took the other. Then took the other as just as fair and having perhaps the better claim, because it was grassy and wanted bread. So as for that, the passing there had borne that really about the same. And come back to this poem, and it's about my journey and the crossroad into, and all of us have that, what career to choose, why pathology and why hematology. So, moving to this. All right. So this will be the oration that I'm going to do. I've met Dr. Ashutosh Kumar in my previous times. Real humility that I talk about walking the heme path, blood, marrow, and beyond. It's a story that I'll tell you, and as a story, there will be some contents. The chapter 1 would be my gratitude and acknowledgements. That doesn't end, so you'll find that everywhere. At an MBBS level, why did I choose pathology? And more important, coming to a level where we are now seniors, what could we do to make our undergraduates more aware of pathology as a career? Chapter 3 would be my residency in pathology and traveling along hematology, how to make it worthwhile, and how to choose our subspecialty. And now as a faculty, what difference do I use? So acknowledging first and foremost my parents and my parents-in-law, my wife who's a rock support in everything that I do, my son, my daughter who's here in the audience today, and my daughter-in-law. So it's a small family of 5 that we are, and we thrive each other. At this point, I'd also like to thank and acknowledge my school teachers, though I'll not talk much about my schooling, and move on to when I joined pathology, when I did my MBBS, and when it doesn't feel right, no, let's go there. And that was the point in Maulana Azad Medical College. We were graduating. And I think all of us at that point of time are wondering as to what will happen. And we are in this situation. Lost, confused, unsure about what path we're going to take. I'll begin as to why I considered pathology at all in my 5 years of undergraduation with these 2 little stories. The story of my tutorials. We used to have a batch of 180, and to accommodate 180 of us, 1 hour we would be sent to the tutorials, and the rest of them would do the practicals, afternoon twice a week, and then we would scrub. So, and tutorials then those days were taken by the senior people. Heads of the department and faculty would take tutorials for the students. And one term, my tutorial teacher used to make us present topics. The only criteria was you cannot read your standard textbooks. You have to find out material from textbooks, elsewhere books. Those days, no net. So it meant at least a definite walk to the library, hunt out books. And there I came across one of my topics that I had got was metastasis. And I came across this book by R.A. Willis. I hope all of you know. We still follow the definition of neoplasia of Willis. And this was the book through which it gave me an idea as to a world beyond my textbooks, beyond that. The next term was even worse, or I say better now, because the other faculty who take our tutorials, his thing was that we had to ask him a question. He won't ask us any questions. Of course, we would ask him and we had to answer. That's a different matter. But what it meant was lunchtime, all of us, 15 of us in the tutorial batch would allot questions to each other and read. So we got into the habit of reading that book, not just for the sake of passing an exam, but for the sake of that. That's how I imbibed power. Okay, fast forward to internship. And that's where you come across patients and come across the real world. In my medicine posting, we had this patient, I still remember her, named her also Chandrakala Pandey, wife of an army man, who had CML, and she was in blast crisis. She was a very precious patient, and all the staff, the residents, everyone was, keen on her. While managing her, I managed oncopathology at that time. I understood how it was. But every evening, everyone concerned would wait for one lady. And that lady used to bring the reports from pathology those days. She used to come trudging into every ward she would hand over and I realized, okay, there is some other department somewhere else on whose values every one of my seniors are waiting. And they would wait eagerly. How many classes today? What is the treatment now? So as an MBBS student, I think all of us, we really don't know what pathology is. But that was my first inclination. Okay, there it is. There is some department which is actually meaning a lot into the patient care. And then came this, my next posting was in pediatrics. And we had a child, a small child, who had big lymph nodes. She presented to the ward and she was there and there was a case presentation. At the end of it, the consultant asked all of us, okay, what is your diagnosis? I mean, we didn't know anything about it. So my senior PGs and residents, someone said tuberculosis, someone said Hodgkin's. The whole thing of everything was there. Everyone guessed. It came to me. Now, I didn't even know what other diseases there. But I don't know why I called it histiocytosis. Langerhans histiocytosis, known as histiocytosis. Maybe I read it up or something, and then in the afternoon, my senior resident said, hey, Basu, let's go and find out. The child went for a FNAC. So let's go. So I walked into the Department of Pathology again for the first time, the corridors where the faculty sit. And there was the last room there in the corridor was Dr. Geeta Jairam.
Many of you would have heard about the cytopathologist. So my senior resident told her that there's this patient who's FNAC we have done. So she put the slide under the microscope and said, there are so many coffee beans, let's have a cup of coffee. I still remember that, and it was the histiocytosis X. Okay, so these two instances somehow made me aware of the fact that there is some department like that. Okay. In my path to the final diagnosis, what I call, this book has played a lot of role after able to final diagnosis. However, as a career choice, pathology is an unpopular residency choice for medical students all over the world. In some countries, this has contributed to a crisis that has affected the quality of clinical laboratories. 1 to 3% of MBBS students take pathology as a career. And out of the 180 of us, only 4 are practitioners. There's been also an experience that when we ask our undergraduate students on the foundation course, all of you, they have to go through. One of the questions that we put on day 1 of their joining MBBS is, what do you want to do? That's a part of our usual questionnaire. And I've been involved in that last 6-7 years. There's not been a single entry of pathology. They're all others, neurosurgery, big things are there. Many of them write, I don't know, that's fine. But I have never seen pathology. We put the same question to the interns on their last day of internship, and we are yet to find any single intern writing pathology as a career choice. So why not pathology? People feel less of the subject because it's paraclinical. These are some of the impressions that people have given me. A prefixed inferiority veil break over pathology. Even when we like it because of others' already set mindset, it comes low in my list of subjects to choose. How I would be viewed if I could take it. There are articles that talk of career choices in pathology, be it Nigeria, South Africa, Saudi Arabia, USA, all of them pathology comes down. So why not pathology? Because of the negative stereotypes. Perceptions of pathologists as being in some ways non-medical and non-clinical, low interaction with patients. But the most important influence that I feel, or even the articles feel, during our training, MBBS training, pathology is invisible. It's totally invisible in clinical practice. Of course, perceptions that pathologists will use is dead bodies and lab stuff, you will know too. Negative influences of your mentors, seniors, family members. Perceptions that pathologists are introverts and pathologists don't learn enough. Our teaching learning methods, therefore, I feel need to change. Why do we need to change? What change do we need to do and how to make the changes? That's important. Why do we need to change? The change in the rate of medical knowledge has continued to increase and accelerate over the years to a dizzying speed. In the 1950s, this is from literature. In the 1950s, the estimated amount of time it would take to double medical knowledge was about 50 years. By 1960, it came down to 10. And in 2020s, the projected doubling of medical knowledge is under 3 months. So if you put it in a way, one thing to think about is a medical student who starts medical school this year will have as many as 20 doublings of medical knowledge before their graduation. 1980s, the type of informers, still not we're happy with it. And today, this was presented. That's it. There's also a paradigm shift in the aspirations for medical graduates. MBBS, if you try and what I do, M. To me, it stands for the M part of your post-graduation. Who wants to remain a bachelor and that to twice over? And the S is definitely super specialization and sub-specialization. So our NMC is talking about the Indian medical graduate. Where in the definition of MBBS are Indian medical graduates? Technology has advanced. This was the quiz question in the morning. No longer. It's become a microscope. And another 20 years, this microscope will go up. No pathologist will go to the next slide. We have digitization. What is this, by the way? This is the first stethoscope. So technology has advanced. Again, I'm sure many are soon going to happen. The stethoscope is going to go away from the doctor's scholars. And that was the first computer. And today it is this and even smaller. So we are dealing with a generation of students, we call them the Gen, who are technologically savvy. Change in the way when we were students, we were told, what is this orphan Annie nucleus? I never knew who orphan Annie is and why. Even my teachers could never explain to me. It was not available. Now, you know that. Nucleus resembles the eyes of this orphan Annie cartoon, and that's how it is.
With this advancement of technology, generation gap has increased, but there is an easier access to information and the knowledge gap increased. Experience what matters. So we no longer can be the sage on stage, standing here taking a class. It's not possible. We have to be the guide by the side. And that's probably why when our students will understand the importance of these subjects. What do we need to change? We need to change the way we teach. Because we are not doing it right. Too much emphasis on didactic theoretical knowledge, too much facts, too much emphasis on our slides, PowerPoint slides that we put up. And the result is this. Right? Now, how many of us as undergraduate teachers are experiencing this firsthand? I am. I walk into the class and at least 50% of the students are with their head down. Or by the end of the class, 100% of them put their head down. In fact, when I joined JITMA for the first time, we had a lecture theatre, a very beautiful lecture theatre with benches. And I don't know if you have done it, I have written graffiti on the benches. It used to be a very common practice because we didn't have cell phones. We didn't have anything else to do. And this was one of the graffiti that I saw in my initial days. You fill in the blanks. Can you fill in the blanks? What was missing? Not G. Some students sitting there commented on the pathology class as password lousy. This aversion to lectures is not new. It is there from ages. All of us, how many? So, need to change the way we teach. We need to have patient-centric learning. We talk of early clinical exposure. It's a part, but most of the time, the early clinical exposure is taking the batch of first year students by the PG of biochemistry or anatomy and making them sit in the ward and see, okay, that's the ward. That's not early clinical exposure. Let's post them in the hospital wards. Let's post them in the emergencies. Let's post one student, bright young fresh first year student into the labor room. Let him see the beauty of a child being born. That will, I think, be enough. Similarly, let them have early clinical exposure, laboratory exposures. Post them in the laboratories, not post them in the practical hall and show them chart and picture specimens and slides which they don't understand. Let them at least spend one day in the grocery room. Let them go to the pharmacy clinic. Let them do a night duty one day in their 5.5 years with the clinical resident or the pathology resident. Let them see how patients are handled. We conduct workshops for undergraduates, and that's very useful. We conduct on academic purposes. This is one that we take every year. We call it the path to the final diagnosis. We have 4 sub workshops. One on how to diagnose anemia, how to diagnose leukemia, one on immunofluorescence and kidney biopsies, and one on throughput to target, we call it breast biopsies, right? C and throughput. And that's the response we get. Thank you for an amazing session, for giving us an interesting peek into the pathology day-to-day activities. Thank you so much for making us be a part. And this is one comment which I like. I think my perspective of visualizing pathology has changed now. I can now feel how it is useful in our diagnosis. Do the pass the website. Take interest, I implore you, in those sacred dwellings, which one designates as laboratories. Demand that they be multiplied, they be alone. These are the temples of the future, temples of well-being and of happiness. This is where humanity grows greater, stronger, and better. We need to change the way it feels. This cartoon, I got it from my senior. That's very beautiful. His father, son, and their dog named Fido. The son says, Dad, I taught Fido how to whistle. Fido, whistle. Fido, whistle. Whistle. All that Fido does, he wags his tail. The dad says, I thought you said you taught him to whistle. I didn't hear this. The son said, I said I taught him how to whistle. I did not say he learned how to whistle. Too often as teachers, we focus on too much of what we teach rather than what our students learn. Teaching and learning are complementary to each other. So we need to change the way we teach. We need to change the way we take our lectures. This is one book that has changed again my perspective of taking a class. I used to take neoplasia from Robbins. All my years I've been doing that. Last few years I read out pages from it. That's all to the undergraduate. Technology is a great aid, but it shouldn't be blatant reading out of PowerPoints. That, sir, is going very fast. I'm not able to follow this. So let's make better use of this powered by taking apps. Lack of proper understanding and confusion due to conflicting. Often this bores students by sheer repetition of the same topic. Anemia or RBCs are taught in physiology, it's taught in pathology, taught again in pediatrics and gynae, and everyone distorts and
presences at their rate. That's wrong. Failure to instill curiosity. These are all comments by my students. Hey, do you still remember our sir acting like a uterus and explaining us flexions, versions, parts? That's what the students remember. I'm sure we remember what I still remember my cardiothoracic teacher teaching us congenital heart disease. Tetralogy of Harlow, one pink chalk in his hand, one blue chalk in the other. He was explaining the entire circumstance. I still have it 40 years down the road in my mind. So a class of anemia that I take, I generally let's start with making context. How important and how severe is the problem of anemia. So make it context. That I think would reach. A class on alcoholic liver disease. I start with this nurse section, little Miss Muffet, out of this spider. There came a big spider. And older Miss Muffet, she decided to rough it and lived on whiskey and gin. Red Hands and the spider developed outside such other ways because of the alcohol cirrhosis. Make learning fun. I'm very much against presentation and teaching classes. I hope you're aware of this entire concept of depth by thought. So an effective lecture should be interactive, concept building, two-way communication, student participation, fast sessions, variety of media, and let's also involve undergraduates in projects and research. This has helped us, many of our students, in at least understanding what the world is. Some of the projects that I have done, and this particular project, Utility of Startup Plots, was a wonderful project that did some training me into startup plot. This was what was the outcome. The student was an artist. He designed his own t-shirt with the startup plot, and he sold it at our colleges. So these are my students who have been with me and who still are, all of them now eminent physicians. And none of them are the colleges. What else do we need to do? This is again from the students, need to have algorithm-based standardized teaching, need to expose us to role of every subject in healthcare, especially the pre and paraclinical, need to train in first aid, critical care scenarios, need to revamp the exam pattern, need to ensure uniformity in marking by different teachers, need to expose us to various day-to-day ethical dilemmas as solution as part of curriculum, need for more apprenticeships and lectures, need for improvement in research incentives, need for better directions in choosing a career, need for greater interaction between faculty and undergraduates. So we are losing out on this. So make students aware of who is a pathologist. No, it's said that what a clinician suspects a pathologist confirms. At times, you know that. Pathologist tells what the clinician doesn't even suspect. So don't teach diseases in isolation. You have a patient, it could be iron deficiency anemia, megaloblastic anemia, autoimmune hemolytic anemia, even leukemia. So don't teach isolated topics. Always try and integrate into patient care. Similarly, this could be not just tuberculosis, whose treatment is different. Lymphoma, whose treatment is different. It could be metastasis. It could not be a lymph node at all. So let the student understand that diagnosis is important. Reading PV, these are examples I generally take, so let's go to it. CS surveys, it could be endometrial hyperplasia, it could be hematology. It's on the side of PV. So the student has to understand that. So expose them to real life scenarios, make learning contextual, keep some time out for laboratory postings. Even the specimens and slides that are told, like we generally say a chart mounted specimen and all that. Let them realize that that actually belongs to a patient. Start like that. Have elective postings in the department, meaningful elective postings. Tag them with residents and faculty, let them do research projects in pathology, let them attend institute CPCs. That's again a very good learning exercise. Let students explore and love the research. That was my residency, how I got into pathology. Influence, of course. Exam was there, you had to score marks, and you got it. And this was where I came across my entire plethora of my seniors, my teachers. Some of them are no more, but all of them. One thing I learned in MAMC was that it is all right to subspecialize. You have experts in every field. Generally tendency for us faculty is I want to do this, I want to do that, I want to do this. No, I feel that you need to have yours. So I had doyens like Dr. Jinder Singh, Dr. Sudharani, Dr. Sachi Prakash, all of them in hematology. I had Dr. Geeta Jairam in psychology and my desk in histopathology. All of them have contributed brilliantly.
They have been the wind beneath our wings. There are two very useful articles as to how we can do this post-graduation better. One of them is by Ranjan Agarwal. It's important for us to go through these. During my posting, there were the usual three: histopath, hemat, cyber. And all three were given equal importance. You know, the tendency for many pathology departments in the country is to ignore hematology. It's mainly surgical path as of that. That is not true, because after all, we realize the bread and butter of an MD pathology at the end of the career is hematology. So you have to give each section, and I was very lucky. All the three sections were given equal importance, equal postings, and that's what in NMC also we have recommended. And one myth was totally busted. Clinical interaction was constant. Whether it be in the FNAC clinics, whether it be the PS and bone marrow. Today, Dr. Savitri said the clinician does the marrow. We have been doing marrows all our lives, and we train our students to do the marrows. The history of the patient is always incomplete in the form. So we should encourage our residents, doesn't matter, no egos there, as far as the patient is concerned. Go pick up the history. Frozen sections, the time for critical interaction. And also in the laboratory, it was not just slides, we were doing the techniques. Encourage your postgraduates to do the hardcore lab work, and that is how you enjoy it. Beauty of microscopy, there is no doubt of it. I still remember a routine case of appendicitis, how thrilled I was to see the neutrophils in the muscle core. You know, that's what books had told me. Here I was looking at it with my own eyes. I was seeing the entire process of margination, rolling, everything happening for me. And at the same time, I was seeing the patient's peripheral blood swelling. The entire concept of acute inflammation, one slide, one evening, and you can get home. This was another case I remember. I specifically picked out this. Every member is sarcoidosis. The way the granulomas were there. Till we found the, I don't know if you can see it, the acid was bacillus within an angle capsule. Again, the entire pathogenesis of chronic inflammation, granulomatous inflammation came out alive. That's how I started getting interested in the subject. We had read about caterpillar cells. There I was seeing it with my own eyes. We read about Wheatstone owl's eye cells, which is there. The aurora fascinates me even now. And myeloperoxidase powder. Then, of course, a big influence of my guide, Dr. Tajinder Singh, and this was the needle that was handed to me actually on my day one of joining MD. Bone marrow, and I had to keep it. I kept it with me for 6 years. And Jesus on bone marrow and breast cancer. What did I learn from it? These were my slides that I had taken, metastasis. Single cluster of cells. I learned those days the basics of immunohistochemistry. I learned through my thesis. It was still developing in the country. I presented it, and this was going to receive the PGI. So, like any good postgraduate, anyone, we did present it and I published it. So the cycle was completed. And through my dissertation, I learned honest work, regularly monitored. That was very important. Work ethics. I learned a technique independently, which I can still proudly say I am master of it. So I may not be, but still. I learned IHC during a phase when it was in its infancy. I learned how to scientifically write. I searched literature the hard way. Those I don't know if you remember. Those books that used to be there. Index Medicus, and the volume that you wanted would never be available in the library, but we had to search. Art of scientific presentation, microphotography, I still remember the hard way. I mean, it's much easier now, but I think once we have learned it, that we can train our students to get into this and communication skills. Another thing that I learned and enjoy and still do was attending conferences. That was my head of the department. This was again PGI Chandigarh in 19. And she was like a mother hen leading the chicks or the baby ducks to go along, Dr. Chauhan and myself, and all of us. This was when I started doing the same with my students. I met innumerable people who have left a lot of influence in my life, because of Amita Borges. And this was 2 years ago, Cylinders at Lucknow. So attending conferences been good. We also had a lot of fun attending conferences. I was even caught dancing in the next day's tabloid with Dr. Gayatri. So this is what I started presenting my own paper. I still like to do it. I still prefer to take a poster or a paper myself and present it. Of course, I have been judges, and this was another talk, Dr. Tilak. I think the same one. So I attended conferences and learned new things, met people, stalwarts, networking, improved my presentation skills, shared my research work.
sense of belonging with the department, that cool. Team building, saw new places and made new friends. We had a blast as a resident in June. That was us with my head of the department there, dancing on the screen. And I'm there, right? So where did I stand at the end of my residency? I came under the guidance and tutelage of many teachers who were and are still the giants in the field of economics. That's what made my career. Had my roadmap laid down towards academics and a strong base in both theory and practical aspects, thanks to my department. I did have some publications, again, thanks to my teachers. Equally confident in surgical path, hemat and cycle, but ill-equipped with clinical path and transfusion medicine because that was not a hardcore subject. That's what I feel. If you don't keep hematology as a part of your pathology, you will never learn. Anything if you try and put it out of those 3 valuable years of training, you are going to miss out. I was standing on the shoulders of giants and ready to let others stand. And that's when I joined the course. And at the outset, my obeisance to 4 of my senior teachers and colleagues who are more, Dr. Beliath, Dr. Narasimhan, Dr. Sachiti, and Dr. Subaya. I've learned a lot from all of you. And that was my department when I joined the Team Devya, we used to call the 3 ladies who are still there and doing great work. Dr. Ratnakar, Dr. Krishnan, who became a very close friend. And also I came under the influence of Dr. Hematologists, those principal friends, they all became family. This was my team at JIPMER, all of us are there still, and this is my new team at NGNCRI. It's always a team, I feel. It doesn't matter from whom you learn as long as you are learning. You know, from my laboratory staff, my technical staff, all of them have contributed. Another point that I would like to cover in this journey for all of us, students or teachers, we generally have this concept of publish or perish. No, we are told. I look at it as publish and search. It's possible to publish. I'll tell you 3 stories of my publications of how it started. The first one, when I joined the department within 3-4 months, we had the Delhi chapter of IIPM, the annual conference in Mamsi. So my job, I had a pretty decent writing, so I was burdened with making the posters for all of us. I didn't have all the gadgets. So there I was, a backbreaking doing that. And one of the posters had my face. So this could be posted. And this is, I don't have the poster, but I was standing in front with my colleagues. I got a certificate. Within about a week or so, Dr. Rajinder Singh came up to me and told me to sign on a piece of paper. He didn't even know what it was. He had written the paper and he included me as a co-author, and that's why I call it a gift authorship. Not the way we talk of gift authorships these days, but that was gifted, and soon I found my name in the paper. I mean, that gave me my first little kick. Okay, it's good. Though I had not really contributed to it, except he write down the poster. He was magnanimous enough. Of course, I had done some amount of little searching on the cases and all. He was magnanimous. So that was my first introduction into publication. The second one was about this. That's Dr. Uma Chaturvedi. Some of you may know her. We had diagnosed the case of vasculitis nodosa. Vasculitis nodosa, those were the days post emergency. So vasectomies were done. So many of the people used to come back to revasculate. Whatever it's called, fertility purposes. So we had this entity of some inflammation in the vascular. That was called vasculitis nodosa. We didn't know about it, so madam said that let's write it up. So I went to the library, did some whatever literature search, and there I found one paper talking about vasculitis nodosa. And I didn't know much. You didn't have photocopy also. So I copied it. I copied everything, I turned it and gave my teacher my written thing and also the original article which I had taught. Within 5 minutes, he came up to me and told what I had said. That's plagiarism. I learned the word plagiarism from her. So we wrote it again and then we published. My third story is this. One evening, 3 hours, there was this little teacher, Dr. Geeta Jairam, she used to work on thyroid. So she had given me one little to do kind of a project of the FNAC findings in thyroid. And she gave it to me when I was doing my PG, first or second year. And PG went, exams came, I passed out, I became a senior resident, and the data was relevant. So, as usual, we have so many other things, including getting married. So, there was a lot of other things. So, one evening she said, Basu, today I will not let you go home. We will sit and write on the paper.
It took her 3 hours. I remember her sitting there and dictating me. The data was there. So that was again another way I learned how to write a paper. So we wrote this paper, this I won the Nalini White Shankar Award of this paper. And soon I had a review in my name. So I'm saying that these were the key triggers that made me get into whatever little publication I've done. I'm not a very good researcher. I'm a very mediocre researcher. But I at the end of my thing, I had about quite a few papers to show. What I believe is you need to focus your work to write papers or to contribute. This was my first, I'm CML, I have done a lot of work. My first PG, Karen, she's in Egan's now, her paper. Through the years I have published, till we did my only first and only PhD student whom we worked on the microenvironment. I turned into a lymphoma, interested into lymphoma by my association with Dr. Naresh. Being able to do. Bone marrow has been my field. And I also really for students, postgraduates, and all of us. There's no dearth of material to write a paper. This was a chance finding. I saw bilirubin crystals in the neutrophil in a neonatal sepsis. It got published. This is probably the only one that I have gotten. It's all right. It's your things. Follicular lymphoma, low grade, but the Ki67 was high. Ask yourself a little question. Why is it high? And we soon found that this is an entity in WHO, low-grade follicular lymphoma with high proliferation. This was a thesis on post-therapy AML, marrows. And we found that CD79A, megakaryocytes were taking up CD79A. Case of ALL, we had done CD79A just to look at the residual blast. And this is now a part of the definition of histologic megakaryocytes. All my NDS cases, megakaryocytes, I apply CD79A. And they are usually a feature of dysplasia in megakaryocytes. This was a case where we picked up basically tumor lysis in the peripheral blood and bone. The necrosis that was there can be turned into. And this is what I was talking about of cervix water. The myelonecrosis, immunohistochemistry helped us in diagnosis. So even if the material is there, and with your residents, you build a bond. And they have been my residents, all of them, who have worked and with whom I have worked. And all of them, it's there, Shailesh, you were there. With Kalyan, I think he's gone, but he was also. This was not my dialogue. My consultant had taken us to a conference, same Dr. Chauhan, and she introduced us to some very senior people, I don't remember, saying that they are my right and left hands. So that bond with your residents is very important. And this legacy continues when your mentor guides yourself and you guide your mentee, and that's how it is. For us pathologists, the power of observation is very important. This was one case that I had got in my PG days of leprosy, lepromatous leprosy in macrophages as negative images. And when it came to my turn, there it was. So macrophage, these negative images were actually as it was. So we have that power of observation which we can use. Again, background looks dirty. It was a slide that you can throw off. Notice carefully and you see these negative rod shaped images. Do your acid fast scaling. And yesterday, I think someone said that I see only what the mind knows. No, a pathologist, it's not valid. Its biggest weapon is our power of observation and our curiosity. What the eye sees, we need to find out what that's important. Have that curious mind in yours. So that the previous slide is actually this. Slide that again on the peripheral sphere. We saw anything until we went into the oil. And we found the platelets. This is the slide I often show my students. Obvious, right? Or not? Can you tell something else? The visible. Something else. You can even say it's a girl or a lady. You look at these. That's the power of observation. If your form is flat, doesn't matter. You can tell yours. This is again a field that I'm very impressed. These are all actually plasmodium falciparum rings around the cell. This is I think the entire concept of falciparum complications, of how the RBCs stick to each other, they make it sticky. It's there in this field. I understood that. Of course, it never ceases to amaze me. The bundle of sticks of Haber cells. Morning. We had the talk on morphology and It's there in front of our eyes, NPM1 or mutations. Morphology is important. This is another I always feel do not shy away from challenges. One fine day, my director said that you have to look after the blood bank. Because both the blood bank officers had left and suddenly it came upon me. I took it up and we built up a blood center in Iswa and had a lot of fun, published, it's important. So again, that's another thing I feel is important. Pathologists have been at the forefront of changes. The saga of CML is the biggest example. What started from morphology, went into Philadelphia chromosome, 922 translocated PCR ABL, and finally anatomy. The pathologist has been there, so that's the power of the stuff. Especially hematopathology has redefined technology through the ages, right? Whether it be morphology, cytochemistry, cell counter, immunohistochemistry, aggregates. Technology is there in this surface. Those of us who say that pathology is about how that we see it's wrong. It's becoming very, very technology. Anything you look at, whether it's fish or it's RT-PCR, microarrays or anything. Pathologists are not magicians, nor would we have extrasensory perspective. But we have a lot of natural influence. Automation, AI, machine learning did come into pathology much with the cell counters and Coulter and their patent. Naveen was talking about Coulter taking 5 years to patent. When they first set up their patent for publication, they were told, I'll come to it. They were told you can't patent a whole. So it was rejected. They persisted. And finally, this is too much so that we now have a diagnosis. The machine is giving you a diagnosis. So that's there. Machine learning and somewhat automation. Your subnets, they're giving you a diagnosis. Cell vision. Even so much so, on histopath, the machines are saying. So we need to be embracing technology as much as we can. Yet, all of us, can you tell who this person is? A Swiss internist, native of Bern, involved in almost all aspects of internal medicine. Made contributions to neurology, physiology, improvements to the BP apparatus, and asteroid is also known about it. And we all love it. All of us. Yeah. No. This is Sally. Why I'm saying this is pathologists are so involved. We have so much of technological advancement, yet we cling to Sali's hemoglobinometer as an exercise for MD exam, as an exercise for MBBS exam. We are ourselves, going backwards in order to saying that, and yet we say that pathology is not business. So let's give up what is redundant. Let's assess difference. Let's get rid of Sali's hemoglobin. It's important. It has a historical significance. But you don't spend 30 marks out of 350 on Sali's hemoglobin. Where even many centers, MD exam Sali's is a major exercise to be done for MD pathology. Newborn chamber, NMC, if you look at those of you are dealing with the various competencies, what one of the competencies? Newborn chamber for RBC. Counting RBC is a certified skill that an MBBS student in pathology has to get, and not just once, 4 times he has to do this exercise. And all colleges are beautifully for bleeding time and clotting time. How many of us still do it and still receive this instruction from the clinicians? For the exams, we pick out exotic slides. Why don't we give a routine lymph node that is stuff? Why don't we give a secretory endometrium? Okay, that's what a student has to learn about. We have these exam specimens, we have these got-up autopsies. Let's get away with it. Let's opt for something different. Let's opt for more objective ways of assessment. Let's opt for workplace-based assessment. One exercise that we can give to our MD is do a crossing of a fresh specimen in the start. Let's see how you cross it. Rather than picking up an old specimen and asking you to describe, that's what we do. Let's change it. Let there be more interpretation, let there be more lab. So why hematology? For me, it was serendipitous. I liked the subject, but it's not that I didn't enjoy histopath and cyto. When I joined JIPMA, there was a kind of vacancy because the head of the department, who was a hematologist, didn't have degrees there, but she was in hematology. She was retiring and she wanted someone. So I don't know what she saw in me. She said, will you take a start reporting hematology? And she told me on that day that here we don't today. If you are serious about it, you say, because you will have to keep reporting hematology. Don't say that I want to do endometrial biopsies also. I want to look at thyroid. So I said, okay, fine, I took it. So it's more of serendipitous. And to me, it's clinical. There's nothing pathological about it. It's a clinical subject. And it's wholesome. That flows me. All kinds of things. These are entirely my perspectives. It's more precise, it's more objective. It's technology driven, combines the art of morphology and the science of technology. Results are instant, and the variety is mind-boggling, whether it's hemolytic or bleeding or neoplasms or benign, malignant lymph nodes, marrow. One thing I would encourage all hematopathologists to do is also do lymph nodes. That makes it complete. You need to. And it deals with global and historical disease. That's where we are really serving. It's constant teacher. In all this, it's good to take time out and unwind as a president and as a consultant. It's important. There I am with my head of the department and here head of my house. So it's fine. So what have I achieved in all these years as a pathologist and as a teacher? Three situations sum up what to me is my sense of fulfillment. When at the end of my class, a student says, wow. Or an old student tells me it's because of you or your classes that I took up pathology and culture. Or when my teacher, who taught me all that I know, asks my opinion, I would that's my achievement. So the path less traveled by, it ends well. I shall be telling this with a sigh, somewhere ages and ages hence. Two roads diverged about, and I took the one less traveled by, and that has made all the difference. We used to harp on this word sigh. In school, this period, is it a sigh of happiness or a sigh of sadness? That's for us to decide. Okay, so we wrote a poem. The path of a pathologist less traveled by. Two roads diverged in a sterile light where microscopes and slides reside. And I, with science as my sight, shows the path not cold nor bright. The road few doctors will abide. While many chase the silent call of crowded wards, the surgeons fail, I wandered down this quiet hall where cells and tissues tell their all, and truth eclipses wealth or healing. It's a path ignored by those who seek more lucrative and lauded ways. For here the voice of blood speaks and whispers rise from marrow's beak in countless hues of pink, blue, and gray. If you see the meaning in a slide, the patient held within the glass, you join me on this humbler ride to walk where life and death reside, to let a cell predict or pass. Two roads diverged, and I was torn to take the one less bright or bold, to work where few would look upon, where quiet knowledge trumps the dawn of faith, of wealth, of days before. And that has made all lives more bold. Who wrote this poem? ChatGPT. I asked ChatGPT, not me, my children asked ChatGPT to write a poem based on Robert Frost's work, and this is what came out. So it's a good thing to have. It's a good tool to use. So I enjoy pathology. This is something that my colleague does regularly. Takes a slide and turns it into a
both shape and secretion. Platelets contain a lot of important molecules which they release, and these can further enhance the activation and help them in their functional aggregation, which is what happens when two adjacent platelets link up to each other using a protein in between, such as fibrinogen. And platelets, of course, provide the procoagulant surface, which is required for cellular coagulation. So they're doing a lot of important stuff at the site of injury. And for this, they're very ably suited because they have a very good structure, which is made for this purpose. So they don't have nuclei and they are very small cells. And we know that the normal platelet count lies at 1.5 to 4 lakhs. They have a cell membrane which carries a number of important proteins called receptors. They have a number of granules in them which contain important cellular proteins. For instance, the alpha granules, which are far more numerous, contain virtually immunoglobulins, coagulation factors, growth factors, and you name it, they have it. They are imbibing these from the plasma. Then we have these dense granules, which you can see like that target in the center, which contain ATP and ATP and calcium. And we know these are energy currency of the cell. So you can make out that a platelet is going to be a very active cell. And for this, it has a large number of mitochondria. It has a storage of glycogen. So all these help the platelet to perform its function. And for the function to occur, the surface has to be very active and recognize changes in the environment. And for this purpose, the platelet has a large number of receptors. And as you can see in this complex diagram, there are a whole lot of receptors on the surface. They bind to something called an agonist. When the agonist and the receptor bind, there is a signal sent to the center of the platelet, which causes the contractile proteins to move. The platelet changes shape, and eventually it releases calcium and the contents of its granules. And this leads to the aggregation eventually. And the main activation pathway involves ATP, thromboxane, and thrombin. So bleeding platelet disorders can be as a result of thrombocytopenia, low count, or abnormal platelet function, thrombocytopathy, and sometimes they both exist together. Especially now that we know a lot about the inherited thrombocytopenias, we know that there is an element of dysfunction associated with a low platelet count in many conditions. The clinical presentation, however, still remains the same. They come as mucocutaneous bleeds. They can be epistaxis, which is very common, menorrhagia, petechiae ecchymosis, GI and GU bleeds. The deep bleeds associated with coagulation factors, that is those in the joints and muscle bleeds, are usually not seen in platelet bleeds, though intracranial hemorrhages have been reported. We need to know what is significant bleeding. All of us have epistaxis, have had episodes of epistaxis while we have been children or as we grew up. So what is important? When are these significant? When there are repeated episodes, when there are multiple sites of bleeding, when these require transfusion support, and when there is a positive family history. So these are the situations where you need to investigate further. And the cause may be either acquired, most commonly liver disease, uremia, drug-related, immune-mediated, or marrow failure, for the decrease in count of platelets as well as for their loss of function. And some inherited disorders, the common ones, these are rare, but we hear them more commonly, are Glanzmann's thrombocythemia, Werner syndrome, and Mayhemian. So there's a whole panel there of disorders which can give rise to bleed. So if we have such common bleeding presentations in platelet disorders, we need to be more objective in the ones we have to take up for further investigation. And for that, we take the help of these objective scores to assess bleeding, out of which two important ones actually address the platelet bleeding disorders. This is the ISTH VAT and another questionnaire. So what the VAT does is, it enlists on the symptoms, scores them on the basis of severity. We calculate the severity score at the end and decide whether we need to investigate further or not. If the score is more than 4 for males, more than 6 for females, and more than 3 for children, then it is significant. But the advantage is that the VAT score gives us a very high negative predictive value. So if the scores are less than these cutoffs, the chances of a significant bleeding disorder are less. So it helps us to take a decision on who has to be investigated further. But they are not perfect like anything else, and there is a drawback. These are dynamic. Today I don't have a bleed, tomorrow I have a bleed, my VAT score will change. In children where bleeding disorders are anticipated, they may not have got so many challenges by the time they come to you for a VAT score. And it's very time consuming. You have to ask those questions very diligently and so. So these are tough things. So in history, we have to make sure that we have taken good history about how the bleeding episodes have come. Is there any family history of a bleeding disorder? Because many of our platelet function disorder defects are autosomal recessive. So some of them are dominant inherit. So father, son, grandfather, that should ring a bell. Medication and nutritional history is very important because there are many now platelet function modifying agents which are available on over the counter, aspirin, non-steroidal and anti-inflammatory drugs, which if the patient has taken and we run tests, we are likely to go to wrong results. Even in the absence of testing, they can, sort of give rise to bleeding in a person who has a mild bleeding disorder. And of course, when we look at the symptoms, besides the general physical examination, we have to look for syndromic disorders. Some of the platelet function defects are associated with early cataract, with renal presentation, with deafness, with albinism. So you have to have the eyes really open when you're taking up a patient for platelet function testing. This is a whole list of acquired platelet function disorder and how they do it. If we have to investigate, we start with the complete blood count and the peripheral blood film. Just the reading and the presence of blast, I need to go no further in platelet function testing. I know this is probably because of the leukemia. But if I can't get my answers from there, then I have to go further. And platelet function testing includes platelet aggregation, use of a platelet function analyzer, which is a point of care instrument, and a simple bleeding time if you have nothing else. The bleeding time looks very attractive, but it needs a skilled operator. It's difficult to do in children, and most of us are not very skilled or do not have that kind of technical help available all the time. So it's not such a popular test. And it misses the mild bleeding disorder. So it's not a complete test by itself, but it has a very big importance. If we don't get our answers through here, then we will need to go to more tests like platelet electron microscopy, which will tell us about the granules, or we'll have to go to platelet flow cytometry, which will tell us about the receptors on the surface and can tell us if the platelets are getting activated properly and granule release is occurring properly. We can also do platelet immunofluorescence to look for defective or deficient proteins in the platelets. And finally, genetic studies may help us to reach a diagnosis. The sample, very simple, we need two. We need an EDTA sample for the CBC and we need an overnight fasting sample for platelet function testing. Mostly the citrate sample with a clean belly puncture through a good needle bore and free flowing. And the tourniquet should not be applied for a very long time. This is taken, in the standard ratio of 9:1 and in a plastic system. Only thing is, for platelet function testing, pre-analyticals become very serious because they can affect the function. So the cap must always remain on the sample and the testing is usually finished within 4 hours of collection of sample. So if you go to the platelet count, all of you know what the normal platelet count is, and we know we call it thrombocytopenia if the platelet count is less than 1,000. Here we have to be sure that if there is no other comorbid illness, but the patient has significant bleeding, the screening tests are normal and platelet counts are more than 1,000, then we have to think that we may need to take this patient up for other platelet function tests. Von Willebrand type 2B is an important coagulation factor deficiency, which is not so uncommon, hence should be kept in mind when we are thinking of a platelet disorder, though not truly in that category. But because it causes thrombocytopenia, it needs to be at the back of our mind. Both morphology and number of platelets is important. We need to look at the mean platelet volume, which is so easily available from most of our analyzers. The normal is between 7 and 11. We might see very small platelets or get a very low MPV, less than 2. Then it's suggestive of Scott-Albrecht syndrome. This child may have some skin lesions, which may help us to diagnose, and immunoglobulin profile will tell us that. Or we may have very large platelets and the patient may have albinism and may have some syndromic disorders, which will take us in another direction. Besides this, we can classify our the bleeding disorders due to platelets in the form of inherited and acquired. Acquired are, there's a whole variety, including malignancies, immune deficiencies, immune causes, non-immune causes. And in the inherited ones, right from the time that the stem cell differentiates into a megakaryocyte and throws out a platelet, there can be a defect in the signaling, there can be a defect in the transcription regulation, there can be a defect in the granule biogenesis, there can be a defect in the cytoskeletal proteins and in the general receptors on the cell. So now we have a lot of information of all these and we need to look out for them by various tests so that we don't miss these disorders in our population. I have found it easiest to discuss the approach for bleeding disorders in the form of case studies, so I'm showing you these. A 10-month-old child was brought with was being investigated for thrombocytopenia. He had had only one episode of epistaxis, so this is not serious. But somebody on the blood film had seen large platelets, so he was referred to our center, and we also had a look at the CBC. And sure enough, the low platelet count was confirmed. It was 30,000. And when we see the film, what we can see here is that the platelets are certainly reduced, and they are very large. And we can see that the neutrophil in the center has a subcapsular blue-colored inclusion. This is a May-Hegelian inclusion, which looks like a Dole body, but this is not the Dole body. This is not RNA, but this is a cytoplasmic aggregate of abnormal protein MYH9. So this is an autosomal dominant inheritance in this disorder, MYH9 related disorders. So we asked for history in the father. He also had been diagnosed to have thrombocytopenia, but had undergone a nephrectomy without any bleeding. He also had large platelets and the inclusions. The grandfather had early heart disease. He also had thrombocytopenia, was being treated as an LTP, and had the same inclusions. So what we have in this family tree is an autosomal dominant pattern of inheritance in this family. Now, this May-Hegelian disorder also, many of us have this concept that it's only one thing. But actually, it's a group of disorders where one thing is constant, macrothrombocytopenia, but neutrophilic inclusions may or may not be there. They can be, some of them may have hearing loss, some of them may have nephritis, some of them may have early cataract. So based on that, they can be classified into further subcategories. We did a genetic study on this, and we found that there was a mutation present in this child, and this mutation was also seen in the father and the grandfather. Now, what is the need to do a mutation testing in a patient where we can make the diagnosis from the peripheral blood? So here the importance is that though this was a previously reported mutation, this is very well known to not have a bleeding history. So this explains some things that we saw in our patient. No bleeding despite surgery. And it's associated with renal dysfunction, early cataracts, and sensory neural hearing loss. So we now know that we have to counsel this family that there may be, you should be screened earlier for these defects so that they can be caught early. So this is the importance of looking at the blood film examination and the mutation detection. The second patient is a 5-year-old girl who came with ecchymosis off and on for 2 years. There was no history of transfusions, and she was being investigated for bleeding despite a platelet count of 69,000, with a clinical possibility of either a platelet function defect or von Willebrand disease. So here, as a rule, we do a screening coagulogram in all our patients besides the CBC. And what we can see is that her APTT is prolonged, which corrected on mixing studies, suggesting a factor deficiency, which was found to be factor 8. And so, because it's a female, we will obviously rule out von Willebrand disease. And we can see that the antigen and activity are both reduced with a ratio less than 0.7. So this is looking like a type 2 von Willebrand disease. Now, even here, there is another test that we can do to, sort of confirm this, which is the abbreviated ristocetin induced platelet aggregation. If you look at the left-hand side, the control shows a flat line, blue color with the low dose ristocetin, but a very good response in black color with the normal dose. But in the patient, the blue line goes up. So this is sort of suggestive of either a platelet type von Willebrand disease, which is a platelet defect of the receptor, or the 2B von Willebrand disease, which is a problem in the DWD molecule itself. This can be resolved best by mutation screening, and in this patient we found a mutation. So this was labeled as a type 2B von Willebrand disease. This case is just to emphasize that in every case of thrombocytopenia, it's a good idea to run the coagulation screen. If we don't do it, then we might have missed this diagnosis. The third case is a 5-year-old female who came with pain abdomen after eating, and she had been noticed to have black-colored stools for the last 3 months, had exertional dyspnea, probably had severe anemia as well, and epistaxis. She had received a packed red cell transfusion a couple of months back, and at this time, the GI endoscopy showed active bleeding, but no ulcer. So again, there was a problem, and the possibility of a bleeding disorder was being considered. And so we ran all the tests, and as you can see, the screening coagulogram, the VWF panel, and the factor 13 were normal. So this is the situation where every day in the lab, if we are faced with this problem, we go to the next step, which is the platelet function testing. There's significant bleeding, likelihood of a bleeding disorder, but nothing wrong in this platelet. So what is the test we commonly use for that? This is the light transmission aggregometry, which is a screening test for platelet function, but still considered a gold standard for this purpose. What it's based on is that from a light source, light travels through platelet-rich plasma, and if we add agonist to the platelet-rich plasma, the platelets aggregate, more light is allowed to pass through, and we get a curve. The increased light hits the detector, which we can see as a tracing on a computer screen. So the whole process of aggregation becomes easy to visualize. And what are the agonists which we use? These are things which are already present in our body: arachidonic acid, ADP, epinephrine, collagen, and ristocetin, of course, is an antibiotic which has shown some activity here, so it's used. So remember that diagram which we saw initially, where there were receptors on the surface. These are the agonists which will bind to the receptors to activate them. Once the agonist binds to the receptor, it activates them, and eventually aggregation occurs. But it's important to prepare the patient well for this, and we usually need a fasting sample, which is difficult in children. We usually ask for an overnight fasting. The patient must not smoke if he's an adult for the last 30 minutes, and no caffeine. And we must make sure that we have looked for all this list of interferences, whether drugs or whether food articles which may interfere with platelet function. We can test while patients are taking drugs, but we will have to write at the bottom of our report that this test was done in the presence of such and such drug, which may have an effect on platelet function testing. So this is a cumbersome test, hence it's important to make sure that the preparation is correct. And all the, if the patient is on non-steroidal anti-inflammatory drugs, then if it's aspirin, etc., we can stop it. If it's the NSAIDs, we can stop them 3 days prior. But if they irreversibly inactivate the platelet enzymes, then we have to wait for 10 days. Platelets life cycle, all those platelets will go off, and then we have to test only when the effect of those drugs is over. So what is this? These are two instruments there, the common ones in use in the country today. And on the right side, you can see that the changes, there are two panels, the left side showing the yellow plasma, that platelet-rich plasma, in which we will add agonist, which can be ADP, collagen, epinephrine, or arachidonic acid. This will cause a shape change in the platelet, and you see a little dip in the curve at the bottom at 0.2. And as soon as the agonist produces its effects, we get a primary curve, the little hump which is coming between tubes 2 and 3. And after that, when the platelets completely degranulate and release their content, the platelet aggregation becomes irreversible. So we get the curve going up between 3, 4, and then it becomes flat. The same thing can be done on whole blood, especially if you have a low platelet count. This is called impedance aggregometry. It's only available in one platform in the country currently. Here we use 2 electrodes which are suspended in the blood, and instead of plasma, we are using whole blood. We add the agonist. The platelets, as they aggregate, go and stick to either the positive or the negative electrode, and the current circuit is broken between them, which we can measure in the form of an impedance tracing. So going back to the case which we had talked about, this patient who had a GI bleed, when we look at her platelet functions, we can see that the normal, always we have to put normal control. The green and pink curves show that the normal control for ADP and arachidonic acid has worked well, but the orange and blue lines are flat for the patient, which means she isn't responding. The same we see for the collagen and epinephrine in pink and green, and in the patients, the blue and orange are flat curves. And in ristocetin, we can see that her curve in blue is somewhat abnormal. So this patient has absent aggregation with ADP, arachidonic acid, collagen, and epinephrine, and the likely diagnosis now is a Glanzmann's thrombostemia. We could see the same in a patient who has afibrinogenemia. So this can be confirmed by, and where is the defect here? It's in the alpha-2b3A receptor on the platelet surface, where it is supposed to bind to fibrinogen. So the platelets aren't able to bind to fibrinogen. If we do the platelet flow cytometry in these patients, we isolate the platelets on a forward side scatter on flow cytometry by their size. We can label them with the CD1 of the platelet markers, 41, 61, or 42. And we can see that in the normal platelet, both CD41 and 61, which are components of CD2B and 3A, are showing up well in the upper panel. Whereas in the patient, both CD41 and 61 are absent. So this confirms the diagnosis of transverse thrombus. The next patient is an 11-year-old male who came with ecchymotic patches and gum bleeds for 4 years. He's born in a second-degree consanguineous marriage. There's no bleeding history in the family. And his screening coagulation profile is normal, but he has mild thrombocytopenia and we see large and giant platelets. If the platelet count is less than 1 lakh, we do not attempt light transmission aggregometry because the results can then be fallacious. So we take this child straight up for flow cytometry and we do the same labeling as we had done last time with CD41, CD61 and CD42B. So in this patient, we can see that whereas in the normal CD41, 42 and 61, which are composite on the left side panel, are all normal. But in the patient, 41 and 61 label well, but 42B is absent. So this patient has Bernard-Soulier syndrome. And where is the defect? This is a defect in the binding to the GP1B59 receptor, which binds to 1 milligram factor. The next patient is an 11-month-old child, male, who had come with history of ecchymosis and epistaxis since 3 months of age. He required no transfusions and there's no family history of a bleeding disorder, but it was a consanguineous marriage. So his screening coagulation tests were normal and the DWF panel was normal. So we did the light transmission aggregometry in this patient. And what you can see is that the aggregation with arachidonic acid, epinephrine, collagen, and ristocetin are normal. Whereas for ADP, we have got just one primary curve. Now, very often we see this when we are doing aggregation studies that one of the agonists may show us an abnormal tracing. It's very important to remember, don't jump and say that this is abnormal and we have, this has to be pathological. It must be repeated once again. So we repeat it again after a little while and we can still see that curve there. So at this point, it looked like something is the problem only in dealing with ADP. So maybe the ADP receptor was defective. So, which was confirmed again on the repeat testing. Still, we asked the patient to come again after 2 months because this needs to be confirmed at a separate sitting. That was done on the same sample, both testings on the same sample. And now when he came the second time, we can see that his arachidonic acid and collagen are fine. But his ADP still in the black is just showing one little curve and the epinephrine in green is flat. So now at this stage, we are a little confused because the primary wave of ADP is down and there is a low amplitude epinephrine. Now, how do we report this out? Is this really true or is there a problem here? So at this time, it looked like a storage pool defect. We signed out the report saying suggestive of a platelet function disorder and left it at that. This child went back to Jammu and Kashmir. He had come from there. He was managed in between for bleeds by packing and by transfusions also. But 8 years later, he came back again to our center with his parents now wanting a definitive diagnosis. This time when we ran his aggregation curves, we can see that the collagen, epinephrine, the collagen and the arachidonic acid and ADP are all down. So this time it is even more confusing. Now we don't know. First we had one agonist which was not working, then we had 2, and now after 8 years we are seeing that 3 are not. At this stage, we put our instruments down and we say now we'll take this up for molecular testing. We put him in the sample in a NGS panel which we run in our hospital for 25 platelet genes, and we found that he had a defect in the ADP receptor P2Y12, which was homozygous, and it's a novel frame shift which has not been previously described. Parents were heterozygous, he was homozygous, and where is the problem? This is at the site of binding to the ADP. So we've seen a number of platelet surface receptor problems. This is a rare bleeding disorder, but imagine, had we just left it at the light transmission aggregometry, we would have never reached a conclusion of what infirmity was. So at some time, we will need to progress to higher investigations to come to the answer. So light transmission aggregometry is a screening test, but it is sensitive to pre-analytical variables and mutation testing may be required to establish the cause of diagnosis. The 7th case is a 9-year-old male. He was being seen in the pediatric rheumatology clinic as a case of polyarthritis. I'm very sure we had seen a number of his hemograms, but nobody reported anything. He was treated as a rheumatoid factor positive GIA and was on naproxen and methotrexate. But 10 years later, he had a mucocutaneous bleed and the pediatrician noticed a splenomegaly. So now we had a good look at the peripheral blood film and we could see large platelets and absolutely gray platelets with no content in them. So the possibility now was a gray platelet syndrome, which we had missed so many times in his multiple films. And this was confirmed on EM. and mutation detection confirmed the presence of the mutation. The interesting thing about this disorder is these patients, even without supplementation, had very high vitamin B12 levels. So if we had just done a vitamin B12 level, we would have got a clue to thinking about Dravet syndrome. So this just shows that many of them, they come with a non-hematological presentation, and there may be bleeding manifestations which are delayed, and a careful examination of a well-stained blood film and myelofibrosis are required. I think I would like to probably skip the rest of my, if I have time, I can show them. Otherwise, okay, I'll just. To look at the granule content, we will have to rely on something which is more than just, simple receptor study. So here we take the help of flow cytometry, and we can do the nepercrine uptake and release assay for dense granule content. What is done is we take the PRP, and to that we add nepercrine. Nepercrine binds to ADP and ATP, which is present in the dense granule. Then we can measure the amount of fluorescence this produces, both in the patient and in the control. After that, we activate the patient's platelets. If the release is good, all the nepercrine will be thrown out, and when we do the analysis, we will get no nepercrine or decreased nepercrine in the platelets. So if the patient, if you look at panel 1, if the patient is showing no nepercrine at the end, neither uptake, then that signals a platelet, the defect in the dense granule content. But if the uptake is there and afterwards it cannot release the content, which is seen in the orange curve in the fourth figure, that indicates that the release was not there. It's still holding on to the nepercrine on flow cytometry. We can also use a number of antibodies, 62P, which will label alpha granules, membranes as they come to the surface, CD63 for dense granule exocytosis, and 107, and can pick up different changes and patterns in various disorders. So there is a whole lot of flow cytometry which can be done to assess the platelet phenotype. But what was very interesting currently, though has been described some time back, is immunofluorescence for the diagnosis of platelet function defects. The monoclonal or polyclonal antibodies can be applied to fix permeabilized blood smears, ordinary blood smears, which all of us can make to detect abnormalities in platelet membrane glycoproteins, their granules, and cytoskeletal proteins. So if you look at the top panel, this is Glanzmann's thrombostemia, because GP2BA in normal patient is shining, a normal person is shining green. In the patient's label 2, it's empty. If there is a decrease in P-selectin, thrombospondin 1 or 1 milligram factor, look at the panel on the left. In the patient, it is decreased, but in the normal, it's good. So this can tell us that it's an alpha storage pool defect. Just immunofluorescence of the blood film. Similarly, for dense granules and for even Wiskott-Aldrich syndrome, same thing can be seen for beta-1 tubulin protein. And we are fortunate enough to hear this directly from Professor Andreas Granacher, who described this technique way back in 2016. So this shows a genetic basis, and I'd like to conclude and thank you for the added time that you permitted me. That platelet functions are a rare cause of bleeding. If we look at the inherited causes, they may be associated with variations in platelet count, size, and non-hematological manifestations. Acquired causes are always more frequent, so we have to exclude them. But inherited causes in our country are now showing up. The good history examination, CBC, blood film examination, and a basic coagulation screen should precede any further testing for platelet function testing. Platelet function tests are expensive, they're susceptible to pre-analytical variables, technically challenging and not easily available, so we use them judiciously. You can use a variety of algorithmic approaches, depending on what you have in your lab. But remember that genetic testing is now here to stay and will be required for resolution of some, or if not most of our patients will be labeled as childhood ITP. I'd like to acknowledge the staff in the lab, which has helped in the diagnosis and in the workthrough of many of these cases. Thank you.
What subject was nice overview from basic to modern, like in the so research now open for any one or two questions.
Common system like
Firstly, Dr. Isna, wonderful talk. And let me tell to all my audience that I had a wonderful comradeship with Dr. Jasmina from the time of our senior residency, and a wonderful friend. And thank you so much for coming to Varanasi. I have just one question. that we are about to buy a platelet aggregometer. So one is that patented one, and another is of Stago with their marketing. So which one we should go in for?
So, for like any other instrument that you would buy, you need to see your budget. You need to see know the platelet aggregometer by each one many centers is a larger. The one by Stago is much smaller. Then you need to know, look at, you need, what do you want to see? Are you going to look at homicide patients? You also, that you cannot go and state because it will not make me and it doesn't let you move on. But if you want to move on homicide patients, as I said, one blood ingredients each can cure, but you can't. The only problem is Stego is widely, there in the that and is largely so so sometimes machines are very sturdy, machines, they come with reagents, don't allow me to they are perfect. So depends on what range you want.
I agree with ma'am. Even we have been using chronolog aggregometer since 2011. Quite sturdy machine. In these 15 years, we never had any breakdown. And even the reagents are very stable because in government setup, we have a problem in procuring the reagents. So here I would like to tell some of the reagents we have used post expiry also, and they have worked very well. There is some problem with the procurement because their reagents are quite costly when compared to the other reagents. However, they are good with a good quality.
The verdict is favoring Chromolog.
Correct. You see your budget gets, and the after sales service, what's that? Because people got chunks from Arab based samples.
Ma'am, can I ask about can we count platelet, microplatelet, large platelet, any new technologies? So, because in dengue, there is a problem with large microplatelet, large platelet or adult platelet. So, we can give result.
I am not aware. If somebody else knows, I will be happy to learn. Yes.
Just looking at the CBC and new treatment ornamentives, so you can tell this क्या size.
So what I would like to emphasize here is when we started looking at mean platelet volume, we realized that whenever we needed it, it was never available from the counters. Because mostly we need to look at mean platelet volume in thrombocytopenia. And if the platelet counts are very low, then there are just dashes there where you see your mean platelet volume. So be very careful. You again have to rely on your eyes and see the film again. And we all know how challenging that is. If there are 10,000 platelet counts, you can keep on scanning the film where you will see very few. And on that, you have to decide whether they are large platelets or they're very small platelets or they're very, densely granulated platelets. So that's a tough call. Best MPVs we get is in our hospital, I think, is when we are crossing 1 lakh platelet count, where I'm really not bothered what the MPV is. So I think Naveen may have something.
Two comments. When the platelets are really down, like ma'am said, you will have a problem with the MPV not generated. But if your counts are, say, 30,000 to 1 lakh, there is thrombocytopenia. MPV may not be generated when you have a significant population of large and giant platelets. Because your histogram at the upper discriminator, the machine gives up. It says, I don't know, this could be RBCs. So it will just cut it off and then give you a platelet count, but does not generate the MPV. So absence of an MPV should actually tell you there are enough and significant large and or giant platelets, both. Second thing is an important thing to consider is look at your platelet histograms carefully. If they rise in their zone, fall down in their own zone, your automated platelet count is likely to match your manual one. But if there is a trail going beyond, not touching the baseline, then expect a manual correction.
Yes, and this is very important when the left side of the curve does not touch the baseline and it continues with the RBC curve.
Yes, yes.
So that histogram suggests that there are enough number of giant platelets which are being counted as RBCs. And
so in fact, people are scared that 40,000 should have corrected to 60. Now, 45 on the instrument correcting manually to 60 means nothing. To me, it's an error of a manual thing because we just want to little bit high. If your histogram is normal, believe that automated cost.
Thank you, ma'am, for the lovely presentation. Ma'am, one question I had. Could you give your insight about platelet transfusion role in cases of inherited and acquired platelet dysfunctions?
So this is not my field of expertise or experience, but the more people I hear of, they are very wary of giving platelet transfusions because of developing of alloantibodies. And I think for minor or small bleeds, maybe antifibrinolytics would do. If there's a clinician in the audience, please come to my rescue. And currently there is and not currently, I think this is known for some time, that recombinant 7A can also be used for Glansmans. And now there is probably a new antibody, a new drug, which is, sort of going to increase the 7A tissue factor axis that can also be used in some platelet function detectors. But if you're saying it truly for thrombocytopenia, you don't treat a platelet count, you treat the bleeding, I think. Because we have our hospital is, they say that we will keep on watching even if it is at 10,000 and the patient is stable. We are not worried that we need, treat the patient, not the cause. Not the cause. That's shitty.
Problem is like minor bleeding manifestation also. Patient become quite, concerned, the family members. So WHO grade 1, grade 2 bleeding, we can just observe, no need to treat. But WHO grade 3, grade 4 bleeding, multiple large petechiae and ecchymosis, all those conditions, or there is frank clinical bleeding, then we have to treat. Gladman patient, mostly they become resistant to platelet transfusion sooner or later because they need a lot of transfusion. And ultimately, we have to take help of recombinant factor 7. In some of the cases, especially, they have very resistant GI bleeds and all, not responding to platelet transfusion.
One case is used to it. Yes, yes.
And that platelet count was 2,73,000, but patient was bleeding. Then ultimately, inventor told me that, and I also read that in these cases, because the platelets are not functioning and they have to be taken at zero and they have to give some support to the patient so that bleeding is stopped. So platelet transfusion is required in these cases.
I know what you're saying and I did count. Yes, yes.
You have to be treated.
Yes. Actually, when I met a couple of people not in India, somewhere outside, they were saying that our trigger for giving platelets is much lower as compared to the West. So I don't know how it is in real practice, but I know that in our hospital, platelets are not given very easily for the simple reason, not that so many platelets are not available for the kind of patients we have. Everybody who had platelet count less than 10,000 and even giving platelets, the blood bank would put its hands up. So I think it's very the same way.
So, thank you so much, ma'am. We'll close the session. And on a lighter note, if you are taking a chronograph aggregometer, be sure that they will not help in sponsoring any of the conferences. Jago will help you. So keep that point also in mind.
Thank you, ma'am, for the amazing talk. Thank you, Chairperson, for sharing this session. Some platelet. From platelet evaluation, we now advance to immunophenotypic precision and leukemia diagnostic. Our next session is approach to flow cytometric immunophenotyping of acute leukemia. I invite the chairpersons for this session, Dr. Savitri Singh, Professor, Department of Pathology, Noida, Dr. Vikas Kailashi, Associate Professor, Department of Pathology, IMS BHU, and Dr. Ritu Chadha, Associate Director, Vedanta Medicity, Gurgaon. Dr. Sema, ma'am, please. Alexa, please. Please introduce the speaker and
It's my proud privilege to introduce Dr. Namrata Avasthi. She's professor, Department of Pathology and HOD Hematology in Ram Manohar Lohia Institute of Medical Sciences. Her area of interest are pathology, hematology, and hematological application of flow cytometry, and she has several achievements to her credit. I request her to kindly deliver her talk.
Good afternoon, everyone. And we also would like to congratulate Vijay sir, the Deepa team for this very outstanding and wonderful event which you have put up and making it part of it. I'm coming between lunch and the end and the valedictory and everything, so even the chairpersons had left. So please bear with me, but I can see some, I think, residents are there. This is a very, very basic lecture on the flow cytometric immunophenotyping. So this is the outline of my talk of 20 minutes. Introduction to flow, the approach to blast amplification, certain caveat from that, and very few focused examples. So flow cytometry is measuring properties of cells as they flow in a fluid suspension across an illuminated light bar. And it has three components: fluidics, optics, and electronics. And this is a very fascinating machine. And this has changed the pathology in acute leukemia diagnosis completely. So a sample, biological sample, is processed. It is labeled with fluorescent markers. The cells move in a linear stream through a focused light source. The fluorescent molecules get activated and emit light that is filtered and directed by the sensitive light detectors. And then there is conversion of analog fluorescent signals to digital signal. So this, what you can see, is a flow cell, which is the heart of a flow cytometer, where you can see that the cells are pushed in a single file through hydrodynamic focusing, and they are intercepted by the laser light here. And then the laser light is scattered in forward direction at 90 degrees, which is the side scatter, and some fluorescent signals are emitted, and all these are collected through a combination of filters and detectors. So you'll come across this term forward scatter and side scatter very often in this. So forward scatter is actually equivalent to the size of the cell. So any cell which is small in size, like a lymphocyte, will have a small forward scatter, and a neutrophil will have a high side scatter. Then, the neutrophil will have a high forward scatter. The side scatter actually detects the nuclear complexity and the granularity of the cytoplasm. So here, look at a lymphocyte with a low forward scatter and side scatter, whereas a neutrophil and an eosinophil will have a high side scatter, and the monocyte will lie somewhere in between. Also, because the cells are tagged with chlorochrome molecules, fluorescent molecules, which can be against the cell membrane, antigens, or the cytoplasm, or in the nucleus, so that will also be picked up. Therefore, the analysis, the characterization is based on the size and granularity and the presence of the antigens or the markers on the surface. Very basic dot plot for RTGs on the forward scatter and side scatter. These are the lymphocytes, these are the granulocytes, and monocyte will lie here. Now, what is gating? It is basically selecting the cells of interest. In a flow analysis nowadays, what we do, this is the first plot, the singlet gating, wherein on the FSC area versus FSC height, we gate out our singlets. The cells which are lying on the right of the forward scatter area, they are the doublets, and we don't want them in our analysis. So we just take our singlets. The other gating, which is uses forward scatter area versus side scatter area, these cells which are blue, which have got a very high side scatter and a very low forward scatter, we are all debris. We don't want them. So we gate them out and we just select our cells here. Now, what software can also do is you can make a region around the lymphocytes, monocytes, and granulocytes and ask the software to give you the percentages. So you get percentages here. This dot plot here, we are selecting our cells based on the expression of CD45 and side scatter. Then we are taking out lymphocytes, monocytes, myeloids, blasts, and the CD45 negative cell population. So basically selecting the cells of interest based on what you are trying to look at. So what is unique in flow cytometry? It is multiparametric and rapid analysis of a large number of cells, which is not possible through microscopy or through RNCs. It gives information on a single cell level and helps in detection of rare cell population, because you can acquire thousands and lakhs and billions of cells. So depending on your experiment, you can detect a rare cell population like in MRD. And it allows physical isolation of cells of interest, that is through cell sorting. Coming to the actual thing, acute leukemias, I will not talk about acute leukemias. We all know it is a neoplastic proliferation of precursor lymphoid and myeloid cells, which are termed as blasts. And our purpose is to look at those blasts and understand what they are. So this is the WHO classification of Hem5. A lot of entities have come here for precursor lymphoid lesions. But by flow, we will only diagnose them as B lymphoblastic lymphoma leukemia, T lymphoblastic leukemia lymphoma, and ETP-ALL. The NK lymphoblastic leukemia is no longer an entity. For the classification of myeloids also, there is this list of defined genetic abnormalities and by differentiation. But by flow, we will mainly give as an AML or an APML, AML with monocytic differentiation, AML with erythroid differentiation, AML with megakaryocytic differentiation, and basophilic leukemia. So you have to understand that flow is just a part of the workup. This is not the complete workup. How do we go about doing this? First, we have to identify the progenitor cell population, then assign a lineage, whether it is a B or a T or a myeloid, and then confirm how it is different from the normal counterpart. This is the basic approach how to go about doing this. So before that, what should a panel comprise of? Essentially a CD45 or an FCA, which assists in identifying the cell population based on the CD45 versus side scatter. Then markers to confirm that these cells are blast. Then markers to assign a lineage. And then markers to confirm whether the given population of blast is different from the normal counterpart. That means you are trying to document the cross-lineage expression or aberrancy or an abnormal maturation. And the panel therefore depends on the type of instrument which you have, 4 colors, 6 colors, 8 colors, 8 colors, 2. And the panel, whatsoever the lab may use, basically has one tube which is an ALOC tube, acute leukemia orientation tube, which gives you an idea of that they are a blast and what is their lineage. And then depending on that, you can take a myeloid tube, a lymphoid, B lymphoid tube, and a T lymphoid tube. These are the common markers which are in use. So for the progenitors, CD34 and TDT, and the other ones are HLA-DR and 38 and 123. Then for myeloid, MPO, CD13, 33, 117, and 15, in which MPO is the lineage specific. Then for monocytic, CD64, 14, 4, 11C, 36, and so on. For megakaryocytes, certain markers like CD41 and 61. For erythroids, 235A and CD71. For B lymphoid, CD19, 10, 20, 22, and CD79A, in which CD19 is the lineage specific. And for T lymphoid, it is either surface or cytoplasmic CD3 along with our T cell marker. So you have to understand that there are some lineage specific markers which will assign a lineage to a blast, and then there are certain lineage associated markers which are also present in that specific category, but may be seen in the other blast classes. So how do we identify blast on flow cytometry? Firstly, based on the CD45 and side scatter. And then if the blasts are not very clearly delineated on the CD45 side scatter, you can also use the CD34 side scatter or other gating strategy based on what kind of a dot plot on CD45 side scatter. And one thing to note is that gating markers are common in all the tubes of an experiment. So if you've got a 3-cell or 3 tube or 2 tube for acute leukemia, then CD45 and 34 will be there in every tube because these are the gating markers. So this dot plot of 645 side scatter, it made our life so easy. When I was a trainee, I was learning flow cytometry. We were doing gating based on the forward scatter and side scatter. So we're just gating out, the small, the lymphoid region cells which were larger in size. But then we knew that we are mixing out, we are mixing CD19 and CD3 positive T cells also. Because then this concept of 45 side scatter wasn't there. This I'm talking about, I think this was 2006 and 7. That. But then when this thing came, 45 versus side scatter, it changed the scenario completely. So here you can see that the lymphocytes, they have always CD45, which is very bright. They are blue in color, and they have a low side scatter. The neutrophils are the green population, which have a medium CD45 and a high side scatter. The orange ones are the eosinophils. Then these pink ones are the monocytes. They have got a higher side scatter than lymphocyte, but lesser than the neutrophils. But CD45 is moderately expressed. And this red population is the myeloid precursors. And the blue ones are the hematologists. The normal myeloid. The red ones are.
I want to tell me to our residents that these colors are artificial and you can label it any color that you want.
Yes.
Please don't be under the impression कि red है तो वो वही होगा नहीं. You can color it anyway.
हमने उसको रेड करा है. हमारे सॉफ्टवेयर को मैंने बोला है कि ब्लास्ट को रेड करो. So it is showing me as red. It can be anything. So this area which is highlighted here is actually the blast hole or the blast region wherein you usually get the blasts. Now you can get some idea of what kind of blasts these are depending on how they look on a CD45 side scatter. For example, here, these blasts, they have got a low side scatter and a quite negative CD45 also, dim to negative CD45. This is usually seen with B lymphomas. With myeloblasts, look here, they've got a moderate CD45 and a higher side scatter as compared to this, the myeloid blast. For promyelocyte, they will have a very high side scatter, this teardrop pattern. They are promyelocytes. And the T blast, usually they have a high CD45, which reaches very close to the normal T cells. So just looking at this also, you get some idea what kind of blast probably you are dealing with, but obviously you will have to go ahead and not stop here. This plot also here, it looks like the blasts are then merging with the myeloid and they are merging with the monocytes. So this was actually myelomonocytic differentiation here. And here the blasts are just maturing into myeloid precursor. There are no monocytes. This was a non-monocytic. These are just hints to prime you at this point itself when you are making a CD45 versus side scatter. And then you should know that there are limitations of flow cytometric illumination of blast. Exact illumination is not possible because one, on bone marrow there is involution. When you are doing a flow, you are collecting more samples than making a smear. Then some nucleated red cell precursors may be lysed during the processing, the whole processing, staining, watching steps. And denominator used in flow cytometry is CD45 positive events, whereas in morphology we count total nucleated cell count. So what percentage of blasts we are getting on a morphology is not equivalent to what you are getting in a flow, but they do correlate. So morphology is the gold standard for blast illumination. You have to look at the peripheral smear anyways because you have to decide your panel also. So based on that, you have to understand how you have to go about. Then there are certain caveats about this blast identification. One, that not all blasts will be sitting in the blast region. The monoblast and promonocytes, they have a higher CD45. This was the blast region actually, but look at this red population. These are monoblast and promonocytes. They have higher CD45 and they have higher side scatter. So they will not always be CD34. They will not always be lying in the blast region. And so you might just miss them if you are not getting them properly. Then atypical promyelocytes. Again, they will have a very high side scatter and they are negative for 34 and HLA. This is one clue that they are promyelocytes. But again, morphology will discriminate well. This kind of a morphology you cannot miss. So if you look at that morphology, and then you look at the flow dot for CD45 side scatter, and you don't get a region in cell in the blast hole, but one cluster as I showed you here, you know that you're dealing with ABM. Then other caveat is that other cells in the blast region can also be there. Basophils and PDPs, and you can get them out based on the other marker of CD1 and HLA. Usually they are not a problem in a presentation case of acute leukemia. And only when you're doing an RD analysis when these populations will become prominent. So you do not worry for a presentation case which has got a good number of blast. The third caveat is that not all blast equivalents are CD34 positive. Like some myeloid blast and progenitors may be 34 negative, and therefore you have to use other markers to identify the blast, like CD117 for myeloids, CD3 for lymphoids, and monoblast and atypical promyelocytes are CD34 negative. That one needs to remember. The fourth is that blast may show aberrant expression of non-lineage antigens. And there are some commonly expressed aberrant antigens. For BLL, they are the myeloid markers like 13, 33, and T markers like 2, 5, and 7. For AMLs, you can have all kinds of lymphoid markers, both T and B. For TLS, it is 13, 33, 117 are aberrant. These aberrancies helping identify neoplastic flow. So once you get these kind of aberrancies, you know that this is not a normal cell. This is not a native hematopoietic cell. But this might lead to an erroneous diagnosis of mixed phenotype acute leukemia. It also helps because these work as leukemia-associated immunophenotype or LAIP, which are important for an MRD analysis. And some of the immunophenotypes are also associated with certain defined genetic types. The blast abnormalities also fall into 4 main categories. So there could be abnormal antigen, abnormal intensity of the antigen expression. Look at this. This is the normal marrow. The progenitors are gaining 33 and HLA-DR to this level. Here, this is a blast. 33 is absent in this blast, and then got a very bright homogeneous HLA-DR. So this is abnormal intensity of the antigen expression. The second is asynchronous expression of the antigens, that is immature with mature. This is a normal. Here, see the blasts are 34 positive, 15 negative, then they are maturing towards 55. They're gaining 50 and losing 34. But here there is asynchronous expression, 34 positive cells with CD15. So this is the second kind of abnormality in the blast. Then the third thing is that there could be homogeneous expression of antigen which are usually expressed as varying level. See here, the blasts are having heterogeneous CD13, right from lower to higher, whereas here they are very homogeneous and bright cluster. The fourth abnormality would be expression of antigens of other lineage. Like here, the myeloid blast are supposed to be 34 positive and 5 negative. Here, these blasts are expressing 5 as well. So this is the expression of antigen of other lineage. So that means you need to know the normal maturation patterns to identify the aberrancy. Otherwise, you'll be just saw that what are these cells which we are looking at. So these are beautiful blasts which are given in Henry's, given by Dr. Brentford and their team. B cell maturation, T cell maturation, granulocytic maturations, and monocytic maturations. We'll not deal with them because of the time constraints. So now you've done flow cytometry. Now you've got your data. How do you look at your data? Whatever plots you are getting. So one is quadrant based. Quadrant based is a simpler method. It utilizes the unstained tube, base negative and positive. So you first tube is unstained, you don't put any marker, just run it on flow cytometer and set your quadrants that the cells are not expressing any fluorescent marker because you've not put anything. And then you stain your tubes, and based on the quadrant and the percentage expression, you say which is positive, which is negative. So this is widely used for ease of implementation, but it is not preferred in today's era. Today, what we prefer is a maturation pattern based approach, wherein we need to have internal positive and internal negative controls. This is the idea here, but this needs in-depth understanding and elaborate analysis with. For example, here you see that the blast I have painted as red and the limbs as green and neutrophils as blue. So in this plot, you can see that the blast are 34, 1 and 7 and the internal control to the lymphocytes which are negative for both. Similarly here, for the MP are taken positive control as neutrophils and lymphocytes as the negative control for CD3 and lymphocytes for positive control of CD79A. This is B cell marker. And here, these lymphocytes are negative for both lympho and CD79A. That means these are T cells. So basically, using internal positive and negative controls for your impression. Just taking you along few cases, so you can stop me whenever you think that the time is over. I will not go through the histories. Acute leukemia cases have a very similar history. Just that 4-year-old child, high TLC and differential showed 90% blast. And these blasts are very lymphoid looking blasts, very scant cytoplasm, agranular. So looking at the dot plots, similarly, what I showed you, the first 3 dot plots regarding the singlets and the cell, and then going to the actual blast. The blast are 19 and 34 positive, negative or MPO and 3, and 1910 very brightly positive. And this kind of a bright expression of 1910, if you get, this is a BLL for sure. But you have to rule out that the other T markers and other myeloid markers are not there. So just complete your panel, CD3 negative, CD7 negative, 33 and 13 negative. HLA-DR here is like a marker of immaturity, again confirming that these are blast. And 64 and 33 is negative. One marker here, CD66C, is actually a myeloid marker, but this is being expressed here in a BLL. So this case was reported as a precursor BLL with aberrant expression of CD66. And this 66C can be used as a leukemia-associated immunophenotype, LAIP. And this has been shown to be associated with Philadelphia positive levels at 12. So you can just suggest that please look for these as well. Similar case, this is a 43-year-old female, adult VLL, and known pH positive. And this case had an aberrant expression of CD33. So just highlighting that sometimes some markers can help you point out towards some kind of genetic abnormality as well. And then you can suggest that please do this for sure if you're not able to do all the time. Second case, 14-year-old male, high TLC, blast 40%, similar kind of blast as we just looked previously, similar kind of gates. Now just keep looking at the immunophenotype. The blasts are 10 and 19 negative, 34 and MPO negative, and they are cytoplasmic CD3 positive, 79A is negative. These are the normal B cells or normal T cells. CD7, look at the CD7 here. CD7 is more positively expressed as compared to the normal T cells. It is brighter for CD7 as compared to the normal T cells. This is a point to be noted. Surface CD3 is again dim. Look at this. Surface CD3 on the y-axis. This is dimly expressed. CD5 is also expressed. CD7 is expressed. 4 and 8 is negative. And this was a case of T lymphoblastic leukemia. Another case, similar, but just look at the immunophenotype. 34 is brightly positive. Cyto CD3 is dim. Here, green are the normal T cells. CD1 is negative. CD8 is negative. And 33 is expressed. So this is a typical immunophenotype of a anybody? ETP-ALL. So this is an ETP-ALL. We need to identify them because they have got a poorer prognosis compared to the conventional TLS. And ETP-ALLs have certain diagnostic criteria. You have to document that they are CD3 positive and CD7 obviously will be positive because they are a TLS. But they must show features of early thymocyte precursors, and early thymocyte precursors are negative for 1A and they are negative for 8, and CD5 should be dim or negative or maybe expressed in less than 75% of the population. Plus, these ETP-ALLs must not show evidence of definite myeloid differentiation. That means they should be MPO negative and no evidence of monocytic differentiation. And they should express at least one stem cell or myeloid-associated antigen in more than 25% cell. So here the plot show that they could be 117 positive or HLA-DR positive or 13 positive, and 34 here is taken as a myeloid-associated antigen. So this is about ETP-ALL. Next case, 65 female, high TLC, blast 90%. Now the blast morphology has changed. You can see all dots. We are very clearly myeloid blast. Just focus at the scatter. The scatter has changed here. And the MPO is positive. Myeloid markers are positive. 117, 13, 33, HLA-DR, all these. Here 19 aberrancy is noted. Okay. And 38 is again marker for blast. Now this was AML with aberrant expression of CD90, and it is known that AML with RUNX1, T1 can show B cell markers associated with the very phenotype. Another case, just coming to the last few cases. This is again 40-year-old female, TLC 45, TLC showing 70% blast. Look at the morphology of the blast. Now they have got more cytoplasm, some indentations and foldings, some monocyte-like cell here. We are towards kind of a morphology along with the myeloid morphology. Look at the 45 site scatter, dense tight cluster sitting on the top of lymphocytes here. They are MPO positive, 34 is negative here, 10, 19 negative, 79A and 7 is very dimly expressed but absent for B cell markers. And now you look at the very bright 33 expression homogeneous with 13 emergence. And HLA-DR is positive. Look at this plot, it's very important. 64 and 40. So these blasts are brightly positive for 64 and some of them are acquiring CD14 and some of them are maturing. This is a marker for monocytes. Maturing. So this was an AML with monocytic differentiation. And this is a very beautiful paper on the monocyte lineage leukemia by flow cytometry. You all can go through these. And this is the same picture which I just showed you. The red ones are the immature precursors and the orange ones are the mature ones. This is how they mature. I think this is the last case, 28-year male, TLC of 21,000, 90% blast. Now blast here have got granules, they've got foldings, some monocytes, and some mineral-like morphology as well. So probably two kinds of blast you all can make out. Look at the scattergram and the markers. All the myeloid markers are positive here, 34 and 117, MPO, 64 and 14 again maturing monocytes. Here also 13 and 33 expression. Now look at this. Cyto CD3 is also expressed and with normal T cells here. So cyto CD3 expressed and surface CD3 is not present. CD7 again very nicely expressed and 4 and 8 are negative. So this is a mixed phenotype acute leukemia T myeloid. This is a classification given in the team 5, acute leukemia of ambiguous lineage. You can go through it and read about it. And there are certain immunophenotypic criteria to assign a lineage in MPAL, and you will have to read them properly, and it's not the time to. I don't have the time to explain that here. Now, this is again a paper by Barbara Bain giving a morphological immunophenotypic close to the WHO catechism of acute myeloid leukemia. You can go through it. So it will help you understand what kind of a diagnostic morphology might be associated with what kind of a immunophenotype. To summarize, flow cytometry is an indispensable tool for acute leukemia diagnosis, and it requires training at multiple levels, including morphology, instrument, the fluorochromes, markers, and their maturation patterns. Blast enumeration can be misleading by flow cytometry, especially on the bone marrow. Therefore, morphology is the gold standard for blast enumeration. Flow cytometry is only a part of workup, remember that, and a complete diagnosis requires integration of the clinical, morphological, immunophenotypic, molecular, and cytogenetic issues. Thank you very much. I'm Eugene from RNM Institute. So, this is which guided work. Again, and I'm unable to. Anyway, very nice. Thank you very much. It was very well elaborated. Ma'am, what are the MRD markers that you put in your tubes? CD30, you should come and discuss it separately. Yes. So I have 4 LAIPs. If there are no more questions, there are 4 LAIPs. We can discuss it.
Thank you very much. With this, we conclude the session. Over to you.
Thanks, ma'am. That's an informative and essential focused talk. So now we arrive at one of the most awaited moments of the day, the prize distribution ceremony. To felicitate the winner of oral paper presentation, I would like to invite on stage Dr. Neeraj Dhameja, Dr. Naveen Kakkar, and Dr. Jasmina Alwania, ma'am. So in the oral paper category, the 3rd prize winner is Dr. Yashashvi Kashyap from IIIrd. Dr. Yashashvi Kashyap. Can someone collect on his behalf, please? It's Department of Pediatrics. For our 2nd prize in oral paper presentation, Dr. Rashmi Malhotra, AIIMS Rishikesh. The topic was spectrum of chromosomal abnormalities in abortus and medically terminated fetal samples from the sub-Himalayan population. And for the 1st prize, we have Dr. Swati Ghosh from Department of Pediatrics, IIIrd. Her topic was next generation sequencing as a diagnostic tool in complex pediatric anemias, a single center anemia. Thank you, sir. Thank you, ma'am. Now to felicitate our poster winners, I would like to invite on stage Dr. Rashmi Kushwaha, Dr. Namrata Awasthi, and Dr. S.P. Verma. So third place for poster presentation, we have a tie. The two people who have won the third prize are Dr. Manisha Kumari, Department of Pathology, IMS BHU, and Dr. Priya Saha, again IMS BHU, from the Department of Pediatrics. In second place, for poster presentation, we have Dr. Akshay Medanti from KGMU Lucknow. And in first place, we have Dr. Priyanshi Chaudhary from RML Lucknow. Thank you, sir. Thank you, ma'am. Once again, congratulations to all the winners. Now, as we approach the conclusion of this enriching event, I would like to invite Dr. Deepa Rani ma'am to deliver the valedictory address.
A very good afternoon, everyone. Respected dignitaries, esteemed guests, dear colleagues, and my dear students, I would like to thank you from the bottom of my heart for the successfully completion of this UPHGCon 2026. Many people are behind the scene who will get recognition today because without their help, it would be not possible for the committee to organize such a big state level conference. And I request you all to please give a big round of applause for all the committee members and all the First of all, I would like to I am very grateful for the blessings of our esteemed teachers, Professor Mohan Kumar and Professor Usha ma'am. Without their support and their encouragement, it would be not possible for me to stand here at this place and organizing this type of state level conference. Next, I would like to thank all the patrons, Professor B. Dubey sir, Professor V.P. Singh sir, Padma Shri, Professor Sonia Nityanand ma'am, Professor A.K. Tripathi sir, and Professor S.N. Shankhawar, Director IMS PHU, for helping us a lot. I also want to thank the institutional heads, Professor Ajit Kumar Chaturvedi, Vice Chancellor BHU, Professor S.N. Shankhawar, Director IMS BHU, Professor Manoj Pandey, Dean Research, IMS BHU, Professor Sanjay Gupta, Dean Academic, IMS BHU, Professor Neeraj Sameja, Professor and Head, Department of Pathology. It's because of their blessings and help it would be possible for us to conclude this big event. Thank you so much to all of you. Special thanks to Professor D.K. Gautam sir. He has helped me a lot in all the logistics and all the planning of this conference behind the scene. Sir is presently not here, but he has helped us a lot. Now, I would like to thank all the esteemed speakers of this conference, the UPHG members, Professor S.P. Verma sir, Secretary UPHG, Professor Rashmi Kushwaha ma'am, and Professor Namrata Avasti ma'am. Now I would like to request Professor Vijay Tilak sir to please come on the stage and felicitate them with a memento and a certificate. I would like to invite Professor S.P. Verma sir. Actually, they are the pillars of the successful event. Mr. Ma'am, please come on the stage. Namrata ma'am.
That's what I think the people have been working hard for past 1 year, and the conference is successful because of their efforts and their teamwork.
I would also like to thank
Please take that also.
It's my pleasure. Sir, please stay here because we have more members on this day. I would also like to thank all the advisory committee members of this UPHG group, Professor Sunil, Dr. Anshul Gupta, Dr. Ruchi Gupta, Dr. Khalikur Rahman, Dr. Sanjay Mishra, Dr. Dinesh, Dr. Priyanka Verma, and Dr. Rinita Radhakrishnan. I would like to thank all the KHG members, Professor Vijay Tilak sir, Dr. Ankur, Dr. Akhtar Ali sir, Professor VP Singh sir, Dr. Mahima Yadav, Dr. Sandeep Nautiyal, Dr. Ifa Jamal, and Dr. Anuj. Now I would like to thank our organizing chairman, Professor Vijay Tilak sir. And because it's a dream of Professor Vijay Tilak sir, the UPHGCon, he always wanted to do this state level conference, and it's a dream come true for sir. And I'm very happy that sir has sir thought of this. Okay, we will organize this a state level conference, and sir has successfully organized this conference. So all the credit goes to you, sir. Big round of applause. Now, I would also like to thank our NAMS coordinator, Professor T.P. Chaturvedi sir. He has helped us a lot for getting this NAMS fund and all the proceedings of getting this fund. It's a very tedious process, but sir has helped us a lot. Now, I would like to thank our joint organizing secretary, Dr. Priyanka Agrawal. Priyanka, please come on the stage and take your this memento as a token of respect. I'm sincerely thankful to our scientific secretaries, Dr. Neha Singh and Dr. Neeraj Singh, for their meticulous planning and academic coordination. Their clarity of thought and commitment to scientific excellence ensured the smooth conduct of this conference. Dr. Neha Singh, please come on the stage. She is the lady behind the scenes. She is not just a scientific secretary. I must say she is the organizing. She, Pratishtha, and Mahima Yadav is the organizing secretary of this conference. I give all the credit to her. Now, our scientific committee member, Dr. Atre, she is my student, and right now she is my right hand, left hand, everything. And she has done a lot for this conference, and she is with me like a shadow. And it's because of her efforts and her sincerity. रात के 12 बजे भी अगर अत्री को मैसेज कर दो, okay ma'am, I am typing, I am doing all the work. And वो दीदी, ma'am, please read. Okay, I will read in the morning. Thank you so much. I am very grateful that you are my student. Now, I would like to thank Dr. Tanima and Dr. Sujata They are our ex-students, but they are still living in IMS PHU, and they are doing all the work. So whatever we tell them, Tanima, you have to do this. Okay, ma'am, I will do. Okay, ma'am, I will do. और negative तो कभी बोलते ही नहीं है. So thank you so much, Tanima. So that is not here. Now, I would like to thank the treasurer, Dr. Akhtar sir and Dr. Pratishtha. Pratishtha, you are here. Please come on the stage. Pratishtha has done actually not the treasurer part. She has done all the oral presentation, the poster presentation. Everything was systematic just because of her. She has done a very good job. Doing a lot, talking less. Now, the man behind the scene, Dr. Anuj Pandey. Anuj, where are you? Oh, still he is managing. Anuj has managed. You have system behind the scene, but the credit goes to Anuj for systematically. He has managed everything. The transport, anybody, car, just call Anuj. Anuj is ready. Okay, sir. Okay, sir. Just coming in 5 minutes. And I'm giving you the card. You can go. Anuj, I can't. Words are not there for Anuj. Food and catering, again, Dr. Pratishtha, thank you so much. And with Mr. Sunil Upadhyay, she has managed everything. For the inaugural ceremony, I would like to thank Dr. Mahima Yadav. Very nicely yesterday, I think आप सब लोग देखा होगा कि कितने नॉर्मल तरीके से कितने अच्छे तरीके से डॉक्टर महिमा ने इनॉग्रल कंडक्ट करवाया था. तो थैंक यू सो मच डॉक्टर महिमा. महिमा इज नॉट हियर, आई थिंक, बट ग्रेट राउंड ऑफ अप्लॉज फॉर मी. Our newsletter committee, yesterday we released our newsletter. The ISHBT Hematological Indica is just because of effort of Dr. Ifat. Ifat is professor in IGIMS Patna and Dr. Anuj Pandey. I would like to thank our workshop coordinator, Professor Roina Singh ma'am and Dr. Akhtar Ali sir. Roina Singh ma'am has conducted 2 workshops, the NGS and karyotyping workshop, and Dr. Akhtar Ali sir has conducted FISH workshop in CGT of this institute. Now the oral paper and poster presentation committee, all have done a very good job. Professor Kiran Giri, Professor and Head Department of Pharmacology, Professor Kamlesh Palandukar, Professor and Head Department of Biochemistry, Professor S.P. Mishra sir, Dr. Bitan Nayak, Dr. Mahima, Dr. Vikas Kalashia, Dr. Ila Singh. Ila Singh is from HIMS Varanasi, Dr. Pratishtha, Dr. Neha, Dr. Rahul Jaiswal, and Dr. Garima Dwivedi. A big round of applause. Now, I would like to thank all our conference partners, Roche, Novo Nordisk, Lalpad, Minetoplax, Sabia, Transasia, and Mr. Abhijit Soni for all the beautiful shawl and sari. The printing and event partner, Mr. Sanjay and Mr. Santosh Trivedi, and Mr. Nazumuddin for this event management. Mementos partner is Mr. Ajay Saxena, and all our volunteers. I would like to thank all our volunteers, especially the volunteers from the Center for Genetic Disorder. They did the commendable job as a volunteer, and they were with me from 7 o'clock till 10 o'clock in the night, and they have done all the works very nicely. So thank you all of them. Big round of applause. Now, special thanks to our telemedicine department. Please give your big hand. Flawless. And all the Safai Karmkari, the electricians and technicians, it's just because of their efforts, we didn't get any interruption in this program, and they are actually responsible for the smooth functioning of this conference, 2-day conference. So thank you, all of you. Now, last but not the least, the family members of the organizing committee, the wings beneath our wings, for their never-ending support. They have suffered a lot. They have supported actually 2 marathons. They are our strength. And actually, our family members have just without their support, we cannot organize this type of state level conference because we are working day and night for the successful completion of this conference, and they are suffering at our home. So they really need a very big round of. And finally, in Kashi Nagari, Lord Shiva has done everything. This conference is just because of him, because many a times I felt I cannot do this, but he was with me throughout this taxing journey. So I would like to say, Namah Parvati Pate Mahadev. So thank you everyone. Thank you for this event. And please, and last but not the least, I would like to introduce you my friend Survi. She came here for me, and in a very short notice, she came and she gave me a big moral support. So thank you so much, Survi.
मैं आप लोगों से कुछ शेयर करना चाहता हूँ. We had to organize the UPHGCon last year. I was the organizing chairman, and I failed to organize it. I owe that failure. And I'm really grateful to the core committee of UPHG, Professor Sonia Nityanan, Professor Tripathi, Dr. Rashmi, Dr. Namrata, Dr. Verma, जिन्होंने एक आदमी जिसने फेल हो गया था करने में उसको दूसरा चांस दिया. And for me, it was a do or die situation. My father had once told कि कॉलर फटा हो चलेगा, लेकिन गर्दन झुकी हुई नहीं होनी चाहिए. तो बेटा ऐसा कोई काम ना करना जिससे तुम्हारी और मेरी गर्दन झुके. और शायद मेरे लिए भी वही था कि प्रेसिडेंट में आजीवन तो रह नहीं सकता था. इट वाज नॉट पॉसिबल. लेकिन जब मेरी प्रेसिडेंटशिप खत्म हो तो सिर उठा के मैं एग्जिट करूं, ये मेरी काम थी. एंड देन वी डिसाइडेड कि हम लोग को करनी है. दीपा एंड आई 2 persons वर देयर, और सब कुछ हमारे अगेंस्ट था. ना हमारे पास पैसा था, ना मैन पावर थी, ना कोई एडिशनल सपोर्ट था. एंड challenges and challenges and challenges. हाँ, तो हमारा अपना कॉन्फिडेंस, हमारा एक्सपीरियंस जो 25 हम लोगों ने कॉन्फ्रेंसेस करी थी, लेकिन we knew, in fact I knew it from the very beginning कि ये बहुत बड़ी कॉन्फ्रेंस होने वाली है. 3 parallel workshops, 3 halls में ओरल प्रेजेंटेशन, पोस्टर प्रेजेंटेशन, 1.5 दिन की पूरी मीट, इतने सारे फैकल्टी मेंबर्स. So the work was overwhelming, and Deepa was organizing secretary, and I found हम दोनों लोग जान लड़ा दिए इसके अंदर. मैं शायद भूल गया कि घर क्या होता है. सुबेरे से आता था, रात के 10 बजे जाता था. मतलब वो जब मैं जाता था उस वक्त वो पॉइंट था कि अब अगर मैं नहीं गया तो शायद मैं कार ड्राइव करके घर नहीं जा पाऊंगा. एंड द सेम विद दीपा. And I give her all the credit क्योंकि मेरे साथ एक बहुत बड़ा एडवांटेज था. My son is now well settled. He is doing his DM in therapeutic nuclear medicine. तो मुझे जाके बच्चे को नहीं देखना. And my wife was very, very supportive of me. But that was not true for Deepa. She had 2 small children to look after. और उन सब के बीच में उस लेडी ने जिस करेज के साथ, जिस मेहनत के साथ, जिस रेजिलियंस के साथ काम किया है, काबिले तारीफ. इनफैक्ट मैं कहूंगा द क्रेडिट फॉर द सक्सेसफुल कॉन्फ्रेंस जो बिगेस्ट थी, इतनी जबरदस्त हुई, ऑल द क्रेडिट इफ आई हैव टू गिव टू वन पर्सन, दैट इज डॉक्टर दीप.
Thank you so much, sir. Thank you, sir, for giving me all the credits. But there are a lot of people who helped me a lot. बिकॉज वो लोगों ने आउट ऑफ द वे जाके मेरी मदद की है. इनफैक्ट एक लोग को मैंने लिखा कि थैंक यू सो मच फॉर हेल्पिंग मी. तो उसने मुझे लिखा कि मैम आपको मैंने इसलिए हेल्प की है जब आपने हेल्प मांगी भी नहीं थी. तो उसके लिए तो मैं बहुत जोरदार तालियां चाहती हूँ. और मेरे पास अभी दीपक गौतम सर आ गए हैं, तो सर प्लीज स्टेज पर आइए और प्लीज अपना एक टोकन ऑफ रिस्पेक्ट हम लोगों से। थैंक यू सर, आपने आईआईटी गेस्ट हाउस हमारा बिल्कुल एंड मोमेंट पे एलडी पूरा कैंसिल हुआ था और आपने इतनी हेल्प करी और फिर बहुत अच्छे से आईआईटी गेस्ट हाउस बुक हो गया था। बट बहुत एडमिनिस्ट्रेटिव प्रॉब्लम्स हैं।
एक चीज मैं कहना चाहता हूँ कि इंजीनियरिंग का डायरेक्टर की जब आप कुछ अच्छा काम करते हैं वो सारी हाँ, और ये हम लोगों ने एक्सपीरियंस किया एक एक कष्ट जो हमारे चैलेंजेस थे and how it happened we carried don't know but some cosmic thing which was testing us and then giving us value.
Vikas, please come on the stage. Vikas has conducted all the oral sessions, postal sessions. Thank you so much, Vikas. I would like to invite SP Mishra sir on the stage. नहीं सर, आपका बहुत मोरल सपोर्ट रहा हमें।
पंजाब में ट्रेनिंग ये डेवलप आइटम है मिश्रा के दो पर्सनल एक तो एसपी मिश्रा और दूसरा प्रोफेसर इंचार्ज से ये मुझसे मिलने आते मैंने किस कैपेसिटी में डॉक्टर मिश्रा लड़का फॉर अ कप ऑफ टी प्रोफेसर इंचार्ज
Now Anuj is here. Anuj, please come on the stage. He is the person behind all the transfer. Hospitality.
जैसे saying कि अगर कभी नहीं होता तो हम लोग ये कॉन्फ्रेंस नहीं ये बिल्कुल इसमें बता दिया ये ऐसा करते हैं ये तो है ना बात
Thank you, everyone. Thank you, everyone, for coming. I hope you have enjoyed all the academic deliberations. Now, I would like to request you all to kindly proceed for lunch.
Let's go for the back. No, for the back.
Sir.
टीवी भी चलेगा
टीवी हटाने फोटो वाले चले já modo de repetir da família. Isso é, tem uma vez de bom.
See, forget all of you like you know.
Then,